Tell you a brief about Dr. Bhushan Kathuria. He is Masters of Surgery in Otorhinolaryngology and from Haryana. And currently, sir is there as consultant head and Department of ENT, head neck oncosurgery at We Care Hospital, Rohtak. And his special interest in head and neck cancer surgeries, lateral and endoscopic anterior skull base surgeries. And today it's a honor that we have Dr. Bhushan Kathuria with us. So, sir, this is a platform where all the legendary ENT surgeons from across West Bengal will be with us today. And this is high regards from my side for being here with us, taking our invitation forward. And I would like to request that when the surgeries will be starting, so please be there with us, and your all sessions will be as moderator. So before starting, I would like to request you if you please come forward on the dais and please tell something to your fellow colleagues of West Bengal, your experience of West Bengal, please.
First of all, congratulations to Dr. Ghosh and his team to organizing as a beautiful conference and a teaching session. So I would like to say thanks to Dr. Ghosh and Cipla team for acknowledging us and inviting us for a faculty to share a session with the stalwarts and the master of the field, like Dr. Deepak Haldipur, Dr. Ghosh itself, Dr. Chaudhary. So it would be a great pleasure for me to share a session with them and to discuss the topics and learning from their experience. So thank you very much. We'll be in touch. We'll discuss the topics. Thank you.
Hello? Hello? Hello, auditorium? Hello, auditorium?
Hello.
Hello?
Sir, good morning.
Hello, auditorium?
Yes, audible, sir.
Hello?
Hello.
Yes.
Sir, are you
I
audible?
Am I audible?
Yes, sir, you are audible and the screen is visible.
Okay. All are visible. Like cameraman kothay? Cameraman ke rakho. Just 1 minute. Now this case is the tympanoplasty, central perforation. Okay, and Dr. Deepak, legend Deepak Haldipur will do the surgery. The first case. Now, case Dr. Arvind Gupta will demonstrate.
Good morning, delegates. I welcome you all on behalf of the GHOSH ENT Foundation and Dr. Tushar Kanti Ghosh, Director GHOSH ENT Foundation. We are going to start our first case, which is the tympanoplasty, right side. The patient is 38-year-old female, Anjali Nashkar. She has complained of ear discharge, right side, and hearing loss for the last 6 months. There were no any other comorbidities. On examination, we found there is a moderate central perforation with tympanosclerotic patch. The ear is absolutely dry. On audiometry, the pure tone audiogram is on the right side. It's a moderate conductive hearing loss, around 40 decibel hearing loss. On the left side ear is normal with high frequency SNHL, which is normal in this age group. Now we are going to hand over to Dr. Tushar Kanti Ghosh. This case will be operated by the Dr. Deepak Haldipur, who is a renowned ENT surgeon of Bangalore. Over to Dr. Tushar Kanti Ghosh.
7.5.
Hello?
Yeah.
Now this case will be demonstrated by Dr. Deepak Haldipur. Okay.
7.5 hai?
Within of
7.5, yeah.
1 or 2 minutes, it will be started. Graft already taken up. The first case, slight bit of weird delay, but my commitment from next case, definitely no delay will be there. Because we have 4 OT and all patients will be ready. Just before just finishing another OT will be live demonstrated from another OT. So it is the first case. After that, no delay will be there.
Lampert speculum.
Now mic will be hand over with the Dr. Dipur. He will
Yes.
demonstrate.
Good morning,
Lampert
sir.
speculum, please.
Good morning, sir.
No, not that. Lamperts.
Audience, slide.
That
view
I use
up.
for
Keep on talking.
laser.
And if any problem, please tell us. Okay. From auditorium, Dr. Bhushan.
Canal is injected.
Good morning,
huh?
good morning, sir.
Good
Are you
morning.
audible?
Yes.
Dr. Deepak Aldipur, good morning. And welcome to the session.
একটু বাড়া থাকবে সাউন্ডটা বাড়া থাকবে প্লিজ স্লাইড
Post-op injection given
sound
now.
slightly less.
Yeah. Okay. Graft you have taken higher up. Okay. Yeah.
Hello.
Okay. Give me the 15 knife. Huh?
From OT the
Hello?
sound is audible.
Hello.
Yes, sir, it is audible.
Can you people
দাদা ওটি সাউন্ডটা একটু
see
বাড়াও
this? Hello.
Hello. Sir,
Yeah.
are you audible?
Can you
sir?
appreciate the?
Actually, sir,
You are getting the picture?
no endoscopic picture we are not getting.
Are you getting the picture? Wait.
Endoscopic
Volume
picture.
थोड़ा उधर का वॉल्यूम मुझे नहीं सुनाई दे रहा है. Are you getting the picture now?
Yes, sir, we are getting the picture, but endoscopic picture we are not getting.
Microscopic picture they are not
No,
getting.
No. We are just
Knife?
getting the picture of 40.
Yeah.
Yeah, now it is clear, sir.
Now you are getting the
Yes.
ear picture.
Yes, sir. It is clear.
See, I will be putting an incision here.
So,
Yeah. Circular knife, please. Or knife. Yeah. See, this is the annulus here. So I will be putting an incision parallel to the annulus, maybe about 3 millimeters away from the annulus, like this. Give me the 15 knife, please. Hold this. 15 knife. Yeah. Keep the circular knife ready.
so you are giving the superior cut, sir.
Yes. Now, elevating this corner of the coroner's flap. Yes. Now, suction, please. You are getting the picture?
Yes, we are getting, sir. It's clear.
$15 knife. That was my 11 o'clock incision, and this is the 6 o'clock incision. Hello?
Yes, sir, yes.
Can you hear me?
Yes, sir. You are audible.
Knife?
We are getting.
Slowly, something kuch gir gaya na. We keep one more 15, knife ready because we have to go. I am elevating the lower portion of the corner's flap now. Circular knife, please. So this corner's flap becomes the main vascular flap for my technique of tympanoplasty. 90% of what steps I do, something I learned from my teacher, the legendary Dr. Mahadevaya, and till date I practice majority of the steps as he had taught me. Now I'll go posturally. Top light, please. "15 knife," yes. Now I'm going posturally, if you can see.
Sir, picture is not clear.
Okay,
Will
the
not-
picture is not clear. Audio visual, कुछ करो भाई.
Yeah, it's fine now, sir.
Gauss piece. Yes, AdSense. AdSense, please. Add forceps, ads and forceps. Cautery. Touch. Touch. No, I don't want suction. Do the cautery. Touch. 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 Okay.
Cameraman, can you please focus?
Touch. Okay.
Hello?
Now, touch. Yes. Touch. Give me one gauze. Okay. Gauze piece. Gauze piece, yes.
Hello?
Cautery again.
Sir,
Cautery, yeah.
sir, in the picture we can see there are two incision. One is post-oral for direct approach to tympanoplasty. One separate incision is already given for the flap. Hello?
Okay. Give me.
Hello?
Yes.
Sir, we just want to ask one thing that we can see two incisions in the picture. One is separate for the flap and one is like post-oral incision for procedure. So,
Yes.
is that one incision is okay or is there any advantage of doing this thing?
One incision means you mean endorally itself?
No, like one, like in the post-oral, this one incision is already given and one already made by for taking the flap. So is that okay to take a one incision and take a
Technique actually,
yes
what I do in Bangalore,
yes
a single incision.
mm-hmm.
There are two ways of doing it. Some people take a separate incision to harvest the grass.
Yes.
It all depends on your comfort, but I would say one incision
One
is
incision
more
is
than
okay.
enough.
Yes. Most
In
of
my
the-
place where I do,
Mm.
AdSense please. Yeah, touch. That's it. Touch. SMR elevator. So what you said is right. I would prefer only one incision. Suction. Yeah, keep the cautery ready. I want a cotton ball put in 4% xylocaine. 15 knife. No, wait. There's still some oozing which I'm missing. Give me the Adson. One artery which is bleeding now. Yeah. I need to catch properly. Touch. Should be okay now. Yeah. 15 knife. Yes. Give me the elevator. Now maybe you can give me a piece of ribbon gauze or Birkin's cheek retractor or whatever. Cautery then, give me the cautery. Yes. So basically the 12 o'clock incision and the 6 o'clock. The most important is, use the cautery to give some good release incisions so that when you retract, you don't apply a lot of pressure. Surgery is all about tissue handling, and the less you retract, is the healing, Suction to be, yeah. Yes. So now you give me the ribbon gauze, small piece.
So you have another mic if any doctors have any questions. So our respected moderator is also present here, Dr. Bhushan Kathuria, and we can directly coordinate with the OT.
I'm using a ribbon gauze now to retract. Give me the retractor, please. Master retractor or any retractor, really. Yes, 3-prong is okay. No issues. Leave it as it is now. We have a good amount of retraction.
Cameraman, can you focus from the different angle?
Saline, please. Saline.
Hello.
Yeah, please, 1 minute. Yes, hello.
Sir, actually, can we ask cameraman to focus at the different angle? It's not.
Yes. We are changing to the microscopic
Okay.
picture.
Then it is okay. Fine, sir.
Just give us a minute.
Yeah.
Now keep the sickle knife ready, okay? Give me the cautery first. Yes. Now, are you getting the microscopic picture?
Yes, sir. We are getting the clear picture.
Action. I want a cotton with 4% cocaine or something like that, please. Myself. Yes. Salam, please. Can we go one step higher magnification? Yeah. Yes. I think you're getting the
Sir,
picture.
Yes, we are
Saline?
getting the picture. The medium size perforation,
Yes.
and posteriorly there is a tympanosclerotic patch is there.
But that's a very small patch,
Yes.
not involving the ossicular chain.
So
And it's not even a well-developed, well-matured patch.
yes.
Saline?
You're going to
Yeah.
remove it, or you just want to leave it like that only?
Maybe worth removing. It's not fully developed also,
Right,
actually.
Right.
It's not that full thickness typical patch that you see.
In future, is there any chance if we leave that patch, so it can grow later on and it cause a like
If you
mild to moderate-
traumatize it, yes.
Yes.
If you create a bleed, yes. No, otherwise no. Cautery, please.
So like in this case, if we want to leave the TS patch, we don't
Yes.
think about the interlay approach.
No. Actually, interlay is done by my one of my favorite teachers, that is Satish Jain.
Right, sir.
I do the classical underlay,
Mm-hmm.
and whenever I find granular meningitis,
Mm-hmm.
which is not there in this case,
Right.
I do the total annulus excision tympanoplasty.
Okay.
Cotton, please, with 4% xylocaine adrenaline. Yeah, adrenaline is there, no? Yeah, because local patient can have pain. So I'm introducing a cotton here. This has like. Okay, give me a sharp pointed smooth curved pick, or you can give me a sickle knife or whatever. To get the aesthetic working, give me this thing. 4% turns out. Give me a little syringe that you gave, and we put a little solution into the middle ear. Syringe with the needle also is okay, fine.
Which solution you are pouring into the middle ear, sir?
4% xylocaine with
Okay.
adrenaline,
Okay.
added separately. So usually, nowadays I do all my cases under GA.
Mm-hmm.
I think the level of apprehension in our Bangalore patients
Mm-hmm.
is very high. Their tolerance for pain is very low.
Yes. The patient doesn't know what is going to with them, but the main concern is their pain only.
Yes. Alligator forceps. You have straight instruments. I would prefer the straight instruments rather than the Can you keep this cotton with you?
So, sir, in this case, like middle ear mucosa is looking normal.
Yes.
So not that kind of edematous or
Yes.
So if we find those kind of finding like middle ear mucosa is a bit congested or
Yes.
pinkish, so what precautions or what measures we have to add on?
No, basically, you can always keep cotton soaked in. Yes.
Like in this case, you are putting ADR with the xylocaine just to
Yes.
reduce the pain. If
Yes.
suppose mucosa is edematous or like congestion is there any role of steroids we can put during the procedure?
Steroids you can put maybe before the surgery. You can use these
Okay. Ear drops.
steroid drops. Yes, you
Yes.
get. My favorite is ofloxacin with dexamethasone.
Right, sir, right.
Micro scissors, please.
Old is gold.
Yes. Yes. So basically trying to trim the edges of the perforation so that you make them raw. Yeah. Give me the sickle knife, please. Alligator scissors. Yeah, take a little 4% solution in the syringe and give it to me. Fortunately, the patient doesn't seem to have much pain. So that's my apprehension, because as I told you, it's a long time since I'm operating on under local anesthesia.
Sir, in audience, they want to ask few questions. Is that okay to discuss in between? Hello.
Yeah, they can ask questions. What is there? No problem at all.
Thank you, sir. Thank you.
No issue at all.
Hello, sir. Dr. Somnath De here.
Yeah.
Sir, is there any difference if you can find cobblestone-like mucosa in the middle ear? this.
See, ultimately, what I always say. During our times, the initial training was about mastoidectomy. Now we don't do mastoidectomy anymore. 15 knife. So we basically try to address the ventilation pathways. And second, if there is no cholestoma and no granulation, whatever is the mucosa, you leave it alone. See this incision of mine?
Yes, sir.
Can you see this?
Yes, sir.
Yeah? It is coming from here. Okay. So, small circular knife. Suction, please. Yeah. So, even if it is cobblestone mucosa, you can always take a bit of cotton soaked in adrenaline, pure adrenaline, higher concentration. The more you find congestion, edema, your concentration of adrenaline increases.
Okay, sir.
Remember, most of this mucosa is cobblestone because it is constantly exposed to the external atmosphere because of your perforation.
Yes.
The second, the three ventilation pathways, one which is posterior to the incus, one is between the incus and the malleus, and one is anterior to the incus, which has been demonstrated beautifully in the endoscopical anatomy by Moaz Tarabishi and Daniel Marchioni. So nowadays, mastoidectomy in such cases has become obsolete. We don't do it anymore. Okay?
Right, sir.
See, this jab of pain, patient moving her head. Now this is the part. Yes, now you're focusing it. No, I think basically I had only focus. I was just working with the. Yeah, can you give me cotton in, no. Can you?
Now we are seeing the middle ear.
Sickle knife, please. No, wait. Let us. Let me see what is the thickness of this
It is fully
plaque
matured.
of tympanosclerosis. Nothing really much.
You can easily separate it from the tympanic membrane.
Yes. Can you see this? Is not a very mature
Yes.
one.
Exactly.
Not a very mature one at all. Yes. Now, that's okay. Can you give me the side knife, please? The chorda seems to be here. Yeah, that's good. Hug the bony annulus. Cotton. 1 minute. No, I'll introduce it. Hold this. Well, careful, it may fall. Yeah, okay. Just see that. Yes. One more cotton, please. Yeah. Yes, now. Hold this. Can you? I'll give a little tilt to the microscope so that I can see the hypotympanum. I think picture is centralized reasonably. Otherwise, I'll centralize it a little bit
it's
more.
okay, sir.
Now should be okay.
A bit blurred. Yeah, it is okay now, sir.
Yeah. Give me this thing, beta. Circular knife, please. Yes, give me the side knife. Can you appreciate the anterior canal wall?
We can easily appreciate it.
Yeah,
Yeah.
because that is where the graft is going to sit eventually anyways. So it's very, very important that we have a good exposure of the annulus.
Annulus.
Yeah, now alligator forceps. Give me the sickle knife. All this, yeah. Now I can see the annulus there. So my sickle knife will stay right next to the annulus. So that way the whole thing gets elevated in one sheet.
Yes.
And as we keep lifting the annulus in local anesthesia, the
It goes pain.
patient will not have any pain, after some time. Circular knife, please. I can see the eustachian tube area.
Yes.
I think you guys can appreciate
Yes,
it
yes.
as well.
Easily appreciate.
Cotton. Yeah.
So, sir,
Actually
you're
now-
going to remove the total annulus or total flap outside, or
I'm just flap with the anterior attachment between 12 o'clock to 3 o'clock. I'll keep the
Yes.
flap attached.
Okay. It's
Wait.
270.
This case anyway doesn't require total annulus excision,
Right.
but any the conference today, I will get that. Okay, so now the anterior elevation is complete. If you have a ball probe, keep a ball probe ready at some point of time. Slowly, not immediately. I may need it in another 5 minutes or something. Yeah, a ball probe would be very useful. You are getting the picture?
Yes.
Hello?
Yes, sir. We are getting the picture.
Sickle knife, please.
Sir, like in this case, perforation was like small, medium size, and moreover in the central compartment.
I think,
Pure tone audiometry says
Sound-
it is more than 40 decibel hearing loss is there. Hello?
hello?
Sir, audible, sir.
Yeah.
Sir, like in this case, perforation was medium size and the centralized.
Yes.
And PTA was saying is a 40 decibel hearing loss.
Yes.
Do you think is there any other associated reason, like in ossicle chain is intact?
Can highest joint here?
Yes,
Mobility.
mobility is there.
That joint. This is the chorda.
Mm-hmm. This is the handle of
Finger.
finger.
Acha, acha, acha.
Yeah.
See the highest joint now. Chorda. Mobility.
Sir, your voice is not clear.
Okay. I feel this attachment towards the chorda. I will test this. You have a ball probe? Ball probe, please. Hello.
Hello.
Can you see here? I am checking the pathway posterior to the inca.
Yes.
Here, see, you need to go here, posterior to the incus.
Mm-hmm.
That is the first one. This is the tympanic isthmus here,
Mm-hmm.
anticus, and you go here for the next pathway. I'm checking the second one. Okay.
Right, sir.
Then you go above the tensor tympani. This is the third one. And one which is
Sir, your voice is breaking in between.
hello.
Yes, sir. It's now it
Yeah,
is clear.
anterior to the malleus here.
Okay.
See, this is anterior to the tensor tympani attachment
Mm-hmm.
to the posterior processus coccyriformis. Check here.
Right.
So this way, hello,
Hello.
this way you are going to ensure circulation pathways, sir.
Sir, suppose if we find some granulation or some cholesteatoma in this only this region,
Yes.
one out of three reason.
Yes.
So would we like to go for the mastoidectomy?
No, you
or
can
take
even
a-
still do
Yes.
inside out, no?
Exactly.
Yeah, if it is in region again, you need not really do the entire mastoidectomy.
Exactly right.
You can always go limited inside out and remove it.
And also now is the endoscopic era. We can easily see all these area with the
Yes,
endoscope and
absolutely. If
mobilize.
there's an endoscope, I can show that as well.
Exactly.
Alligator forceps,
All
crocodile
these-
forceps.
All these species, even sinus tympani and
Gel foam is
hypothalamus,
ready?
we can easily appreciate with the endoscope.
Yes, yes, absolutely.
Yeah.
Absolutely. Even the visualization of the sinus tympani,
Yes.
थोड़ा बड़ा करना, इतना छोटा पीसेस, और मुझे एक पीस दे दो, मैं ही काट लेता हूँ. Yeah. Can you see the middle mucosa?
Yes.
It's all absolutely pristine and neat. So I think I'll go for the grafting. Top light on, please.
Sir, one thing I just want to ask.
Yeah.
This patient has a moderate perforation.
Yes.
And on PT it was like 40 decibel hearing loss. Do you
Yes.
think is there any other reason that TS small plaque was there?
No, TS plaque is not contributing to the hearing loss. As you saw, it was very, very thin.
Mm-hmm.
I don't think that was the reason.
Mm-hmm.
You know, so you have some solution to dip this in? Yeah. Ziplocs drops in one bowl, please. No, not in that, ma. Separate bowl mein dena. Keep the straight pick and pick out pick. Where is the graft? Ah, very good, fantastic. Get the knife. Yeah.
Hello.
Yes.
Sir, we just want to ask, what is your preference to take graft, like before starting the procedure or?
See, ideally, I started my tympanoplasty in 1990.
Uh-huh.
My first plasty 33 years back.
Uh-huh.
Nothing. So, I am used to drying the graft and then making it wet just before I put it.
Okay.
But to me, if you ask me now, after I've seen my guru Satish Jain doing,
Uh-huh.
I am convinced that a wet graft
Mm-hmm.
is much better. And taking the graft just before grafting would be ideal. Okay?
Right, sir.
So a fresh graft is any day much better than having
This is dry graft.
out scissors if you have. You, now you give me the straight.
So, your voice is breaking in between.
Loose contact की तरह कुछ. It is better.
So, what is the size of the graft on an average you are taking? for
Depends on the canal. Here the canal is a medium width canal.
this? Okay.
We always say that about 1.5 centimeter by 1 centimeter
Mm-hmm.
would be ideal. Patient is moving a little, maybe a little, just a little. Yeah, you have this, wait, I'll put it on this. Pehle, I think you have vein press or something, gel press, yeah. Give me the vein press. कहीं तो था ना वो इसमें I'll keep the graft in this so that I'll take it in the end. अभी straight pick or smooth curved pick देना मेरे को. इस पे रख देते हैं. Yes. So I would any day say, please learn the art of taking a fresh graft and ideally take it just before you graft. Okay.
Right, sir.
As Satish Jain says, bed to bed. You know, that would be the ideal thing.
Sir, I think there is a different school of thoughts for any kind of procedure.
Yes.
Initially, we people used to do dry tympanoplasty, dry graft, everything we just thought about.
Yes,
that
yes,
everything
yes.
should be dry. So
All
there
this-
is a lot of studies also.
Sickle knife देना
People are
मुझे.
doing in the wet years also.
Yes.
I think there is a no difference in the results.
Yes. In fact, if you ask me, wet years are better.
Yes, because of the
The
congestion-
vascularity is much more.
Yes, because of the inflammation, vascularity.
One more
is
ऐसे
much.
ही कुछ. ये कहाँ है बेटा सिप्लॉक्स का बॉल वो इधर रख दे. Yes. I am now filling up the middle with the gel foam pieces. I'll take one under the malleus in my ventilation pathway. That is the tympanic isthmus posticus. Okay. The second one, I'll place it near the eustachian tube area here.
So these gel foam are soaked in the antibiotics.
Yes, antibiotic steroid. Ofloxacin and dexamethasone. Right?
Right, sir.
So you can put small pieces or you can put big pieces. You can graft even without putting the gel foam. The important thing in the gel foam technique is see that you don't create any scratches and wounds on the middle mucosa.
Right, sir.
Try to keep it pristine.
Even some people, they used to put it later on after putting the graft.
That also is okay,
That doesn't-
especially where you feel the depth of the middle ear is less.
Even
For example, if you have a little hypertrophied mucosa and the space is less or the depth of the middle ear cavity is less, you can always do that as well.
even sir, I saw some people who are not fond of putting gel foam into the middle ear. When
Yes.
they do like 270-degree flap technique, or when they do the anterior tucking, the
Yes.
flap is always on the air.
Yes.
There is no need, according to their opinion.
Yes,
I
crocodile
also,
forceps,
I also
please.
do in some cases. I don't
And
do
I
the
want
gel
a
foam
number
also.
22 suction. Yeah, I mean each one, I feel they should do whatever they are comfortable doing.
Exactly.
Okay.
But we have to appreciate other person also,
Yeah,
what they are
abs-
doing. This is the thing.
Absolutely. See, there's
Yeah.
no one technique. Straight pick or sickle knife, you give me, please. This is stuck a little to my crocodile.
Sir, you haven't scrutinized the malleus, sir? Sir, is there any...
Yeah, if it's a large perforation, I do skeletonize the malleus. In this case, I didn't find the need because the perforation was central,
Okay, sir.
and I feel I can comfortably place it under the malleus and also go anteriorly. Yeah?
Yeah. One thing I
You
just want
can
to,
see me placing it now. Okay?
one thing I just want to add on, if suppose perforation is not exposing the handle of the malleus, we don't have to touch it.
Yeah,
if it is
because-
exposing, then we have to expose it completely.
No, yeah, then a sickle knife is enough for me. Yeah, if you expose it,
Then we have to expose
it completely and
Skeleton
denude
knife.
it completely.
Yes.
Otherwise, it can go into, granular
Yes.
meningitis later, or what you call as mucosalization of the graft.
See, if the perforation
See,
is not
now
touching the
I am
handle of
taking
the
it
malleus, ideally we don't have to touch
Under
it.
the malleus, can you see this?
Yes.
I have taken it under the malleus, and I'll check the anterior part here, where I will place it on the canal. Yeah.
Excuse me, sir. Sir, there is
Yes.
a question from the audience, but
Yes.
they were asking about the pop-up technique. Seriously, I'm not aware about that technique. They
Which
just want
technique?
to pop-up technique.
That
I
is-
also not aware about that technique. I just want to enlighten.
No,
you about
what? I didn't get the term.
Pop-up technique. This is the question from the audience. So is there any?
What technique is
Sir,
that?
actually, I haven't read any in any book. I have seen it before. If the margin of the if the perforation is very small, then just doing margin refreshing, then put the graft inside the perforation.
Yeah,
and
you
put
can
it
do
at-
that. You can do that.
Without take out the.
That is a simpler technique as well.
Yes, sir.
You can do that.
Okay, sir.
But see, this technique I find is relatively foolproof, because you are making sure that you are seeing the entire middle ear, not missing any squamous epithelium, anything.
Yes, sir.
And if you have any tympanosclerosis, you can always, take it off. And most important, you will not be addressing the ventilation pathways in that technique. See, remember, many times perforation is not the disease.
Yes, sir.
Perforation is an endpoint of a problem in the middle ear ventilation. Okay?
Yes, sir.
So you need to address the pathways. I showed you with the ball probe the 4 pathways which you check. So that you can't do with that technique, whatever you named just now. You're just assuming that your job is to close the perforation.
Yes, sir.
Right?
Absolutely right, sir.
Yeah.
See, even in the traumatic perforation, if we saw like medium, large, small perforation,
Traumatic you can do
it can,
maybe. Yeah.
it can easily heal itself only.
Yeah.
So if there is no pathology, like sir was
In fact,
discussing
traumatic
about the
perforations
ventilation,
I wait for as long as 6 months many times over.
even
you know.
within 3 weeks or 4 weeks, we are actually seeing that patient with
Yes.
the medium size perforation, they get
Yes.
healed itself only. Yeah.
Yeah.
So main point is that sir was discussing about the 3-point ventilation.
Yes. That is in chronic,
Yes.
long-standing perforations. You can see I am almost done. I am placing the flaps back again. You can see the perforation was small anyways. So, and because I have not exteriorized the malleus and I have not done anything to the malleus, this drum will have a natural appearance when it heals. Okay?
Now itself it is looking like that only, sir.
Yeah, it will. In fact, it will. Ball probe, please. Please let me know if the picture is not centralized.
It is clear, sir, and
Yeah.
centralized.
Now see, with the ball probe,
So one question is from the audience.
yes,
Hello, sir. Can you hear us?
yes,
Sir, 2 points I'd like to inquire about.
yes.
Number one is regarding the perforation, small perforation where there is no, what the suggested just before me.
Yes.
That is almost like patch test or patch repair work.
Yes,
Yeah. With paper or like that, even this can be done.
yes.
This is more for testing the credibility of the hearing improvement.
Yeah, which I do.
Preoperative.
I do a patch test.
Yes, sir. Patch
See,
test.
some people also come with tinnitus.
Yes, sir. Yes.
When I do the patch test in the treatment room under the microscope,
Mm.
and they feel the tinnitus has come down,
Yeah.
I do tell them that after the tympanoplasty,
Yeah.
there's a good chance that you'll get good relief of your
Sure,
tinnitus. Yeah.
Sure. Thank you, sir. And
Yeah.
another point is that regarding your graft use, dry versus wet,
Yes.
if the graft is anyway, wet perforation, wet graft is always better. I agree with you.
Any day. Any day.
any day,
Yes,
any
yes,
time of the year.
Yes.
But if the graft has been taken before, it is becoming dry.
Yes.
Can we put it in saline solution? Is that the result will be better?
Yeah.
Okay.
But again, the point is, see, if it is a fresh graft, you put it in saline, that's okay. You know, in fact, this exercise, which I've been doing for years, but see, I'm drying it first and then again making it wet. It appears kind of self-defeating. You know, so that, otherwise, I am more for fresh graft these days. I think you can see the end result. Yes?
Yes, sir.
See, it's all nicely covered. The old tympanic membrane, the new are nicely amalgamated. So there is no problem. छोड़ दो.
So what is your point on this perichondrium using as a graft and or the
it's,
cartilage tympanoplasty? Please.
My colleague, my younger colleague, Dr. He uses perichondrium. Perichondrium is a good idea for endoral. Meatal endoscopic. Because you are not going to give any incision to the patient as well.
Right, sir.
Perichondrium is also a very good material.
Right, sir.
What is important is that material has to take up, your perforation has to clip. The ventilation pathways have to be addressed properly, and there should be very less chance for the mucosalization of the graft. Right?
Right, sir, right.
So I think ointment डाल देना इसमें.
So, sir,
Yeah.
all we are getting from the procedure, if we summarize this, whatever procedure we are doing,
Yes.
so whatever approach
वही
we
भी
are
है.
doing, like post-oral, end-oral, or the
Scissor देना,
endoscopic,
straight scissor.
whatever graft we are using, wet or dry,
Yeah, yeah.
whatever like tympanoplasty, wet or dry.
Yes.
So main thing is that the 3-point ventilation.
Yes.
If we are getting this, whatever we approach or graft or wet or
Yes.
dry tympanoplasty we are doing,
Yes.
so I think result would be same.
Yes.
Both sided. All
So
time.
very nice demonstration, sir.
अरे
As
no
usual-
problem, boss.
As usual. So,
SMR elevator और कुछ something you can give me, yeah. थोड़ा जेल्फो मिक्स कर
any
दो.
questions from the audience?
Yes, boss. So I think I am putting back the coroner's flap now. Lampert speculum, please. Yeah, you can feel free to ask me any question. Your questions don't disturb me in any way, even when I am doing the thing. Please feel free to ask any question.
স্যারকে এই ঘড়ি চলে আসতে বলো, এই ঘর থেকে আনসার করবো.
Any question from the audience? Don't feel hesitate to
Yeah.
ask any question, because question
sickle
never be
knife,
stupid
please.
question.
Yes. Ointment देना बेटा. The microscope is wonderful. I enjoyed operating with this. Really, it was very, very good. We had initially one bleeder infero-posterior, which we took a little time. Other than that, I think this was a reasonably straightforward case. Yeah.
Sir, I think technology when meet with the skills, it do the wonderful.
Yes. मुझे कुछ SMR elevator की तरह कुछ देना बेटा, ये ointment डालने के लिए. हाँ? Yes, yes. I'll come. I'll just fill it up this particular part.
Of course, huh?
Freer is best.
Hello.
Nothing like freer.
Hello?
Yes.
Hello.
Audible. Sir will come this next room. So all are ready. Next room.
Yes.
So,
So what is the case in the next OT, sir?
next OT? This is the basically we prefer. Dr. Deepak Khutukar sir ke ekhane aste bolo. We prefer in both perforation in a single sitting. Okay.
Okay.
But in 25 years female, Shantana Ghosh, both sided subtotal perforation. We prefer in our hospital in a single sitting. Hello?
Yes, sir. Yes. We are
30 and 38.6 decibel hearing loss. But in that cases, we checked through nasal endoscope. Any nasal pathology is there or not. Okay.
okay.
And
Cotton?
we take the big graft.
मुझे जरा cotton देना.
Hey, sir के छेड़ दो.
वो नहीं. Dry cotton देना. I'll take my left. Yes.
Hello.
Hello.
Sir, like you are talking about in bilateral CSM, you are always looking for the nasal pathology.
Yes.
So if suppose something is there, like allergic rhinitis, vasomotor, DNS, or even the sinusitis,
We ask the should correct before
Yes.
that.
like
And in that both sided cases, we prefer GA. Otherwise, we do the all are under local anesthesia. If patient cooperate, okay.
right, sir. So
Sorry.
my question was, sir, like DNS or the sinusitis, if these are the surgical indication, we have to go first.
Yes.
Like in allergic rhinitis, what is your take in these kind of cases? You have to suppress it. You have to do the medication for allergic rhinitis.
Allergy rhinitis, definitely
cause-
there is a treatment
Yes,
or
sir.
immunotherapy, all
21 days
skin prick
later,
test. But spray
निकाल
and
दो.
anti-allergic also
After
we should
21
give
days, yeah.
before surgery.
Keep this
Before
for
surgery.
21 days.
What is the exact time?
Indication.
Yeah.
So,
Don't
what is the
remove it for
time
21
before
days.
the surgery you
That way
are
the canal
thinking
will be nice and round, well
to
healed.
start treating the allergic
Especially when
rhinitis?
you do a 360-degree elevation of
I
the
should
flaps,
stop talking basically.
you won't
just
get any
health
canal
people are already talking.
stenosis.
Okay.
Huh?
So
Will
one.
you
just
close?
1 minute.
Thank you.
Okay, okay, fine, sir.
Sir के खाना आस्ते करो.
Thank you so much.
Thank you so much, sir. It's
Yeah.
a very, very nice presentation as
Dr. Huldewood
always
sir,
from your
please
side,
come
sir.
this room
Yeah.
and you will moderate from here.
Yeah.
Dr. Huldewood sir. Hello.
Hello.
Okay. Now this is a subtotal perforation nearly, and we prefer the end roll incision. The big graft already taken up for both sides, and
Thank
I prefer the always end roll incision. Okay.
Okay.
So and this is the perforation and big this way the freshening. Okay. You may take this Jolna needle
DCR डाल दो.
also,
हाँ?
and also sickle.
एक
Okay.
दिखाते हैं तब तक बॉस को कुछ.
Okay, this way. Simply. This way, and take the microsuture and try to all along, okay? And take the alligator. You see how the ring-like structure will be coming up, okay?
Okay.
This way. And beautifully, look. The ring-like structure, okay? Now freshening already done. Now
He's very fast.
the undersurface freshening, okay? That's also I prefer. Otherwise sometimes mucolization will be there.
I
Okay.
think it is in the spinal.
What is the Huldewood say?
It's very precise and very fast.
Oh. Okay. Hello.
Hello.
This is the freshening.
Yes,
Now
sir.
I prefer the antio-indo technique, tympanoplasty. Antio-indo technique, okay?
Okay.
So I prefer, this is the freshening done already. Sir is coming. Now sir will answer all question. Okay. The freshening done. The right links like structure. Now I prefer the antio-window technique tympanoplasty. Here, look here, the mucocutaneous junction, slight bit of lower, okay?
Okay.
Around 8 millimeter or 7 millimeter. Not circle. Here up, posterior part. Here anterior. দেখা যাচ্ছে? মাইক বুঝতে পারি তো? Okay, this way I prefer this incision, okay? Yes, this way. Look here, bone deep incision. And just take this smoothly. And take left hand stiff sucker and right hand your instrument.
Excuse me,
Yeah.
sir. Dr. Ghosh,
Yes. Yes,
did
sir.
you did something else in this case, or it is your routine? It is not bleeding at all.
Yes. Cadaver dissection.
Exactly.
No, basically, good infiltration. My all our assistant is the very good.
Okay.
Basically, nowadays, getting the chance to infiltration is very less, and also flap elevation is very less. So all our, my assistant is basically champion. Okay.
Because
This-
you
this-
trained them so well, sir.
Yeah. Look here, and also your flap elevation according up to your flap elevation technique. Bleeding will be there, because if you take the proper plane, okay, and here, and for junior, here the struggling started, okay. I have seen my all juniors initially all started the struggling here, okay. This is the annulus. Just should check the annulus, and also this way. Look here, this way, okay. Beautiful. This is the bony annulus. This is the fibrous annulus, okay. And now take.
And the blue thing in the middle is the mucosa.
Yes. Now the problem started. Sucker. Now take the sickle knife, okay? Now the sickle knife.
Hello.
Here, hello. This is a sickle knife. You
Sir.
just take it this way, okay?
Hello.
Hello.
Sir, I just asked that question in that if in bilateral CS1 cases, if patient have an allergic rhinitis, like we have to treat them medically, if there is a no surgical
So
indication like DNS or
like you
how
just
long before you start the treatment and after the surgery, how long you put on the allergic
basically,
rhinitis management?
if you give the put the if you treat the allergy rhinitis, control the allergy rhinitis, then you do the surgery, no problem at all. If gross DNS, gross polyp, definitely look here. The normal allergy rhinitis treatment, not nothing else. Basically, we prefer the you ask the patient to do the tympanomasty in a sitting, and you see the big graft, big graft. This is the big graft. Also, I think this is the big graft. We place the both side, okay, and simply no harm at all. I have
And see, allergic rhinitis is not a contraindication for you to do a tympanoplasty before that.
yes.
The culprit number one always is adenoid or some
Yes.
pathology in the nasopharynx.
So for that reason, I have also mentioned the nasal endoscopy is the essential
Yeah.
for
And secondly, if there is an antroconal polyp or bilateral huge ethmoidal polyps feeding into the eustachian tube,
That we have to address first.
yes,
Yes.
rarely you find this Thornwald cyst or something like that.
yes.
DNS per se causing the problem, I have actually never encountered.
Slight.
You can
Very
always
less.
correct it
Very
later,
less.
but
Yes.
mainly the pathology in the nasopharynx.
Right.
For that reason,
Yeah.
I do endoscopy here also.
Yes.
And also you see that this is the end point of my anterior flap, okay? So not circle. This is the not circle. I prefer the slight bit off, 2 millimeter off. Okay, this way, and this way. Simply,
Two parallel radial incisions you are giving. That's it.
yes, this way. And bone dependent. Again, you will see the bloodless field will be there. Under GH still. Under LA, a little less bleeding. Under LA. And also, this is the stitch I prefer. This is the stitch.
See, basically the funda of tympanoplasty or myringoplasty is the vascular supply to the canal skin.
Yeah.
And the leash of vessels come from the suture lines.
Right.
So in this technique, he is correctly creating windows, keeping the vascularity intact,
Right, sir.
and the graft goes underneath.
Exactly.
And
This
what
way-
is important is if the infiltration is good, look at the ease with which he is elevating and the speed with which he is doing, and it is avascular.
And you see here, this is the main. Here. I how I'll manage it. I always
Tushar, center the picture a little bit. It's going to the top little bit as you are.
this way. You see,
That's better.
I don't prefer to touch the malleus. Okay, but I open the notch of ribness. How it is possible? You see here. From here, just give the pressure here. Just give the pressure here. Put the pressure. Look here, and the notch of ribness will be there automatically. You see this technique.
Right.
Look, and no, yes. Okay.
Beautifully, sir.
Yes.
I think you didn't put up infiltration over there.
No. And no pressure at all. And now you just quarter tympani will be there, and you will remove this part. Okay. So it's very simply.
Sir, these two flaps you are already taken, and anterior and posterior, they are
Yes.
incision at the same level or at the some bit different
No, also
level?
already I mentioned 2 millimeter at least gap is there. No, not circle.
No, I'm not asking about the complete circle. Their level of incision at
Level
the
of
same
inside 2
level.
millimeter posteriorly 2 millimeter high.
Okay, fine.
Ayyo.
And also
Right.
look here,
ಹೇಳ್ಬೇಕು
not
ಇಲ್ಲ.
attaching here.
Right.
I am creating area here, but above will be attached. But here I'll do.
Leaving the strip over.
Okay,
Yes.
this way. Okay, this way. Okay. So I will place the graft. Look now, the placing the graft and checking the first. Hey, অন্য case ready করে হয়ে যাবে. Look here. The freshening. পুরো ready, full ready করে ফেলো. Now you see, today we kept 20 cases. I don't know how it is possible, but I will manage.
The way you are going, I think it is possible, sir.
No, basically, we don't prefer any time loss between
Posteriorly
two surgery.
2 mm higher.
Basically, 4 OTs there.
Higher means goes
So all job will be ready by assistant. Next case will be the adenoidectomy. And look here, the clean area. Nowadays, now I put the graft, okay? A dry graft, but I put the slight bit of water. Okay, look here this way. Okay, look here this way. As much as possible, just go every day. I'm asking my assistant, go this way, okay? Simply.
So you are using the underwater technique.
Look here, this way, okay? As much as possible. Yeah.
So is there any need to nip the head of the malleus? Do you find any indication, or in which case you prefer to do that?
Basically, if possible, I always put the lateral to handle malleus. Sometimes not possible, I will, but I always put the notch up to notch of ribness. Okay.
Okay.
So touching the malleus is the most important for me, not medial, not lateral. Okay.
If suppose handle of malleus is just touching the middle ear mucosa,
Yeah.
so then you, what is your take? Did you nip that?
Okay, I will show how we'll manage basically.
Yes.
This way now, this way, as much as possible, okay? This way, look now, this way, okay? And how graft not attached, will be attached to the promontory at all. Now this is my graft, and take this, left side, my tip sucker, and right side, my flap, okay? This way. For junior, take this way, and suck this and take this, okay? This way, okay? And 100% sure your graft will be taken up. Luckily, sometimes reperforation will be there. As Dipankar said, the
Whenever you
reperforation-
reposit the flap, it is already taken, sir.
Yes, look here. Look
It's wonderful,
here.
sir.
Go the inferiorly, okay? And
Yes.
go this way, okay? And look. And how beautifully it will be placed.
Yes.
And your question answer will be there after placing. Okay. Look here, this up to annulus. Yeah. This way. Look here. So like Luci or ballooning, okay? And look here the apposition. The beautiful apposition.
Okay.
So we tell the 10 minutes tympanoplasty.
Very fast, very precise, sir.
Look here the attached.
So I
And
think
now also you should maintain the canal. Look, another rasp. Yeah, this is the annulus. Here you should mention and check this way, this jack, and also you should again put the air here, okay, and here, okay. This is the ballooning, okay.
so, sir, in the last case I was discussing about the same things. So some people not use the gel foam in the middle ear, like in these cases,
I
anterior
don't prefer
tucking.
normally.
Yes,
Sometimes,
exactly.
if slight bit of confusion, sometimes I put gel foam only 6 o'clock.
Right.
Basically, I don't believe the basically rejection of graft in upper part. Sometimes we have seen with my lot of series. Basically, I have done at least 8,000, more than 8,000. Okay, so luckily, so less, definitely failure is there in all surgeons. But here, my experience is the
There are a lot of factors for the tympanoplasty failure, not only the surgeon factors.
Yes. So I have seen the perforation here, the 6 o'clock position. So sometimes.
So what was the reason for that? Is that stitch into negative pressure or what?
Question.
So that you are mentioning
Pardon?
that 6 o'clock position graft
I
failure
don't
is.
know. Basically, sometimes I have seen after the infection, slight bit of reperforation. I have seen the sometimes 6 o'clock. Sometimes,
Okay.
if any confusion, sometimes I put the gel foam here,
Right.
only here 6 o'clock, not
Right.
anterior, no superior. Here, I'll show, but normally we don't prefer too much put the gel foam. I'm lucky I have operated with Dr. Bijendro, Dr. Ruby, Dr. Janki, but Ruby I have seen in Baroda all time full of gel foam, middle ear. So I asked why full of mental security. So after showing my case, he told, oh, you are tucking, no, too much, so you are not fear about the rejection.
Yeah, exactly, sir. When you are doing the tucking, I think there is no need to put a gel foam in the middle ear.
Yes. So
Yes.
I'm sure, no, because if you check, no harm, no, you see. So look, this is the system. No?
Sir, endoscopic picture is not on the screen. I think it is the OT picture.
Hey, hey.
Yeah, now it is fine.
Now you see,
Yes.
my graft is there, no. So
Uh-huh.
no way, no rejection, no.
Yes.
Big graft. So sometimes if you are not sure, again you check. And this way you place the graft fully, not half-heartedly, okay? When I was junior, I have done this tympanoplasty technique. I mentioned this is the window technique, and was very much senior and my respectable Dr. Dulal Bose told me, Tushar, you tell that this window, it is now the door technique. No, you have given the big incision. So this is the anti-window technique. Still now mentioning the anti-window technique, but this is that like door technique, it's because the safety security, you will see, and also you just movement this way, okay, this way, and the ballooning, okay. Now you are sure, no leak at all, okay. So also the finish the tympanoplasty, okay.
Very, very nice presentation,
Thank
sir.
you so much.
You already checked the mobility of tympanic membrane also.
Yes.
Any
Look.
question from the audience?
And also put the
Hello,
gel
Tushar.
foam over the annulus. This is very, very important.
Hello, Tushar.
Yes.
Very excellent demonstration.
Thank you
Thanks,
so much,
thanks,
sir.
many thanks.
Yes, sir.
I am Shubhendu.
Oh, Subhendu, fantastic. I'm lucky Subhendu here.
Thank you.
He's so busy with practice and also association work, not giving the time. Basically, the hero and guru is the Subhendu. My roommate.
Thanks again.
But he's so busy with his practice. This way, just should put the gel foam here also rounded. After that, also not gel finish. Put the cotton again. Give the gel foam because it will be maintained. The canal will be maintained. এই অ্যাডিনাইট রেডি করে দিয়েছে অ্যাডিনাইট করে দিই তারপর স্যারকে দিয়ে দেবো অ্যাডিনাইট রেডি আচ্ছা যতক্ষণ আন্ডার হচ্ছে ততক্ষণ আমি বলে যাই লুক হিয়ার কোশ্চেন বলতে হবে তুমি তাকে থাকো সেটা ভালো বলো
So, sir,
Bhushan sir,
do you do this anterior tucking technique in every cases or some specific indications are there?
Every cases.
Every cases.
Without
Okay.
tucking, basically in our hospital, no one allowed to do any tympanoplasty.
Okay. Like we people are used to do with the endoscope. It is bit difficult because in the microscope your both hands are working, are coordinating very well. So in our center we are doing this anterior technique when moreover in the large perforation.
Sometimes it's very rare, your question, according to question. Sometimes ekdom posterior small perforation, we basically prefer the incision from here to here, like Deepak Holdipur.
Okay.
That way sometimes I avoid this technique. Otherwise all cases
Yeah.
I prefer the anterior window technique. Otherwise insecure, I feel the all time insecurity.
Mentally insecurities. But sir, it was a great demonstration.
Thank you so much.
Very fast,
And
very
also-
precise.
also
The bloodless tympanoplasty.
No,
Any question from the audience?
hello. Now my
Yeah.
assistant will put the gel form. That one, that is gel form now.
Hello,
now-
Dr. Ghosh.
Yes.
Just putting in a few points. Can you help us? Number one, whenever there is bilateral perforation,
Yes, sir.
there is every chance that nose and the nasopharynx may be the main culprit.
Yes,
So you have to look for that and redress the pathologies there. And number two, whenever we are doing any sort of ear surgery, there is slightest even 0.1% chance of cochlea getting affected and sensory neural hearing loss may set in.
No, but in
If
case of-
we do bilateral, there is always the increased chance of that in both ears. Yes, your comments,
but
please.
nowadays in tympanomasty, sir, SN loss is very, very less. Very, very less, negligible. If you do properly surgery, because the suprastructure, if you damage the suprastructure or anyway stapes movement or anyway round injury, then there is a chance. In case of stapedidomy surgery, definitely we don't prefer the same sitting bilateral stapedidomy. But bilateral tympanoplasty, sir, I am doing. But in case of if I suspect the osteoplasty required, then also I avoid to do the bilateral sitting. But in case of plain tympanoplasty cases, we prefer the bilateral tympanoplasty. I think no harm, sir. Initially you will be hesitating, you will hesitate, but if you start this practice, then you will be confident. Because one of my sister's brother, I have done these cases at least 12 years back in another nursing home. That time I have seen, oh, good, both sided graft taken up. After that, lot of army patient coming to me, and they are went to fitness for early, very fast, after
Right.
1 month. So there is no time, no, in between two tympanoplasty, 21 days.
So
For that reason, I have started the both sided tympanoplasty in a one sitting. Sometimes I prefer the GI in both sides. Otherwise, patients sometimes irritated. So after that, started this technique. Now I am a regular. Now I offer the patients do tympanoplasty both sides. And single, okay, fine. Sometimes patient not agreed because the bandage will be there, but patients costing will be so less. After both sides, no, patients costing will be less.
So sir, what you are cutting? Anesthesia charges or your fees charges?
No, basically both sides the total accumulation will be the charge, no?
So
both,
just
here-
accommodation charges will be complement, huh?
basically both sided means 1/3 of the another charge, no? Add only.
Right.
1/3 of the so then the first operation is the if think the same charge, then another is 1/3 of the one. So 1
Okay.
plus 1/3. So total basically is very less, no? And patient also is happy basically.
So totally
And
agreed with your point, sir. Sir, I just want to ask, what is your like in your experience in bilateral CSM, you are doing tympanoplasty. So what is the outcome, prognosis or results? How many
results,
failures?
Initially, you will think that
Hello.
okay,
Hello.
result will be less.
Hello,
but
Tushar.
same result.
Tushar,
Hello?
you should mention time is money for the patient.
Yes.
Yes, yes. Also headache free. No, sometimes you have seen no patients are done one tympanoplasty at least 2 years, 3 years before, and came for discharge another year. I asked the patient why not doing the tympanoplasty after 1 month. I have asked. No, sir. They are okay, fine. Now the discharge coming sometimes. Okay, just offer two surgery. No, in a one sitting. No, and Jamala khatam.
Sir, this is the interop thing. I just want to ask the follow-up thing. Did you encounter sometime both of the ear graft is failure or one-sided we can easily see. So both side graft is not taken up.
Both side failure is less, but I have seen in case of reperforation.
Okay.
But now the hospital is mine basically. We prefer the offer the okay. I will do free. So if
Yeah.
free, no patient, no comments. Free visit, free free hospital.
What is your take on bilateral unsafe CSM?
Unsafe session? No. Unsafe protocol is the one-sided first, and after 2 months at least gap will be there. Then we will do the tympanoplasty. এটা হয়ে যাবে তো এটা তো এটা ও রেডি করো ওটা
It is the standard protocol for all of us.
Now this case is
the free for the failure cases.
Hello.
It's the standard protocol for all of us.
Yes.
The free for the failure cases.
Now the
Nothing.
endoscopic adenoidectomy cases, a case type to description দিয়ে দাও না. With coblation, you love to do the surgery. If you take Subhenduda not fond of adenoid basically, I know, but sometimes adenoidectomy is very much required. In this case, 7 years of age coming from the GHOSH, Sonarpur, ঠিক আছে, and basically pain in the ear, mouth breathing, pain in ear, right ear. We'll do the, I think, grommet also, OME and grade 2 tonsil enlargement. We don't prefer too much of tonsil. If tonsil obstruction only, then we'll do the tonsillar surgery. Otherwise, only adenoid, I prefer the adenoidectomy. Adenoid will give the good result of OME. Also the mouth breathing will be less. Also the allergy problem, nasal obstruction all time, that will be definitely improved. Okay. So, hey, Deepak sir, কোথায়?
So roughly you're talking about the indication of the adenoidectomy.
Yes,
Some
yes.
is the obstructive, some is the non-obstructive.
Non-obstructive, I don't do any, in case of only CF suspected, in that cases I do only non-obstructive cases.
Okay.
Recurrent tonsillitis nowadays is very less. Recurrent
Right.
tonsillitis, throat infection is very less. Only patients complain the nasal obstruction, bar child cough,
I
cough
think
and
this,
cold.
I think this refractory cough,
Yes.
maybe
so
the reason
all-
is adenoiditis,
all are
that could
due
be the
to- all are
indication
due
for.
to- All are due to adenoid basically.
Yes.
All are due to adenoid. স্যার কত দীপক দেব আচ্ছা কাজ ও রাতে তো ঘুমোয়নি না হ্যাঁ ঠিক আছে তো 3টের সময় এসে। দেখো look here, the huge adenoid.
Sir, actually endoscopic picture is not clear. Not
endoscopic
yes.
picture?
Now we can see that.
If you see this type of picture, how will manage this kid? No way. You should do the adenoid, life totally will be changed. Really unbelievable results.
Sir, there is a question from the audience. Is there any chance of bleeding in these kind of childs when the patient having a grade 3 or grade 4 adenoid bleeding?
So bloodless technology, I will apply the bloodless technology.
No. In complaint or presentations.
Presentation bleeding is less. Adenoid from adenoid, I don't believe. If child present with the bleeding, then you think about the septal any congestion or septal point will be bleeding will be there. Sometimes
Right.
we have seen lot of cases, adenoid, huge adenoid, but with the problem with the septal congestion.
Maybe some
You see,
trauma is also
I am
there
putting
because if adenoid hypertrophy is there, so all
One-
time their nose will be wet. There is no dryness. I think some add-on trauma will be there if patient is presenting with the bleeding.
Yes. This is the tube, okay? I put the tube.
So you are going to do the adenoidectomy or tonsillectomy along with that?
Adenoid.
Only
Adenoid.
adenoids you are going to address,
Grade
huh?
4 adenoid. Basically.
Yes.
So adenoid, if you address the adenoidectomy, the problem will be solved 98% basically. Because the ear problem will be solved, recurrent cold cough, and now this is the bending. Slight bit bending.
Any specific this band?
Okay. ও স্যারকে একটু ইয়ে করে দিই, স্যারকে একটু আসতে বলো, আমি তারপরে ওনাকে ফুল দিয়ে দেবো, ওনাকে ড্রেস পরে চলে আসতে বলো। Look here, this is the adenoid, no? My preference of adenectomy from upper pole. This is a beautiful technique you see, and sometimes the blood spot is there. This case was lot of infection, recurrent infection. You prefer, sometimes we prefer basically adenoid before adenectomy, 7 days or 5 days antibiotic course and anti-allergic course, okay? Now you see how we'll manage. Look here, the beautiful plain.
Audio visual. Hello.
Hello.
I think there is some issue with the audio visual thing. Video is not on the screen.
এই
There is
ভিডিও
no
যাচ্ছে না?
signal. Yeah, now it is fine, sir.
Okay, fine.
Sir,
Now, so see the
sir,
adenoidectomy,
screen-
how will manage?
Hello.
Hello.
Sir, can you please wait a bit for us because screen is not visible. Yeah, now it is fine.
চেঞ্জ করছো কেন?
Yeah. You can, sir. Thank you, sir.
Now fine?
Yeah, it is okay now. Oh,
Okay. You see from upper pole,
I think,
I'm starting, okay?
sir, very sorry to interrupt you in between.
Abhi now, okay?
Now it is okay. Whenever you putting the pedal, I think the screen is gone.
Hello, sir.
হ্যাঁ।
The same coming and going syndrome
I
we
think
had
so.
faced just 2 weeks back. Same thing. Please tell the audio people, visual people.
ও এটা প্রেস করলে ভিডিও চলে যাচ্ছে?
হ্যাঁ হ্যাঁ
Maybe
বারবার
there is
তাই হচ্ছে
some
ওই গত রোববারের মতো
এই সেম প্রবলেম।
Same problem, same problem.
সোর্স চেঞ্জ করতে হবে, সোর্স চেঞ্জ
I think
করো।
earthing.
করেছো? নাও ওকে নাও?
No,
Now
sir.
okay?
No, OT picture is visible. That endoscopic picture is not there. You are visible, sir. Adenoids are not visible.
পিকচার দাও। এই জল দাও, জল।
We want to see both adenoids and the surgeon.
হ্যালো?
Sir, you are visible, but adenoids are not visible.
ও
You-
আচ্ছা। 100 বার বলেছিলাম সেটিংটা চেঞ্জ করে দাও। কোবলেশনটা চেঞ্জ করেছো? আরে আসবে না কেন? প্যাডেল মারলেই চলে যাচ্ছে তার মানে। নাও পিকচার ইজ রেডি?
No, sir. Endoscopic picture is not there at all.
এন্ডোস্কোপি
Okay. Yeah, now it is fine.
It has come,
Okay.
but let's
Yeah.
wait for
now
the staying
fine.
of it.
Now
Yeah.
you tell if I press the pedal
Gone.
Yes, second gone.
again gone.
Yes, sir. Now come back. This coming and going syndrome is always there.
বুঝতে পেরেছো শেষটা? পালাটা আমি বারবার বলেছিলাম পাওয়ারটা চেঞ্জ করো। বোর্ডটাই চেঞ্জ করতে হবে। Same source, no? So when I press the coblation, then picture is gone. Now I think 795 for. Now okay, picture?
Yes.
Till
it
now.
is.
Now,
now.
Now it is
picture
okay.
problem?
Yeah.
No.
Okay.
Picture problem?
Yeah, there is no issues now.
No
you
issue,
can,
no?
You can proceed, sir.
Yes. দেখেছো? Same problem. বলেই দিয়েছিলাম তো একই পাওয়ারতে দিলে হবে না। Now see, Dr. Bhushan,
Yes, sir.
just mention about this endoscopy adenoid. You prefer with coblation? How will just take audience? Look here. How will manage? Beautifully manage if you do the coblation adenoidectomy and fantastically without any bleeding.
I think you are just brushing the tissue.
Yes. You see, I don't prefer any brass in my table. Okay. Lot of people complain that there is a block, but if you prefer the too much water flow, you will see the block will be less. Look here, and don't allow any bleeding. Okay.
So, what is the setting of this?
I prefer 9.5, not 7.3. Automatic setting is the 7.3. By I always increase the setting.
Okay.
And initially my assistant will start the 7.3, and when they are expert, I always ask please change the setting. Initially problem will be there, but when you will be expert, then no problem at all. You will be very fast water to come there.
If you have
see,
to, if anybody has to do the endoscopic
Look
or
here, my assistant
debrided
wants sucker in my oral cavity.
adenoidectomy, they have to learn how to deal with the
nasopharynx.
debrider. So, what is your limit for the adenoid? Where you did stop?
Grade 4, level 4, basically full nasal obstruction was there. Fully nasopharynx, totally corner block.
No, where you stop removing the
Basically,
adenoid tissue?
I used
Limits
the
of.
one
Yeah.
sucker catheter
Uh-huh.
to retract the palate. I will show
Okay.
how. Outside camera, I just finished this side.
So, what is the posterior limit of removing these tissues?
Okay. I will show the seed. Okay.
Okay.
Inferior I will show the boundary, basically. Total boundary I will show. So you see, this is the eastern tuberosity, okay?
Yes.
But torus tuberous. So here the lateral boundary, fossa
Sir,
rosenmula is the lateral
Some
boundary.
screen issues going on continuously.
Screen? Hello?
Hello?
Picture is good?
No, picture is not clear
Hey,
and some
hello.
blurriness is there.
Picture is not going?
No, sir.
Hey, stop. Okay, I'll stopping.
So, sir, like in this case, we can easily see that station tube is a bit edematous and congested. Is this patient has some hearing loss issues or
Yes, yes.
otitis media
Otitis media was there.
was there?
And
Yeah.
patient came basically ear pain, with ear pain.
Okay.
And patient came ear pain, recurrent history of recurrent pain.
So
we
you're-
always do endoscopy, nasal endoscopy.
So you're going to relieve that part, or you just finish with the
No,
adenoids
I'll
and just
remove.
leave it?
I'll show total. Basically, this is should encounter. Otherwise, this way and also obstruct this way.
Sir,
I'll
actually,
remove
your
it.
picture on the screen, endoscopic picture is not there.
কি করছো? Okay, just wait 1 minute, please. Sorry. কেন দেবে? কি ঠিক করতে হবে? কুবলেসের পাওয়ার তো অন্য জায়গা থেকে নেওয়া হয়েছে, এবার চলছিল তো। হ্যাঁ তো রেডি করো না, আমার তো হয়ে যাবে। এনওডিসি কোনটা?
Sir, which endoscope you are using? 2.9 mm or 4 mm?
হ্যালো,
Which endoscope you are using?
2.7.
2.7. Okay. In every case, you are using 2.7
Yes,
only.
in pediatrics, all cases in endoscopy outdoor also 2.7.
Right.
এসছে ছবি? এসছে পিকচার?
No, sir.
No sir, no. Why picture not coming? Console.
We can do PIP also, both picture in the screen.
You have not done this case. Sir. Oh sir, আসুন sir. Good morning sir. অ্যাডিনেট করছি ওদিকে আবার ওই একটু মানে ক্যামেরায় গোলমাল হচ্ছে। নাও ক্যামেরা ইজ কামিং?
No, sir.
পিকচার নো?
No.
ব্যাক পিকচার ইজ কামিং?
No.
কি করছো তোমরা? এতক্ষণ ভালো করলে। লোকাল
So, sir, for ear symptoms, you are just doing the myringotomy, or you are going to put the grommet also?
প্রথম করবে তারপর স্টেপস করো। হ্যালো?
Hello?
হ্যাঁ।
So, meanwhile, we just want to discuss until the screen is coming. So, for the middle ear symptoms, you are just going to do the myringotomy, or you want to put grommet?
Grommet, myringotomy, grommet also.
Grommet also.
If fluid is there, definitely grommet. Otherwise, only myringotomy. But I
Okay.
address much
Okay.
more here. Fossa rosenmula, all will be clear. তো এতবার করে দেখে এই যে এইটাই কাজটা যদি ঠিকঠাক না করতে পারে, কি প্রবলেম হচ্ছে একটু বলবে? কেস ছিল তো, আমার তো ঠিক ছিল না, তাহলে কি হচ্ছে?
So, sir, what is the minimum age of patient you are doing the adenoids and the extreme age? Hello?
হ্যালো?
So, what is the patient age, minimum patient age and maximum patient age you are dealing with the adenoidectomy?
1.5 years.
1.5 year is the minimum age.
Minimum
And,
age I have done.
What is the extreme higher end age?
Higher end is the 55, 65.
Okay, you're getting that
Looks the
kind of.
adenoid reduces, but adenoid not reduces. If you check by endoscopically regularly, you will see the lot of adenoid will be there. So OSA patient all
Okay.
present with the.
Sometime what happen when we are planning a patient for the
And
septoplasty?
sometimes I have done also histopathology test after removing the big adenoid, but all are basically lymphoid tissue.
Okay.
And if you look the angry looking denture,
He's telling to us to
Yes,
stop or what?
now picture is coming.
Yes, picture.
No, both of you are coming. So what you are talking about, sir? During that night, you are sending some tissue for the histopathology also in the
Yes,
adult cases.
sometimes, but not in
Okay.
case of children, in adult.
Right, right, right. So what you are suspecting in all these cases?
Sometimes if patients complain the bleeding or something's nasal, suddenly nasal obstruction, lymphoma cases or nasopharyngeal carcinoma, but normal smooth swelling, क्या प्रॉब्लम होता है ये तो दो कैमरे से आता है तो अच्छा से
So
কি প্রবলেম হচ্ছে একটু বলবে দয়া করে
squamous cell carcinoma
আপাতত
usually
চালাবে সে এক কথা হয়ে গেল আপাতত দাও কি করবে পৌঁছিয়ে মানে
Hello.
হ্যালো
Yeah,
now
this is
picture
I
from
think
this monitor anyway not coming.
yeah, this
So
is
they
a
are giving
better way, sir.
temporarily from external camera. Okay.
We can zoom in also, sir.
দাও ফোকাস করে আপাতত কাজ চালাও কি প্রবলেম হচ্ছে
Yes.
এই পোটে কেন এতক্ষণ চলছিল তো
Who's the man behind this idea? Sorry.
now ready this picture is ready
Yes, yes.
this picture not so good but still now
No, it is
stop
okay,
that.
sir. It's better than before.
Okay, look here. How will manage this way, just fast movement this way, so at all no bleeding will be there.
Sir, some people used to prefer this
So this is the
debrider.
upper pole basically. This is the periosteum will be there.
Right.
Here the periosteum will be there. So I will give the guarantee to the patient. So no chance of recurrence. But if you do without
If it is the
seeing the patient, there is a chance of recurrence.
if we leave the tissue behind, then definitely there is a
And also I prefer to supply the recording system also every patient.
excuse me, sir.
Hello?
Sir, some people prefer to do with the micro debrider.
Definitely I before
What is your
profession,
take on
I
this
used
thing?
also micro debrider.
Okay.
But micro debrider is in case of small children sometimes very difficult. Sometimes I have faced also nasal syneca because the repeatedly putting the endoscope nasal and bleeding, packing, headache. But here no headache.
Sir, like
Population
in,
tonsillectomy 2 minutes time
Sir,
and here the only 15 minutes time. And absolutely fine. Patient same after 3-4 hours patient absolutely fine.
so I think different tools, different mechanism, and different advantages also. Like in the coabulator assisted and adenoidectomy, charring is there. So there could be
The
chances of bleeding
problem
later
is
on.
if you go first curettage, then you just allow the microdebrider, then you just allow the coblation,
Right.
then you realize what is the best. Otherwise, some people only doing the microdebrider, they will tell the micro is the best.
Some people using both tools together also, sir. Some people do the debulking with the micro debrider, and after that, that base layer just above the fascia, they are dealing that part with the
That also
this
possible, but
debrider.
why not
Yes,
from
yes.
very beginning, no?
Yes.
Unnecessary bleeding, and also that is not a demonstration case, no? If
Yeah,
you do
totally
this
agreed
type,
with that. One
this
thing
is
I
not a
just want,
demonstrable.
one thing I just want to ask about this charring and
Sorry,
post-op
what is the
bleeding.
problem, sir? Post-operative bleeding in case of adenoid, I have never seen.
Okay,
Sometimes
okay.
it's very, very rare, sir.
Right,
Sometimes
right.
definitely in tonsil possible,
Yes.
but you should learn the technique. Automatically, it will be
There is
reduced.
chances, but with the expert hands, with the experience, it will not happen. Yes.
But headache free. I do regular adenoid basically. This is a headache free surgery, no?
So there is a question from the audience. You're
Look
telling
here, the
that.
periosteal sheath also will be seen properly.
Hello,
So, hello.
sir. There is a question from the audience. As you are dealing with both the tools, did you find any difference of the pain post-operatively?
Same question asked from one in railway hospital when I have done this surgery. Dipankar Da, now is very close to me. Dipankar Da. Question from audience. Tushar, if you anyone asks here the curettage and microdebrider and coblation. You grade the marks. So I told at the time microdebrider is 8 and coblation is the 10. Because the advantage, if I ask the patient, you just I will do this way, the surgery, light off so I do this way, I do the surgery and I will show the microdebrider surgery. Definitely patient will adopt also, and if you learn the technology, then you love the surgery. No doubt about it. Because the
Agreed with your point, sir. But
my assistant always suck the water from, because I will prefer. Please suction karo oral cavity.
So what I think, sir, if we dealing with the microdebrider or whatever with the coblator, if we are doing the adenoidectomy, there is no much difference in the pain. If we are doing the tonsillectomy, definitely it would be a great difference.
Sir, basically in adenoid,
Yes.
if you do microdebrider, if you do coblation, if you do curate,
Right.
only curate there is a chance of pain because the pharyngeal injury will be there, oropharynx.
Despite of injury,
Otherwise no pain at all with the
Exactly.
coblation also.
Even with the debrider, there is no pain because that adenoid area, that nasopharynx is going to rest after the surgery. If we dealing with the tonsillectomy, so that area has a continuously movement is there.
I will
Yes.
show the technique how the pain will be reduced because the intracapsular here, if you any point bleeding, no, encounter that point also. See how beautiful technology. You will remove the all tissue, all from all area. This is the perimycial sheath and beautiful. So it is very difficult to do with the coblation also. Microdebrider also.
Microdebrider also,
And if you
yes.
do try to microdebrider, definitely I have done the microdebrider. So this is the also the bleeding will be there. Lot of bleeding. Sometimes diathermy required also. But
And
if
you have to stop in between. This
but
is
if
the
you
like
technique-
continuously you
how?
can do.
This is the
yes.
lateral margin. Okay, this is the fossa of original molar margin. Okay, how will you manage? You say press it, press it, press it, and press it, and you will see. Another technique is the if you take the angle endoscope, that is possible also.
Okay.
Otherwise just save the some area, save this area, and you will see the some adenoid tissue in the fossa of original molar area. Okay. Okay. This way. So this is a possible, no? You see the how beautiful. কি করছো সবই না দেখি মারছো আন্দাজে না স্যার মানে আরে তুমি পেটে জল ওরোফেরিক্স জলটা অফ করো না হ্যাঁ তো ভর্তি তো জল ইউ সি this is the most inferior margin, okay? This is a passavans ridge, okay? And here you see the muscle is there, so pharyngeal muscle will be there, so slight bit of movement will be there. So you should be careful and also ask the anesthetist patient's light or not.
Also, until unless we injured the muscle,
So
there
you
would be
see
no
if-
post-operative pain.
You see post-operative pain, sometimes if you injure the
Sir, screen is gone.
sheath, yes, sheath, then there is a chance of post-operative pain. The neck pain will be there. Here the sheath is there, okay? So
Right,
if
right,
you
right.
see the sheath, just slight bit of tissue, just leave. Otherwise, the unnecessary pain will be there, okay? So any bleeding, if you see, just see no coagulation,
Hello?
only ablation, okay?
Hello?
You see.
Sir, we are having the screen issues.
Hello? Question?
Hello? Hello?
Hello?
Sir, we are having the screen issues.
Again?
Yes.
কি ব্যাপার বলো তো আমার কপালটা খারাপ হয়েছে।
No, you are also not visible.
এই আবার স্ক্রিনে কি হলো এরকম করলে কি করে হবে এই স্যারের একটা টিম প্রমোস্টার রেডি রাখবে না এইগুলো ফোনগুলো সরাও তো এখান থেকে তাহলে ওই নাও ক্লিয়ার পিকচার you see the perimycial sheath, okay, the extreme posterior, okay? So here ছবি আছে পিকচার
Yeah, we are getting the picture.
okay no so you see so all tissue removed and this is the institution tube, okay? And sometimes if you just young adult, you just remove this portion also. Otherwise sometimes up young age there is a chance of snoring. And this part of that. You see, so this is the periosteal area and beautifully. এই জলটা কমাও তো, খুব জল বেরোচ্ছে আর পারছে না ছবি। Now you see the, okay, so 100% removal of the adenoid, okay?
Right, sir.
Huh? Oh, limit. So it is the upper margin, upper pole. You look here. Now secretion coming out from the sinus cavity. So lot of patients, the sinusitis, if you do CT scan, then you will see the maxillary sinusitis, phenositis. Don't believe the sinusitis, please. Just see the endoscopy. You will see the adenoid is there. So encounter the adenoid. All children sinusitis will be reduced, and give the good spray. All draining system now active. Look here.
Sir,
So this
if
is my experience.
sir,
Every day I am doing adenoid. Every day I am doing endoscopy.
excuse me,
Hello?
sir.
Okay, sir.
Sometime we encountered the patient. They are getting the scan done. CT
But
pain is,
I asked
and,
the patient, please don't believe the sinusitis.
yeah,
Please
exactly.
believe
All
the
sinuses
adenoid.
is filled up.
So
I think-
so I do adenoidectomy and I ask the patient, give the good spray, good wash, few days, few
Yeah.
more days, and all will be okay.
Yes.
And only thick polyp and young adults. Sometimes also I open, but I have shown also nothing is there. In front of a lot of doctors, patients also I have shown this.
I don't
Look here, this is the cavity. So this is the upper pole. Okay, this is the inferior, this is the lateral. The first, this is the lateral. So every corner. So there is no chance of again recurrence of this adenoid. Okay, so you'll be happy, no, after doing this surgery, and you will be more confident that there is no again return of this patient. All tissue. See, focus.
Sir,
Okay,
this adenectomy with coblation can be done in daycare only?
Daycare, all daycare, sir.
All daycare. Okay.
Oh, my all surgery daycare except parotid and thyroid.
Okay, sir.
Also face surgery also daycare.
And
Look here, the movement.
what would be
So
the
muscle
post-op
is there,
management,
so
sir?
movement is there. So you should careful.
Hello,
Now this is the inferior pole, this is the
Hello.
upper pole, this is the lateral. Okay, sir.
sir. There is a
The
question
posture.
from the audience.
Yes,
Hello.
sir. Yes, yes.
Sir,
Yes, sir.
what would be the post-op management of
Post-op
this
management?
certificate? Yes, sir.
Sir, post-op nasal wash, iodine type, and
Oh,
also
any
nasal
normal
type
saline.
wash
Okay,
and
sir.
spray
Okay, sir.
intranasal corticosteroid or momentazone and
Okay, sir.
anti-allergic and good nasal wash for
Yes.
few days because the slough exudate will be there for few days. Few days, at least 21 days, 1 month. I prefer the intranasal corticosteroid or momentazone for 1 month or 2 months.
And
And naso wash, sir?
Nasal wash, hypertonic nasal saline basically.
No, high.
not
How long you are giving the naso wash to these adenoids patients?
Hello, can't check kore diye. Hello.
How long you are prescribing this naso wash to
Nasal
post
wash,
adenoid?
1 month, sometimes 2 months also.
Okay.
If
Okay.
if patients don't wash properly, then is the problem.
Yeah,
Nasal
definitely crusting will be
secretion,
there and there are
crusting,
chances
yes.
of bleeding also
Basically,
there.
moist crusting will be there. So adenoid bleeding is less, but in tonsil, so definitely there is a chance of bleeding. In case of adult, is very much. In case patient notes.
So one question is from the audience.
Hello, sir. Do you advocate nasal sprays containing azelastine or like that? Does that help in
No,
post-op
no.
period?
No, any clear cut. Clear
Hello?
cut, patient notes. Yes, sir. My ring
Azelastine nasal spray. Do you advocate in post-operative period?
No. No, Agilestrin I less prefer. In case of allergy rhinitis, for few days only I prefer. My government nahi.
sir,
Shift karo dao camera.
should we start the mometazone or fluticasone spray from day 1, post-op day 1?
Please speak in loud.
Sir, he's asking about whether we have to start Momentus on post-operate day 1 or we have to wait a bit for to start the steroids.
Hello, steroid,
Hello.
oral steroid.
No.
No.
Topical steroid he's asking
Ebil tolo.
whether we have to start post-op day 1 or we have to wait a bit
After 2 to 3, ekbar.
after 2-3 days.
After
Okay.
2 to 3 days basically.
Okay.
But same day nasal drop is very important. Tolo. Same day
Yes,
nasal
yes,
drop
yeah.
is
Next
very
question,
important.
sir.
Same day.
And Sir, should we do audiometry test in all cases of adenoid
কিছু নেই বেশি
enlargement?
পুশ
Hello.
হ্যালো হ্যালো
Sir, there is a question from the audience.
হ্যাঁ
Did you get a audiometry test to all the adenoids patient or have some specific
not all
presentation?
basically if patient complain and if suspected OME then definitely audiometry temperametry.
Okay. So these what you are putting gel foam, I think, huh?
এই শোনো ওটা ওই কানটা
Merosil.
না দেখতে পারলে
So these are soaked in.
হ্যালো
Hello.
হ্যালো
So what you had put in the intranasal packing, sir? This is Merosil or gel foam? What?
Can you hear me?
ইন্টারনেজাল
Hello?
Intranasal packing you are doing, na?
Can you hear me?
ও ইয়া ওখানে
Hello. I think mic is shifted to other OT.
বাবা লাগছে ওখানে
On air, on air.
কর না এই স্যারকে
হ্যাঁ।
মাইকটা শিফট কর
Hello?
Hello.
I think now you can hear me, isn't it?
Yes, sir.
See, this is a solution which is 30 ml of saline
Okay.
with around 5 ampules of adrenaline, which has been put inside that. Ye lights up off kar dena beta.
Okay.
So this basically we are planning a endonasal DCR. Yeah.
Right side endo TCR.
Yes.
Yes.
So I'll be starting that. Injection, please.
So, sir, in which cases we have to prefer to do the endo DCR? What was the indication in this patient?
No, I would basically do endo DCR in almost everybody now. Very rare case where you would do external DCR anymore now.
Okay.
Most of it is replaced by endo DCR. ये suction काम कर रहा है क्या बेटा? No, I think it's not working. No.
So we are seeing the endoscopic intranasal picture.
Yes.
So this is a middle turbinate with the axilla and higher DNS is there. And uncinate process we are seeing very beautifully.
Yeah, and you can see the axilla here.
Yeah.
So I'll first inject a little bit.
এটা সাপোর্ট দিচ্ছে না তাহলে আমার দরকার নেই
Suction is not, it's not
চেক
working
করো
that
তুমি, নাহলে তো
much.
মুশকিল আছে তাহলে তো এই
Working now, it's working, yeah. Working. अभी on है हाँ. Give me the.
এই চন্দন ভাই স্যার আচ্ছা ইয়ে করে দাও স্যারকে একটু ইয়ে করে
Some noise we're getting.
এই স্যারের
Hello.
এই
This is my first injection
হ্যাঁ ওটা হয়ে গেছে
above the axilla.
আপনার টিমপ্লোমাসকে প্রথম দিচ্ছি পরের দিকে স্টেপিস করবেন
This is the second injection here in the middle part of the.
থ্রি ফ্ল্যাপ আর একটা স্টেপিস স্যারকে ফুল দিয়েছে
And this would be the.
হ্যাঁ এই স্যারকে না
Inferior turbinate
ফুল একটা নিয়ে
injection.
আমি দেবো
Yeah. Mirocell, please squeeze it well. Or maybe
Sir,
we'll use
can I
ribbon
take
gauze
notes?
only,
Amar
cut
has
it
to
into
take
small
notes.
pieces. Yeah. No.
কোন স্যার
Yeah. Hello.
Hello.
Can you hear me?
Yes. We are.
I just
Hearing
completed the injections.
স্যার কি আপনি প্রথম
Okay.
স্টেপিস
Just one above the axilla and
স্যার আপনি একটু আসুন না
yes, bus.
ছবি তুলে দাও না
Now what we'll do is give me a scissor. Maybe this
স্যার লোকাল প্রেফার করেন নাকি
Chili-
প্রেফার করেন
Mirocell is a brand which is very good. Mirocell on the softer side.
লোকাল যে কোনো
Sir, your voice is breaking. What you are talking about?
Yeah, I mean among the packing materials,
Okay.
I would prefer net cell.
Okay.
Net cell. Mirocell is also okay, but the only thing is Mirocell is
ওকে স্যার
little more softer than usual, so may not give you the amount of tamponade
হ্যাঁ ওই হাফ আরেকটা হয় না খুব
that
ঝামেলা।
it should
নয়
give.
নাহলে ফুল দিয়ে और একদম ওই পেছনে
হ্যাঁ?
গান দিয়ে
You can hear me now?
Yes, sir.
Yeah. I think I'll just wait for a couple.
আমরাও লোকালি আমরা লোকালি কনফারেন্স জন্য
To act.
দুটো কান একসাথে করে দিলে আবার জিয়ে করে দিই, এটা যেমন দুটো কান করে দিই।
15 knife I want, Sister, 15 knife.
একসঙ্গে এক সিটিং করে দিই, সেটা বোঝালাম।
Audio visual, can you please shift mic to 1 OT?
প্রথম হেজিটেশন হতো, প্রথম হেজিটেশন হতো, এখন
Hello?
10 বছর ধরে করে যাচ্ছে।
I think, yeah.
10-12 বছর।
There is some bit disturbance
Some
from the other
disturbance, I
audio.
think,
Yes,
OT
yes.
में,
বলে দুটো কান করব।
OT में ऑडियो ऑफ करना,
নাহলে হেডেক আর ওই ঘোরানো
उधर से ऑडियो भी आ रहा है। 15 knife. I'll be starting with the first incision, a horizontal incision at the upper border of the
Inferior turbinate.
turbinate,
Yes.
tilted slightly at a 15-degree angle,
Okay.
like this. Okay? Now I'll go up. Parallel to the first.
Okay.
The third one exactly at the upper
Axilla.
border of the axilla.
Right.
Okay?
Right, sir.
You can see this. Another horizontal incision. Keep the circular knife ready. Okay?
Yes.
Now the most important incision will be roughly about 8 millimeters to 1 centimeter above the axilla with a slightly downward slope like this. Okay? Am I audible?
Yes, sir. You are audible, sir.
Yeah.
Nicely clear also.
Yes.
Excuse
You can
me.
put these knife, incisions with cautery knife also.
Excuse me, sir.
Yes.
Sir, there is a question from the audience. There is a request from the audience. Actually, this technique is new. You are taking some mucosal flap. They want to repeat it. Can you please, sir?
Yeah. Ribbon gauze pieces are here, na? Yes, sir. Dena. See, basically, you can do this using the cautery knife also.
Okay.
It will look very good on the table because it will be bloodless compared to this technique which will bleed a little bit initially. But the healing always with cold steel is far better.
There is a
Then-
filling also, sir. Surgeon's filling.
Yes. Yes,
He
so,
is dealing with the blood.
yes. Another, basically I put new 50, I put 4 incisions.
Okay.
The first incision, as I showed you, is at the upper border of the inferior turbinate.
Right, sir.
The second incision about 3 millimeters horizontal above that.
Mm-hmm.
The third one is at the axilla of the middle turbinate. And the fourth one is 8 millimeters to 1 centimeter above the third incision.
Yes.
The lowermost incision you always hit 15-degree upwards. The uppermost incision tilted 15 degree.
Downward.
And most important, you put the inferior incision first.
Okay.
So that way the blood from the upper incision
Is
won't
going
trickle
down
onto
also.
your
Not interrupting the
operated
field.
side. Yes. 30-degree scope hai? 30-degree scope le lo, sister. It should come about maybe 5 millimeters. Or maybe you can come up to 1 centimeter. You can see the incisions.
Yes.
Yes.
So, sir, is there any advantages of all these incisions? You're taking the
You will
mucosal
see this,
strip.
you will see this now
yes.
shortly.
Yeah, actually.
You will see the advantage of these things.
uh,
Now see, with a circular knife, I am palpating the uncinate here
right.
and I am putting an incision here.
Just interior to the.
Yes, at the junction of the uncinate process and the ascending process of maxilla.
Right. So you are just elevating the middle strip, huh?
15 knife. The other thing I am going to do, all
Yes, your voice is breaking. Hello? Hello? Yes, your audio is not.
yeah,
Hello?
ribbon gauze dena beta.
Hello?
Hello,
Sir, actually, your voice was not
hello.
clear in between. Hello?
Can you hear me now?
Yeah, now we can hear you, sir.
But in between, I think it keeps going.
Yes, yes. So I
Yes.
think this is the new technique for everyone. Everyone wants to hear from you only.
Yes, yes.
So we can't miss anything from you.
Yeah, yeah. 1 minute. I'm just packing that area, and now I'll elevate the flaps. Okay?
Right, sir?
See, this can be done even by using your endoscopic scissors.
Okay.
The only problem with the endoscopic scissors is after a few cases it gets blunt, and it is a fairly expensive instrument. So if you can use a 15 blade and later 11 blade and a 12 blade, those blades are very economical, and you can all take another one. Now, yeah, elevator, 30-degree scope is there? Yeah, for I think better demonstration, I'll try to use a degree.
Okay. Excuse me, sir. Sir, there is a question from the audience.
Yeah,
They want to ask whether this patient required. This patient already has a higher DNS. Is there any need to do the SMR in this case?
let us see.
Okay.
If the space is a little constrained,
Also, with the
There is-
experience, I think there is a least invasive surgery.
no, better if wherever you feel,
Okay.
you know, the septum is coming in your way, you can always do an SMR, nothing
Right.
wrong in it.
Right.
In this case, I have a feeling maybe I will get away without doing that. Let us see.
Right, sir.
At any point of time, if I don't, circular knife please, then I may go ahead and do an SMR. Can you see this middle flap? Hello?
Yes, sir. Yes, you're audible, sir.
Straight as per. So I am taking out
Yeah, I think suction elevator, curved suction elevator is there.
Yeah, give me the endoscopic scissor if you have. You have this, okay, fine. So I'm just straight grasper. ये सलाइन में रख देना सिस्टर देखो फ्लैप सलाइन में रखो एंड में काम आएगा. So you can see I have removed the middle flap.
Middle flap. Yes.
Hello? Hello?
Hello, hello.
Can you hear me?
Yes, sir.
Circular knife. See the middle flap?
You already removed, sir.
Yes. Now what I will do is elevate the
Inferior flap.
lower flap. Okay? Can you see this?
Right, sir.
It goes away from me now, and again similarly elevate upper flap.
Okay.
And this upper flap also goes away from us. Okay?
Right, sir.
Mirocell, please. Or you can give me the ribbon gauze. Dressing for forceps. Yeah, call it till is okay, right? Which is the correct way of naming it. Suction. Looks like she has a this patient has a very thick bony structure. You can see this is the uncinate and this small bone is the lacrimal bone.
Yes.
Can you see this narrow bone here?
Yes, sir.
This is the lacrimal bone.
Right.
This is the frontal process maxilla which has to go. Right? So I think we are kind of with our area of bone removal. DCR punch.
So, sir, what do you prefer, punch or drill?
I mean, if you have to drill, nothing like it.
Okay.
But drills are going to be expensive.
Right.
I think the first inferior bite I took now, you can see this. Just palpate the sac, you can see the movement of the
Exactly, sir.
duct.
Beautifully it is coming out.
So once you do that, ball probe, free waiter, yeah. Now what you can do, and flake this lacrimal bone. Okay?
Okay.
Basically, if you can create
Hello? Hello?
yes,
Yes, sir. Voice was missing in between.
yeah, give me the Tilly's forceps. Which
So, sir, you are going to remove this whole ligrimer crest, huh?
yes,
So,
The
what we can
frontal
say, what is
process
the
of
good
maxilla.
adequate exposure of,
yes. Dressing forceps. See, go in and out, you should go at least about 8 to 12 millimeters.
okay,
Please forceps, sister. Because the majority of the failures occur if you don't expose the sac,
right,
the fundus. Many times as beginners we end up exposing only the so if you can create a fracture line like this, straight
spontaneously it is
plexually
coming
or
out.
Tillis, yeah. This is another technique I picked up from Satish Jain.
Out fracturing
You
the,
try to
yes.
give a rotation to your bone punch.
Okay.
Chahiye dena, sister.
Hello.
Yes.
Sir, there is a
Bone
question
punch.
from the audience is that patient is gender is female because bone is very easily coming out.
Yes.
Okay, one is the another good factor.
ये क्लीन करना इसमें हड्डी है. ये छोटा है. Ultimately, the very hard.
Yeah,
You can
as
al-
we go anteriorly, bone is getting hard. Yeah.
But the most important thing is expose the well. And widely, bone punch देना पुराना वाला. So, yes. Bone punch. थोड़ा बड़ा बोन पंच है और now see the ball probe. Hello.
Hello.
Bo-
Your voice is breaking, sir. Not clear.
Yes.
Hello.
Nine. Yeah. Straight Beckesley है. Can give me that.
Now I think all of the lacrimal sac is
Yes.
exposed. Yes.
The big chunk of bone came in. It is going to bleed a little for a short while. We need to keep a pack and wait.
Yeah.
Otherwise, you can see all the way up to the upper border of the turbinate. It is open.
Yes.
Ribbon gauze, please. Or I think I would prefer a ribbon gauze now. Yeah. But anyway, even with the mirror cell, it has stopped. We'll wait for just. See, the key to a successful nasolacrimal surgery is adequate bone removal.
Okay.
आप probe सकते हो, you can do the probing, yeah, okay. Then
So
probably we'll
adequate
do
means you're dealing about 1.5
at least
centimeter.
1.5 centimeter
Yes,
by
yes,
1
yes.
centimeter.
As such, there is a defined limit to removal of the bone superiorly, like inferiorly you did up to the inferior trephinate.
Superior is the important thing.
Yes.
Inferior is up to the upper border of the
Inferior trephinate.
turbinate.
And superiorly up to the axilla.
Yes. Dress. Give me the mirror cell sponge now. Let me see. Yes, yes. In the meantime, I'll ask my associate to probing. You can do the probing. Done with surgery. This sister. Give me the 0 degree. Yeah. You do a probing, no problem. That will tell us how much
Can you focus the camera, please?
Yeah. Yeah.
Sir, that
Suction.
probing can we see on the screen, sir?
1 minute, huh?
Yeah.
Probing is done. No, you have to direct it downwards. Always. No, wait. You put the probe. I'll tell you just 1 minute. Dressing forceps. Wait. I will tell you something. 1 minute. You have a lacrimal stent here or whatever. Do you do stenting? No.
So what is your take, sir? Stenting.
I mean, I stent in all cases.
All cases, okay.
Because that keeps me away from the cringing.
Okay.
You know, yes. Suction, please. Suction hai? Bone punch. Yes, I think my sac exposure is almost complete.
Yes.
Bone punch. I think we'll see the probing later. Keep it pressed. Oh,
This part of bone removal is a bit difficult, actually. Yeah.
trying to get a little wider exposure of the sac. I'm happy with the superior exposure. Curved punch, please. Can you appreciate the exposure?
Yes, it's very nice exposure.
Yeah.
Coming.
Now we will just take away a little bit more here.
So you will get the interior component also.
Yes. That way. Bone punch. Curved, yes. I am quite happy with my exposure now. I think if I can take away a small sliver of bone here and a small sliver little above, I am quite happy with my exposure.
Yeah, interior wall is also a good exposure.
Yes.
Yeah.
Yeah, looks pretty good. Ball probe, please. I'll get this inferior flap away from me. Yes, and maybe, yeah, even here it is almost well exposed. Maybe the small sliver I'll try to take out, that should be it. One punch, curved one. Curved punch, and then we'll use a 12 blade to incise it. Yes. Bone punch. Now I'm quite happy with the part of my exposure. Tilly's forceps ma. Or ball probe. Suction. Now you give me 2 pieces of ribbon gauze for one final before I incise this sac. Yes. Very good. You hear me?
I think there is some audio visual issues.
No problem. Aram se change. One more mirror cell, please. Lacrimal stent है? Stent है तो stent निकाल के रखो. Ball probe. Stent है. Okay. Dressing forceps. Tilly's देना. And yes. Yes, ball
But
probe.
in case of if arrow, sac or pass is not coming,
Yes.
so at that case definitely we put the stent.
Ball probe. अच्छा वो ये थे ना number 12 blade थे ना yes no already it is done. Now the sac is nicely marsupialized also. You can see the yes number 12 blade yes. उसके बाद 11 देना. Okay. Okay.
Hello.
Okay. What I do,
Hello.
one horizontal
Hello.
incision
Hello.
like this, one more incision here, so that this falls like
Hello.
this
Hello.
on the bone.
Hello.
Sister, number 11 blade. And then with the number 11 blade, what we do is give it a horizontal incision here, like this, and one more away from here, Okay. This all goes away very comfortably. See now the entire medial wall you can see
Yes.
nicely marsupialized. Ball probe. stent.
Hello, hello, hello.
Stent. You can put the stent. So that I don't need to syringe for 6 weeks. You can take off the stent.
Hello.
Okay.
Hello.
Yeah, hello.
Sir, can we focus on the
Yeah.
you're
Can
doing
you
the
hear me?
syringing or you're
Yeah.
putting the cannula, na? Yeah.
No, it is there. You want top light? Very good. You are getting the picture?
Yes, now we are getting it. So this syringing technique is also important, the movement of instrumentation or cannula.
Direct it towards the nasal spine. Direct it towards the nasal spine. Yeah. Got it? Yeah, wait. Now, yeah, your direction.
We're not
should
getting
be
the picture, sir.
Yeah, one
Yeah.
minute.
Yeah.
Take off your hand. Oh, it has come here.
Yeah,
Can you
it is
see?
already in.
Yeah, pull it a little backwards. Little. Give me a
Yeah.
mosquito. Can you see that?
Yes, yes.
Yeah. Oh yeah, this is stuck. No. This is okay. This is the perfect one. 1 minute. Don't move anything. Don't move it. नहीं, stent क्या है उधर stuck हो गया. Remove that. Yeah, you have to because it's not coming. This is not a. Forget the stent. Take out the stent. So I think if we can do syringing, that should be more than enough now. Maybe you can put the same stent from the upper punctum and see whether even that is patent. Ball probe. So the important thing is that you should have exposed the sac about 3 to 4 millimeters above the level of the
Exactly.
common canaliculus. That is the one which determines that you have opened the fundus of the sac and not the nasolacrimal duct. He did the probing beautifully last time. I'll ask him to now put it through the upper punctum. I think you can get the case ready that side. Yeah.
Thank you, sir. Very, very nice demonstration.
No, I'll just
Once
put
you
back
put the cannula, then we definitely come back to the screen.
Yeah. See, can
Yeah,
you see
it's
this?
already there, sir. Yeah.
Okay.
This is from the upper punctum, huh?
Upper punctum.
Yes.
It's coming in very easily. The exposure is above that. You can
Right,
see
sir.
the two flaps, one going posteriorly very comfortably, not falling back, the other one anteriorly on the bony wall. Now two more things that I will do. Ball probe. Take it out now. Yeah. And if this is passed, then there is no need to do the syringing. Now see the upper flap. It comes and sits over the bone.
Okay.
Can you see that?
Yes.
See here. Right?
Right, sir.
And it won't close on your sac. It's like a box. Hello?
Hello. Yes.
Yeah, can you hear me?
Yes.
And see, this is the lower flap.
Okay.
This is coming back and again sitting on the bone. So it becomes, the bone won't granulate. Sister, वो saline में रखा था ना वो piece, वो दे देना. Remember the middle flap which I had removed. Okay?
Okay, sir. Middle flap you are going to put at the same point, huh?
And not at the same point, but on the raw bone
Okay.
which I have kept exposed. You can see here.
Yeah.
Okay?
Right, sir.
This way what happens, there is no bare bone exposed, no
Okay.
granulations, no fibrosis. You can see a nice square window there in which you have your nasolacrimal duct and the sac open
Exposed.
nicely.
Open.
Right?
Yes, sir.
Thank you.
Thank you, sir. Thank you so much, sir. Very, very beautiful
You can do.
demonstration.
Why did you do syringing? अरे करो रे. इतना ही क्या वो assistant so that
Any question from the audience?
ball probe.
Sir, there is a question from the audience.
Yes.
Can you
Hello, Dr. Holdipur.
Yes.
If you place the stent,
Yes.
then these elastic tubes should be tied so that in the medial canthus a loop will remain.
Yeah. I put about 8 knots. Yeah. Wash. Yes, you can see the wash coming in there. Doing the syringing. Hello. Bas, I think. It's good. I think. You can see there's no bleeding as well.
Sir, there is a question from the audience.
Yeah. Sponge.
Sir, what we used to do, we
Yes.
just raise a flap from which begins from above axilla
Yeah.
and up to the inferior terminate, just
Yeah.
above the inferior terminate,
Yes.
and we raise it.
Yes.
And again, after expose the lacrimal sac,
Yeah.
then we again split it,
Yeah.
split the whole flap into
Yes.
two,
Yes.
and to cover up the raw bone,
Yeah.
raw exposed bone.
Yeah.
Just it is very new technique we have
Yeah,
seen.
that is also a good technique. You could see this is also a good technique.
Yes, sir.
This technique has given me consistently the results approximating an external DCR, which was the gold standard operation in nasolacrimal duct block.
So, sir, just one small question is there.
Yeah.
That audience already asked you that we already take a one flap and we did the split and later on put on the bare bone.
Yeah.
The both part of the flap they are still they are attached to the rest of the mucosa, but the technique you are showing in the mid part that mucosa you already taken out
Yeah.
is not any kind of blood supply. Is there any chance of that necrosis of part of the tissue or
No,
any
no,
aid?
no. See,
Because
bone,
already we
see,
devascularized that part.
Remember, bone has very good vascularity.
Okay, okay,
And this is a fresh, wet flap, mucosa,
okay.
and which was actually belonging there only.
Right, sir. Right.
Only
right,
thing
right,
is the horizontal thing I have rotated vertically
right.
and put it on the bone.
Okay.
And you see it after 1 week, everything would have got stuck very nicely. Only thing you have to remember is when you do suction cleaning or whatever in future,
Okay.
first 15 days you should see to it that you don't displace the flaps.
Right, sir.
Okay?
And, sir,
Okay, sir.
Thank
Okay.
you.
Sir, one more question is there.
Oh, no problem. Ask me
Sir,
two more.
when should I remove the Merosol pack?
I have not put a Merosol pack really.
And what would be the support of this?
I have just put one small anterior Merosol so that patient should not see the blood trickling.
Okay.
Okay.
Usually in this DCR procedure you don't pack.
Okay.
Oh, if there are any bleeders in and around, you always use some cautery or coagulation and stop it. But as you saw in this case, in the end there was hardly any bleeding. The whole thing was quite okay.
And
Right,
And
sir.
again, all the raw bone is covered with mucosa. So I think the healing should be good. There is no problem.
is the capillary action of the blood is enough for the flap to deposit in the same place?
What?
What if the support of this flap, this cut down flap,
Yes.
free mucosal flap?
See, two of them are pedicle flaps, the superior and inferior. Only the middle flap is a free flap, which I had kept it in the salon to put it back.
I am talking about this middle flap,
Yes.
Yes.
this separate
Middle
middle
flap,
flap.
yeah, it will take very nicely. By today evening itself, you will find it stuck nicely to the bone.
Okay.
Remember,
Uh,
only thing, Your sac should be well incised from top to below along its entire length,
Okay.
including the NLD up to the upper border of the inferior turbinate.
In marsupialization should
make
be a good way. Yes.
H-shaped, it is a horizontal H. So you make two horizontal incisions with number 12 blade on the anterior wall of the flap and two horizontal incision with 11 number blade posteriorly, so that the sac is nicely marsupialized.
Right.
And these mucosal flaps should now fall on the sac wall. So that way you are ensuring that the sac walls don't flow, fall back again. That is the thing.
Sir, there are a few articles over there. Use of mitomycin in, during.
See, mitomycin I used to use once upon a time.
Just want to
Even
ask your
even now I
experience and
use
your
it
take.
in cases where the sac is fibrotic.
Okay, like in the recurrent cases, you can say.
Yes, yes. But I think the trick is to have a stent, keep the stent for long time.
How long you
For
can?
example, in patients who undergo diode laser DCR
Okay,
by the ophthalmologist and then they come with a failure,
right, sir.
I found very bad fibrosis in the sac.
Okay.
In such patients, I keep the stent for something like 1 to 1.5 years.
So how long you usually advise to put this stent to prevent the recurrence or the fibrosis or?
Yeah. I actually put this stent regularly.
How long-
In
how long
fibrosis
you-
can keep it up to 18 months.
Okay.
1.5 years you can keep.
Okay.
But you have to see that every month you call the patient for a follow-up,
Right.
because one complication of the stent, you can give granulations around the stent.
Exactly.
So you have to keep on peeling off the granulations, put in a little bit of steroid or whatever.
Right, sir.
That's the only thing. Otherwise you can keep it for 1.5 years also.
Right, sir. Thank you, sir. Thank you so much, sir.
Right.
Sir, there is one more question. They are asking you for the post-operative protocol care, sir.
Post-op, if you have stented, then you call them for endoscopic cleaning
Right, sir.
on the 7th day, the 17th day, 27th day.
Okay.
You
after
remove
10
the
days
stent
interval.
on the 42nd day. That is
Okay.
exactly after 6 weeks.
Right, sir. Right.
If you have not stented, then you send it to the ophthalmologist for syringing on the 48 hours.
Okay.
And again syringing every 3 days for another 10 to 15 days.
Okay. Thank you, sir. Thank you so much, sir.
Yeah.
আচ্ছা এখানে অ্যানেস্থেটিস্টকে থাকতে হলো মাথাটা আমি ঘোরাচ্ছি
So now we are in the other OT.
Building
What is the
anesthetic
case?
এখানে একটু আমি ঘোরাচ্ছি মাথাটা একটু খুলে যেতে পারে
Hello. Hello. Audio visual, can you shift the mic to the other OT? So what is the case in this OT, sir? Hello.
Yes, hello.
We are audible, sir.
Hello, hello.
Hello.
Could you hear me?
Yes, sir. We are hearing you.
I am Dr. Rai Chaudhary, BK Rai
Sir,
Chaudhary.
good morning. Good morning. Good afternoon, sir.
I am now going to start my technique of tympanoplasty on three flap.
Okay.
Dr. Bidhan Chaudhary also is with me. He is helping me for this operation, and he has already taken the graft because I take the graft before I start the operation, and that graft is being dried up, and after after completion of elevation of three flaps and cleaning everything and inspection of the middle ear, ossicles and movement and everything, then I will put the graft and replace the three flaps. So this is my own technique. I am privileged. The Dr. Tushar Chaudhary, Tushar Ghosh, has invited me to do this surgery, because this is my technique I started long back, say in 90s, And I'm so glad that he has invited me here to do this technique. And if you are satisfied with this technique, you can take up or you may not.
Yeah, definitely,
And
sir.
one thing I should say that you can do it postorally, you can do it endorally. I usually do it endorally.
Okay.
And some people say that it is difficult to see the anterior part if there is an anterior overhang.
Okay.
That I agree, but the thing is that doesn't give any difficulty to me to elevate the anterior flaps.
Right,
And
sir.
if I don't know what will be here in my case today, and I will be glad to demonstrate my technique of T-flap tipronoplasty in this new OT of Dr. Tushar Ghosh, great Tushar
Great.
Ghosh. Thank you.
Right, sir. So what is the case, sir?
Yeah.
Perforation, CSM perforation status and PTA short history. Hello. Hello. Hello.
Yes.
Sir, should we know the brief clinical history of the patient?
Couldn't follow? Couldn't follow? I'm just cleaning the
Hello?
debris. Hello?
Okay, okay.
Yes.
The patient is 35-year-old male.
Okay.
He's come with the history of ear discharge, almost more than 2 years.
Okay.
Definitely was hearing loss. In this patient on audiogram we find the patient has a left side a mixed hearing loss. Some amount of nerve loss also there. The air bone conduction gap was 73.3 decibel. Right ear is normal, 25 decibel hearing loss.
Okay.
So we planned for left side
5
tympanoplasty.
decibel hearing loss is
And
not normal.
in this case, as you know, it's a mixed hearing loss. So we preoperatively counsel the patient. There will
Okay.
be no improvement in the sensorial component.
Sir, should we ask you what counseling you had done to the patient about the results, and because we encountered these patient and sometime patient didn't turn over to the surgery. So
See,
we are
the
very
patients
curious about
usually
it.
come with
What
the say ki we want hearing improvement.
Okay.
Means, I think in this case we say ki Bangla which is ki amader kane shonata barbe to. So we just explain with the audiogram. See the nerve loss will not be improved by the surgery.
Right.
And we just explain by the diagram also. Ki sir also shows that only the conductive part will increase.
Okay.
So the patient and also the ear discharge, the disease process, the primary target is the disease, ventilation and then the hearing.
Okay.
And we also convey in the next you have to use for the sensory component the hearing aid.
Mm-hmm.
That's
How the you ask the patient, just show the diagram. Okay. Just 1 minute. Just show the camera. Here. Look here. Now camera focused. Hello.
Yes,
See
yes,
the,
sir.
See the diagram. All time we explain this way. So here now you should normal hearing will 10 to 15 this way graft, but here the graft is there. So this portion not improve. We will improve this portion only.
Okay.
Always this way we have drawn basically and explain. This is the mixed hearing loss, or the mixed nerve loss will be there, but conductive loss definitely will improve. So after that patient if interested, a hearing aid also required if required.
So we can counsel that patient that you
Yes,
can
yes.
use hearing aids very properly
After that basically.
without any hesitation, without
Yes,
any
yes,
discharge or like
Yes,
something. Yes, yes.
So explain also drawing also. All
The-
time mention. Otherwise patients
Spirit
later on claim, as I used to, you ask the hearing will be improved. But we mention not improved properly.
Okay, okay. Right, sir. Good to know that,
Main
sir.
part of the practice. I believe counseling is the main part of practice.
Right, sir.
If you good counseling, then no problem at all after
Right,
surgery.
right, sir.
Actually, the tree-flap
Okay.
technique is ideal for subtotal perforations or near total perforations. But this case is having a white canal and a moderate size dry central perforation. So just for demonstration of T-flap technique, I will do T-flap in this case.
Right, sir.
Yeah.
Sir, sorry to interrupt you in between. Dr. Ghosh. Hello. Sir, there is a comment from the audience.
Yes.
If we do the tympanoplasty, like in these cases, it will prevent the further mixed hearing loss.
Yes, that is also important. No?
Okay,
we
okay,
explained to the
okay.
patient also.
That the conductive
if
part
you
we
want
already
the
covered up.
proper stay of this hearing,
Right.
definitely you should do the tympanoplasty also.
Right, sir.
কি বলছে?
ও স্যার আপনি ইচ্ছে করলে এটা
So,
বাড়িয়ে দিতে পারেন।
one, hello. Sir, one more thing I just want to ask. Like this patient is a 35-year, is the young male.
No.
If we encountered like a patient 60, 70,
No.
where the hearing aid
I
use
don't
is
think
more
so.
oftenly, so if we encounter the perforation in these patients, should we counsel and we go for the procedure?
Basically up to 75 years all time I counsel the patient about the surgery basically. I
Okay.
always mention the why unnecessary perforation will be there. No, we'll do the repair of the perforation.
Right.
And then if you choose the hearing aid trial also.
Exactly.
Sometimes some family okay, no sir, age is there. But
Okay.
I always try to make convince. Please do tympanoplasty, otherwise further loss will be there and discharge. Sometimes I
Right.
have seen a lot of patients, no, 85 years, 80 years of age, lot of
Yeah.
discharge. Sometimes the mastoid pathology also they are also not done surgery. So from at least 50 years of age he suffers. And then he told that some doctors told that how the boys
Yeah,
age,
this is the
age,
this
age
is the issue
there,
because
why? So when it
everybody is
will be
not
fixed?
doing.
No.
Because everybody is not doing, they get counsel done. There is no need for the surgery, and this will do something else and all that. All these things are there.
Yes.
Despite of this is a good message or good way of doing. One more thing I just want to ask: in which patient you do the tympanoplasty in the same way, like temporalis fascia in every kind of patient, or you suggest some cartilage tympanoplasty, like in the old patients, where the healing is a bit compromised?
No, basically in reperforation case and revision case, we prefer also cartilage tympanoplasty. Otherwise,
Okay.
all time we do
In old patients,
the graft tympanoplasty.
graft only. Okay.
Infiltration
Sometimes
yes,
graft
not
also, sometimes cartilage support also
Done.
we have given.
Invitation
Sometimes
yes,
in case of reperforation.
And
Right.
what about the size of perforation? If
please follow to
there
bring
is
the diploma.
total or subtotal perforation? Hello, sir.
Hello.
to pause in
Sir, there is a question from the audience.
Okay.
Sir, if there
Yes.
is total or subtotal perforation, graft will be enough? Is graft tympanoplasty?
Hello.
Hello.
Yes, question.
Moderate. I think it's the moderate.
Hello.
In case of total or subtotal perforation, that graft tympanoplasty would be enough, sir.
Oh, subtotal or total, we prefer the anterior-window technique tympanoplasty. Already I have shown the technique,
Okay.
no?
That one. Okay.
So all time big graft and all anterior wall, posterior wall, all total surrounds at least 350 area covered with the graft.
Okay, sir.
So no problem at all with subtotal or total. Same thing. Only in case of revision tympanoplasty, we prefer sometimes cartilage support. But if in our center, if revision, then definitely cartilage tympanoplasty, because we know that we have done good job. But
Okay.
others reperforation we prefer again graft placement.
Okay.
And also sometimes check also nasal nose also nasal endoscopy.
And
Preference nasal endoscopy.
what type of cartilage you prefer, sir?
Hello.
Hello?
What cartilage you prefer?
Tracheal cartilage,
Okay.
or sometimes conchal cartilage also.
Okay, sir.
But we prefer the end-roll incision like sir. Basically, we are follower of this legend. So
Still
end-roll in
yes.
Calcutta, I think a lot of surgeon following some all end-roll. In Bangalore or in Chennai also, I have seen some all are post-oral. Here also a lot of doctor prefer the post-oral. But anyway, I prefer the end-roll also. I don't know how. Sometimes some doctors mention how the manage, but I think the manage basically. Sometimes is in 100, 1 in 100 cases, sometimes anterior overhang and drilling required. Other is very less drilling required. Manage anyway. Manage.
And what is your vision about endoscopic tympanoplasty, sir?
Definitely endoscopy, no harm,
You see-
because I now mentioning the endoscopy mastectomy will be
Could you see?
definitely.
Yeah.
এখানে
Very interesting.
তুষার
Hello sir.
এটা একটু বলে দাও যে there is a pus collection or cyst here.
Yes, small
you see this?
collection. Sir,
Yeah,
you mentioned
fluid is
that your
looking like clear.
mic
It's
is
more
there,
over
sir.
towards the cyst.
Your mic, sir.
Yes.
Hello?
Hello.
Could you see there is a
Yes,
pus
yes.
collection, a cyst like that?
Yes.
In
It
the-
was more over the
This is
clear
the
fluid.
anterior,
Serious
this is
fluid. it was
inferior, this
coming
is
out.
superior, anterior and posterior.
Right, sir.
So I was going to remove the rim and the pus came out in a from a cystic swelling like this. Could you see this?
Yes, sir.
So you can see the anterior margin also in this case. And most of the cases you can't see the anterior margin with postoral, endoral incision. So with this you see I remove some portion of the mucous membrane underneath. You see a cystic granuloma here. Okay, ये दाओ तो cuff forceps টা दाओ. Could you see this?
Yes, sir.
This is just a granuloma.
Sir, how oftenly you encountered these kind of granulomas?
Pardon?
How oftenly you encountered these kind of granulomas? Because this is, I think,
কি জিজ্ঞেস করলো?
we are naive in this field, but I think this is the first time we have already seen that.
Probably this is for the first time I got it.
Yeah. We were thinking
Because-
we are totally naive and new in the field, so we
Yeah.
didn't saw that.
So for the first time I saw while I was just going
I
to
think audience-
remove the rim of the perforation.
Is the audience also first time?
Pus
sir?
came out from a granuloma and I have removed that. এটা দাও
Yes. It is
crocodile.
not already seen. Perforation now it is the subtotal perforation after the margin pressure.
You can do it posteriorly also if you like. You see, now the rim has come out all around. Only at this portion of. Could you see this?
Yes, yes.
Now it is completely removed.
Completely. Now it is the kind of subtotal or total perforation.
এটা একটু জল দাও তো এটা ব্লক হয়ে গেছে বিধান এটা ব্লক
Excuse me, sir.
yes
Sir, like in this case, now almost membrane is gone. We are not able to see any ossicles. So, do you planning for the ossiculoplasty or you just do the tympanoplasty and come out?
where here you are not seeing any ossicle
No, sir. I think view.
in
Yeah,
this
yeah.
case,
Now we can see. I think because of the angulation and tilting. Yes.
I will show you that this is malleus you see
Yes. Now we can see that. Yes.
this is the malleus okay could you
right.
see so I have removed the rim all around now I will give the incision for my 3 flaps এটাতে কাটবে হ্যাঁ so I will give one incision here the other incision in this left ear it is about say 11 o'clock
11 o'clock.
here it is about 1 o'clock
Okay.
then at 6 o'clock
Okay.
so 3 incisions I will be 10 নম্বর ব্লেডটা পাওয়া যাবে দাও তাই দাও 10 হলে ভালো হয় নাও দেখি না এটা যদি হয়ে যায় হ্যাঁ কি বলছো ফ্রেশ দাও, ফ্রেশ দাও। এটাও তো ভালো, টানছে না বিধান, এটাও সাকশন ভালো টানছে না। আর একটু ইয়ে দাও তো। দশটার মধ্যে দিয়েছে? ওকে, ওকে। So this is the first incision I am giving. These are vertical incision. One is 11 o'clock in the, this is the left ear, 11 o'clock here. Got it? And another incision here. Now at 6 o'clock another incision I will make. This is the granulomatous area. Could you see this?
Yes, sir.
Okay.
You're including the remnant part of the tympanic membrane into the flap.
Pardon?
You're including the remnant part of tympanic membrane into the flap. You're taking the incision of
No,
the remnant tympanic membrane also.
Side neck.
Yes.
কি জিজ্ঞেস করলো, কি বললো?
The incision is through the membrane annulus in the right.
Yes.
Yes.
You will have to cut it, otherwise flap would, it should be tympanomeatal flap, isn't it?
Right, sir.
So this is the first incision. I put this was the second incision. এবারে এ দাও, আগে না এটা। Now first I will elevate the superior flap.
Focus according to their comfortable, not according to us.
And that will be elevated from the tip of the handle of malleus.
Yes.
The chorotympani, actually the incision has been given in the 1 o'clock or 2 o'clock position, and in that position chorotympani may be there, but usually when you are cutting the, because I have cut the section, the remnant of the tympanic membrane only with the sharp knife, and rest of the work will be done in such a way so that chorotympani doesn't involved.
Sir, on the screen we are seeing some tympanosclerotic patch is there, just just about to your instrumentation. You're going to remove it, or we can just leave it? Is it the patch, or is the some
This one, this
yes,
one.
yes.
No, that is not the patch.
Okay,
This is
so
not the
some-
patch.
some
I'm
reflection
elevating
light
from the
reflection is there.
handle of malleus. You just see, because this is very important. টিউবটা দেখতে বলো, কারণ আমি মাথা নাড়াচ্ছি তো।
Sir, one thing just to ask, if suppose suppose there is a patch, tympanosclerotic patch, then you have to remove
I will
it, or
see
you
if
just
there is a
remove?
patch and I will remove it.
Yeah. Yes. Yes. If we remove the patch, then it should be removed. If it is removed, then we interrupt the flap vascularity also. We have to cut in between. Malleus.
You see choroidal nerve? Could you see? You can see choroidal, you can see the incus. The anterior malleolar fold. Could you see here?
Yes.
Anterior malleolar fold. So this is the most important flap, because to me this is the main flap for the blood supply of the tympanic membrane. তুষারকে আউট অফ এক্সাইটমেন্ট আমি তুষার চৌধুরী বলে ফেলেছি, ডোন্ট মাইন্ড। তুষার, তোমাকে তুষার চৌধুরী বলে ফেলেছি, কিছু মনে করো না।
Hello, sir. Actually, Chaudhary is a title offered to honorable people, so it is no harm.
Somebody was telling about the choroid tympani now. So I have elevated the superior flap, and I will show you the choroid tympani as well as the long process of incus. একটা নিডল দাও, একটা নিডল দাও, এটা দেখিয়ে দিই। So now you see, this is the handle of malleus. Hello, 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 could you hear me? Hello, audience.
Hello. Yes, sir. You are audible.
Yes.
Yeah.
And this is the incus.
Yes.
Incudostapedial joint.
Right, sir.
And you can see the movement of also, you see, it is moving,
Yes.
incus also moving. So we have seen the articular chain movement, it is intact, and here is the choroid tympani nerve. So most important flap is superior flap, which is already elevated. Now I will elevate the anterior flap.
I just want to ask the same thing. Hello. Hello.
Yes.
Sir, there is a question from the audience.
Yes.
What is the lateral limit of raising that flap? Up to which level you are
What
elevating
is the, what is the?
lateral limit of elevating these flaps?
This one, as much as actually 4 millimeter, 5 millimeter,
Okay.
even more than that,
Okay.
because we have got bony wall of 16 millimeters. Is that
Okay.
it?
Okay.
So much space is there. Now I am elevating the anterior flap, you see. This was the incision line. And
This is posterior flap, huh? Yeah.
this is the anterior flap I will be elevating now. Yes. And almost Blindly I do it. Is it clear now? Focus.
Yes.
Yes.
So bit focus is required, I think.
Yes. Pardon?
Bit of focus of required, I think. Microscope focus. Yeah.
Microscope is a very good microscope.
Need that kind of focus also.
Focus it. One must be very careful while elevating the anterior flap because it should remain intact along with the annulus. Remnant and annulus, I will show you after elevation. Nothing doing in a hurry.
If we use the endoscope, I think this is not would be the
Pardon?
blind. If we use the endoscope,
No, I don't.
yeah, it would not be the blind procedure then.
The reason is, in this age, I do not like to change my
Yeah. Yeah, that is okay, sir.
technique.
Yes.
Okay?
It should be in that way only.
So it is not possible for me. My students are doing.
Yes.
In Calcutta, I think one of my students, Dr. Dr. Gon, he is doing it. And he does very good in neural endoscopic.
With the same technique only, sir.
Pardon?
With the same technique endoscopically. 3 flap technique endoscopically.
This is my own technique.
No, you are talking about your that student. One of your.
He
student
also
is-
does it.
Okay. Okay.
So Busashi also does it.
Yes.
The 3 flap technique. And many of my students, they do it. The Bidan is with me, who is assisting me. He is also one of my students. He does it. And many other students do it. Now you see, the anterior flap is elevated. Even you can do it blindly. If you can see with the anterior overhang, you without removing the rim, you can elevate it. And after elevation, when this remnant to the annulus comes up, you can see and remove the rim. So that is another advantage of this technique. You see?
Right, sir.
So anterior flap also is being elevated now. This is the anterior flap. This is the annulus.
Right, sir.
Here's the annulus.
Yeah.
Until now, I have not seen any temporoclerotic plaque. So this is the removal of the margin of the rim of the perforation. So anterior flap is being elevated now. You see this one intact
So interior and the superior flap is already been raised. Huh?
So superior flap elevated,
Yes.
anterior flap
is
elevated.
raised, is
আমাকে একটু রুজিনটা দাও, so that anterior flapটা আমি ফেলে দেখিয়ে দিই. Now you look at the anterior flap, how it looks. You see, this is the anterior flap.
yes.
Now I put it back. Again I will elevate it before putting the graft. Though I do not do it, but just for demonstration, I am showing you. Now I will elevate the posterior flap. Is it focused?
Yes, sir.
Hello?
Yes, sir. It is focused, clearly seen.
Is it center? It is at the center?
Yes.
Okay, thank you. Now this one is the posterior flap margin. This is the easiest way and the most easy is the posterior flap elevation.
I think this is the most common raised flap in the tympanoplasty all over the world.
Yeah.
So that's why it seems to be easy. So I think all three flap raising is very easy for you also. So how long you are practicing this technique, sir?
Which one?
How long you are practicing this technique?
I couldn't follow.
Hello?
This one, since 1990.
Okay, since 1990, come on.
Yeah. This was published in probably 2000 ki 2002. In Indian Journal. So all the three flaps now I have elevated.
Yes.
I have inspected the ossicles, now ball put down. Now I will see the patency of the
Three-way.
this patent, you see?
Yes.
Yes, this is also patent. See?
Yes, sir. I think ball probe is the ideal instrument. I think it is made
Pardon?
for the ball probe is to ideal instrument to check the patency.
The ball probe.
Yes.
I passed the ball probe.
Yeah.
Oh.
His size is made up of.
You know, এবার এটা আমার উঠাই anterior flapটা এটা কি এত ছোট দিচ্ছ কি এত ছোট দিচ্ছ কেন বড়টাই একদম বড়টাও দিতে পারো
The endoscopic tympanoplasty. We just tilted and looked.
So you see this this is the posterior flap. This is the posterior flap.
Also plays an important role at their own time. Yes.
And this margin you can see now. If you leave behind some cuticular epithelium, you can remove it. Another advantage of this technique. Now I am elevating the anterior flap again. You see, such a big flap.
Right, sir.
Anterior flap. And I use a big flap, big graft, large graft. so that it lies. You can see the bone in the posterior wall.
Yeah.
This was the granulation. Let me clean it. Could you see the bony wall in
Yes.
the posterior part?
We can easily appreciate it, sir.
Audience, please.
Yes, sir.
This one.
Is clear.
And the granulation is still there. I will leave. छोटा मजा इटा दाओ तो. So that granulation would be cleaned. So all around it is like this. This is the granulation still lying here in the inferior part. So it is thoroughly cleaned. This is the superior flap. This is the anterior flap. This is the posterior flap. So happy with the flaps? Audience, please.
Hello. Sorry.
Are
sir.
you happy with the flaps?
Yes, sir.
Oh, sir.
Very happy, sir.
Now I will put the
We actually saw
Graft.
first time these 3 flaps and very happy for that.
and I will put the graft onto the handle of malleus. And here the handle of malleus will act like a cantilever. Now I have focused the handle of malleus. Could you see now handle of malleus?
Right, sir.
Yeah. Okay, এটা দাও আগে সার্কুলার নাইফটা মাঝে এটা so again you inspect this one. This is the incus, this is the malleus, this is the superior flap, this is the anterior flap. গ্রাফটা দাও Now I am putting the graft.
Initially thing was then tried tympanoplasty, try graft. Here should not
কি বললো সাকশনটা
everything is just like
ওটা দাও তো একটু পড়ে গেছে
already in the wind.
let me focus হচ্ছে না কেন আরেকটা দাও
Being trained yourself will be easy within the couple of years or couple of months. See, sir is more comfortable with this technique. Nowadays people are using endoscope and they are doing it.
graft has been put first on the anterior wall. Onto the handle of malleus. Suctionটা now spread it out. onto the wall, anterior wall. And under the malleus. All around.
I think in this technique we have to take graft very cautiously. The size of graft is very important. If it is too big, then it is crumbled up.
Focus cover.
It didn't come. Yeah. Yes. No, like in other techniques, if graft is big, then we can push it a bit posteriorly. So there is no point. There is like if we didn't cut it, then always it is okay. We can push it a bit posteriorly. But in this case, I think we have to be very cautious about the size of the graft. Otherwise, it is.
Is it clear?
Yeah, sir, it is clear, sir.
Can you see the graft clearly?
Yes. I think this is the most amazing thing.
This is the most important part of the anterior superior part.
Right.
And the graft has been put onto the handle of malleus and the short process of malleus. And anteriorly it has been put onto the anterior wall. Now I will replace the flaps one by one. The anterior flap first. Can you see the anterior flap?
Yes, sir.
This is such a big anterior flap. This will be lying onto the graft, and this is the superior flap. Would you see?
Yes,
Would
sir.
you see the superior flap?
Yes, sir. Yes.
Audience?
Yes, sir. It
Would
is
you see the
visible.
superior flap?
Right, sir. Yes.
আমি একটু মাথাটা নাড়াবো। Now I will put the graft onto the posterior wall. Needle-টা দাও।
It's very complex thing, man.
I will have to put it again. Just come out here. এটা দাও রুজিন Now this is the posterior wall
Posterior
lying
flap.
onto the bone. See?
Yes, sir.
And this is the posterior flap.
Right.
Just look at this. Falling onto the
Great, sir.
graft. You see, have you seen this?
Right, sir.
So there is 360-degree coverage of the flap onto the graft all around. You see? And this is the air in the middle ear that you are seeing the blowing of graft. Can you see all around?
Yes, sir. It's very, very beautiful, sir.
So all the 3 flaps now put down, lying onto the graft, covering the graft all around and 360 degree. Huh? দাও কটন বল একটা দাও দিয়েছো So just to see and show you, let me clean this.
Yeah, just do the suctioning only. Yeah. Yes, it's perfect, man.
So this is 3-flap tympanoplasty.
This is the most amazing thing happened today, and
Now you see
I think every
make out-
ENT surgeon should see this technique and have to do that before think that they are the master of the tympanoplasty. I think this is the masterpiece.
because all around the graft is lying onto the bone.
Yes.
And you have put the graft onto the put the flaps onto the graft.
I think you need
And the
good
proof-
applause for that, sir.
Pardon? And I will show you, because I have not put any gel foam into the middle ear.
Yes.
After tulo dao. I will show you how the graft has just blown up a little bit. That proves that eustachian tube is patent. I will show you that because I can see a little bit of graft which is not covered by the flaps. Here in the anterosuperior part. Could you see this?
Yes.
Needle down.
I think if we check.
This is the graft
I think if
left over, not covered by the
patient definitely
flaps,
will see now it is improved.
and it is blown out. You see, air is there inside.
Yes.
Could you see? Could you see this?
Yes, sir.
So this is the proof that eustachian tube is patent.
Patent.
Air has
Right.
entered, and I have not put any gel foam in the middle ear, and that is another proof that there is 360-degree coverage of the graft with the flaps. Otherwise, this would not have been blown up. You see? See? No, your gel foam now. So in fact, operation is over now. I will put gel foam onto that.
Thank you, sir. Thank you so much.
Any question?
I think you left no one for any questions, sir. This is the most amazing thing. Sir, there is a question from audience, very small question. Do you put any kind of suture for this endoral incisions or not? Hello?
Pardon?
So there is a question from the audience.
What is saying? Key audio?
Sir, endoral incision, in the endoral incision, will you put any
Yes,
suture?
yes. We'll have to suture it. Because a little cut is there. You'll have 2-3 sutures would be necessary. That I will do later on.
Thank you, sir.
And then you can see that not always endaural incision blocks the anterior view of the anterior part. You can see the whole of the tympanic membrane now. Could you see now? Whole of the tympanic membrane is visible by endaural incision. Not always it is blocked by the anterior overhang. Again, small anterior overhang is here. Had it been a bigger one, it could cover the part of this anterior part, and that too is not difficult to do this technique even blindly, because after elevating you can see the portion of the flap at the bony part, and if हाँ की बोल रहे हैं and here you see the superior flap falls onto the graft. That graft lies onto the handle of malleus. So there is a sandwich of the graft between the handle of malleus and the superior flap. Because superior flap I elevate from the tip of the handle of malleus, which is not the technique described by Sambo. উঠে চলে আসছে হ্যাঁ চলে আসছে কেন
বিধানদা 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 সব হয়ে গেলে জেল ফর্মটা তুমি
I thank Tushar again. I thank Dr. Bidhan Chaudhary for assisting me. I thank all the staff in the OT. The anesthetist has done a good job. Though it is done under general anesthesia, I do this surgery usually under local anesthesia. But anesthesia is so good now, almost the field is dry.
Hello.
Hello.
Hello, Professor Sir, BKRC Sir, done beautifully.
Very,
Just
very nicely.
Because at the age of at least I think 85. No, sir, your age?
Pardon?
Age, your age.
My age?
Huh?
My age is, just guess, it is nearly 90.
80 more than 85. I to mention the 85. So think about 85 of age. Huh? See, more than 35 years of senior, sir. So I don't know, basically 80, up to 80 are you able to work or not. Okay. So
Regarding the age, there is a small mistake. It is not 85 years old, it is 85 years young.
What is?
85 years young, sir, not old.
Yes. So now this case will be doing with coblation tonsillectomy and adenoidectomy. Previous adenoidectomy was transmission problem was there, so I decided I will show another tonsil adenoid. Okay, another adenoid was there, but I will not showing basically the lot of another cases there. Face is there, microscopic thyroid, mastoid, insidoid mastoid will show, and another 4 stapes is there. Now next case will be the laser stapedotomy. After that, sir, one showing the one stapedotomy. I will show the one with skitter. So lot of different. Sir will show the with I think sir uses the pick. I use the skitter. From tomorrow I will use the laser also. So today Dr. Deepak Holtipur will show the laser stapedotomy. Okay, now I will show the here the Sreyoshi Dana. Basically nasal obstruction is there with recurrent throat infection, recurrent tonsillitis. Here grade 2 tonsil, still I will do the tonsillectomy. Bidanda tu emni manage kor dao na, microscope amake dao, microscope, one microscope. Okay, so I will showing the microscopic tonsillectomy. Microscope, please, if you use the microscope during tonsillectomy, you will see the difference between the open eyes and microscope. Hello, Dr. Bhushan? Yes, sir. Beautifully done, sir.
Hello. Yes,
Hello,
sir.
Dr. Bhushan?
Yes. We are seeing.
We are habituated to do the microscopic tonsillectomy. If you use the microscope during tonsillectomy, you will see different basically. And 5 peritonsillar fiber, every bits of lymphoid tissue, every peritonsillar fiber, loose areolar tissue, all will be seen clearly. Okay. So now, this is the extra microscope, is the varioscope. So if you ask me the which lens I'm using, normally 250 is the enough for tonsillectomy, not 400 lens. But here we are using the varioscope, so no change of lens. Basically we are 250 to 280. Sir, can you tool down? So I'm lucky, sir is there. And zoom will be not too much, sir. So zoom at around 1. Now I change the zoom. Basically 4 for tonsillectomy is the good. Okay. The small tonsil.
Can you
small
focus onto the
tonsil
microscopic
difficult.
picture, sir?
Yes. Microscopic picture definitely
Yes.
will come.
Now we are getting it.
Yes. Yes. Okay, getting?
Yeah, there is a history.
Previous
of
case
frequent
was
throat
not
infection. That was the reason.
properly. I think now is the good. Okay. Now here, what is the advantage? Here, how will your pain will be reduced? Look here.
The patient given a
First
history of
bite
frequent
it.
infection.
Okay.
I think that is the reason.
Sometimes endophytic tonsil. Okay. Look here. This is endophytic tonsil, and just check the water. And here, I will get the plane first. My target to get the plane. Here I will get the plane. So from upper pole, I will start the upper pole.
Sir, sir, can you just please stop for a while because not getting the picture.
Hi, Abar again.
Hello.
Hello.
Yeah, now we are getting the picture. Yes.
Oh, when I will press the paddle, there is the picture is gone. Here
I think, yeah, it's happening again, sir.
again. আমি চেঞ্জ করতে বলেছিলাম তোমাদেরকে।
Better we can see on the small camera screen if it is the problem remains happen.
এই ফোকাস করো তো। ওই বারবার বলেছিলাম তো চেঞ্জ করো না। এটা চেঞ্জ করে দাও না। না পুরো বোর্ডটা চেঞ্জ করে দাও। ডিফারেন্ট বোর্ড তাই। Again problem.
Yes. Now it is okay, sir. You can
Now is
proceed.
okay?
Yeah.
Okay. So
Again
here,
happen.
Again.
Wait, sir. Wait.
Again problem?
Yes. It's happening again, sir.
A problem?
No.
No problem. If I touch the tissue, then is the problem started. Here, look here again. This is the problem?
Yes.
Problem?
Yes.
Or no problem?
No touch technique.
Oh, then is the problem is the touching. এই টাচ করলে হচ্ছে অজয়, তার মানে পুরো সিস্টেমটা চেঞ্জ করতে হবে। হ্যাঁ, আর্থিং প্রবলেম। সো হিয়ার দ্য নিউ ইউ সি,
Hello.
you see this is a beautiful
sir.
plane. No,
sir, we are not able to see anything.
এই আবার কি করে চলে গেল? বোর্ডটা চেঞ্জ করে দাও না, ওদিকে করে দাও না। Now the picture is there.
Okay, sir. Yes.
Then now we see the beautiful করিনি, beautiful peritonsillar fiber. No.
Oh,
So
yes.
capsule is the intracapsular. Look is the lymphoid tissue. No.
Nice.
If I do this way, no. This
Yes,
way, the beautiful tonsil will be removed. Yes, sir.
Yes, sir.
Now no problem. Picture.
No problem. At the moment,
Now
no
picture
problem.
no problem.
Now it is again problem, sir.
কি হচ্ছে বলো তো? Oblationটা কোনো গোলমাল হচ্ছে?
Now it is visible. Carry on, sir. Now it is gone.
Again gone.
Yeah. Again come.
এই ফোকাসটাও ভুল হচ্ছে।
Touch on and touch off. That is the thing.
Oh, no, I think is the power cord is something is problem. পুরো টাচ করো না ওখানে, হ্যাঁ নিচে ডিফারেন্ট জায়গা করে দাও তো, বডির সঙ্গে টাচ থাকছে কোনোভাবে। আমি বুঝতে পেরেছি, তার মানে হচ্ছে বডির সঙ্গে কোনোভাবে টাচ করছে এবং এখানে মারলে হচ্ছে না, বডিতে লাগলে ব্যাপারটা বুঝো। এবার লাগাও দেখে কি সেদিন তো হলো না now here now picture is there
Okay, okay, picture
now
is there.
touch picture is there
Yes, sir, picture is there.
oh good no now
Please carry on.
then building total setup look here the beautiful plane no
Okay,
this is
sir.
the total peritoneal fiber
Absolutely.
total no vessels here
Sure,
this is the bloodless field
sure.
so here if you this way you do some secondary hemorrhage and also then pain so all will be less because the no muscle no
Right,
supraconstrictor
right.
exposed just beautifully it will be there
No blood is there.
so within of 1 and 2 minutes you will finish the surgery just beautifully look here and if you see any vessels just coagulate it to prevent বডিতে টাচ করা যাবে না বুঝতে পেরেছো তো আমি বুঝে গেছি এবার নাও ইউ সি you see beautiful plane and don't see anything just see the tonsil and under microscope it is possible Dr. Bhushan you are happy
Yes, sir. Very happy, sir.
Yeah.
Sir, I just want to ask one
within
thing.
2 minutes I will finish the
Hello.
tonsil
Hello.
so no headache free surgery totally headache free
Hello.
hello
Sir, you are using microdebrider since like 3-4 years. Before that, I think laser was there, and before that, call instrument was
sir,
there.
I can't understand your language sir
Hello.
hello
Sir, you are using this coabulator technique since 3 or 4 years, I think.
no sir more than
10 years.
more than 10 years
Before that, I think there was a cold steel instrumentation and laser was there.
huh.
So, in between, some people are using monopolar cautery also.
oh
So,
but I don't like this
So, this is
basically,
beyond
few years
like or
back,
dislike. What is your
when,
take on this?
sir few years back when I not used coblation I don't prefer that time no headache tonsillectomy headache now I'll enjoy every day tonsillectomy
Right.
now every day different from different states I am getting referral from the tonsillectomy and adenoidectomy I enjoy because there no headache for me
Yes.
tonsillectomy headless headacheless surgery for me so if any spot is there any RBC is there just coagulate it okay then you see secondary hemorrhage will be very very less and just my policy is
Which
the good
microscope
antibiotic.
you are having, sir?
Hello
Which microscope you are having?
now the extero I have all microscope I have 4 microscope here two extero 2 Zeiss another 1 FC 1 Pico
Which one is this one? RBCs are.
this is the beautiful microscope আর হচ্ছে না now the picture is good no again you see all are not habituated to do in the left sided but I prefer the left sided tonsil left sided hand okay look here now
Carotid
my
pulsation is there, I
instrument
think.
will be in left hand okay
Yeah, carotid transmitting pulsation are there.
yes so when you will do the styloid so you be careful with coblation okay because sometimes internal cavity you will see
Excuse me, sir.
yes
Sir, there is a question from the audience.
yes sir out of focus আছে ডাউন করো তো টেবিলটাকে ডাউন করো তো একটু
তুষার
yes sir
ডক্টর সুব্রত মুখার্জি বলছি
হ্যাঁ সুব্রতদা বলুন
হ্যাঁ
ঠিক আছে
in between the tonsillectomy and tonsillotomy there is some difference
possible it possible
is it
but
possible
normally here due to infection no but sometimes only crypts patients comes with only crypts at that time I do the tonsillotomy
yeah and
you see here no plane so you just get the plane first otherwise operation will be difficult okay just you search the plane you see Now is the plane. Okay, blue line is the plane. So, endophytic tonsil. Okay, look. So my instrument is the left hand. Okay.
Yeah.
So initially for beginner of, look here the plane. Okay.
Yeah.
Now again blue line. I call it is a headache-free tonsillectomy. Look, the grip change.
So, what is your experience about the patient post-op pain?
Post-op pain is there. In case of
There.
children is very very less. In case of adult too much.
Okay.
Nowadays we start the Bupre plus patch.
Okay.
Buprenorphine patch.
Buprenorphine patch.
Pain is there. I explained the patient. The painless, bloodless, no. But bloodless definitely. But pain will be there. If do the tonsillectomy, definitely pain will be there.
So,
But headache will be less for patient, for doctor also.
Sir,
Not
like in this
headache
technique-
not for pain, sir. Headache for surgeon and party, mainly bleeding. If no bleeding, no headache.
sir, in post-op, what is your experience? What is your take?
Hello?
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 Sir, intra we are not seeing any kind of bleeding. So, what is your experience about post-operative or in follow-up?
Initial
Because
life,
we
if you
can see
start
lots
the-
of charring in the whole of the
no,
tissue
no
bed.
charring, sir. No charring, no coagulation. I am
Right.
using. Only
Yeah.
ablation.
Okay.
No charring at all, no charring. So only slab will
One
be there.
second.
Post-op hemorrhage, sir, initial life definitely you will face. But when you will be expert, sir, negligible bleeding. Basically nowadays we are doing a
hello.
lot of tonsillectomy,
Hello, Dr.
but in
Tushar.
very very rare cases. In last few years, not admitted in only 1% I have admitted, at least few thousand cases I have done. Okay.
Hello, Dr. Tushar. I am
Yes.
Dr. Parekh.
Yes, sir.
What is the makeup instrument you are using for
When?
coablation? What brand?
Huh?
I mean,
Oh, Smith and Nephew.
only there are other varieties
But
available
I
in the
am not,
market. What is
liking-
your opinion?
I have three Smith and Nephew.
That I know. But
Three and
you are a
nephew-
very conversant fellow. I like to have your opinion on other brands like Eon from Gujarat. They are producing.
Sir, you look here the plane, no smoothness. You see the smoothness?
Yeah.
No muscle exposed. So pain will be very, very less. Look here the smoothness.
I didn't get my reply.
Hello?
As you are a conversant person in this field, in coablation surgery, I like your opinion, especially for the juniors who are intending to break upon this procedure.
Sir, please tell it loud. No, the noise is there in OT.
Okay. I like to have your opinion on the coablation instruments. I mean the brands which are available in the market, especially for the juniors who are trying to
Sir,
embark on
I know your question. Basically, lot of company, no, one Chinese company, one Indian company coming to me also, because I am doing lot of coablation. So they have data also.
Yeah.
I am using. Basically, I purchased the more than 200 in a one shot, sometimes 100 or 200 one. So many companies
companies are coming to you. That I got. But what is your opinion on the other instruments, the
So
cheaper
first
ones?
opinion, few days I have started another one by demo purpose, but this is another problem, because if you see that one, the water coming from the front side. So if you started front side, my endoscope will be fogged with water, because I always prefer the I will show the not tonsillectomy, during adenoectomy I will show the problem. What is the problem? But I don't want to comment any company, but I use the Smith and Nephew and Smith and Nephew's company's product.
How expensive it is? What is the price?
Not so
market
expensive.
price?
The difference is the 1000 wand difference.
No,
I
no,
think.
not for the wand. For the entire instrument, I mean.
Entire instrument, I think not very cheap in Indian company also. I think 1 lakh difference, 1 lakh or 1.5 lakh
In
difference.
Smith and Nephew, what is the cost?
Smith and Nephew cost is the, this is the, we use the 2 coblation 2. That cost previously was the 6.5, now is the 7 lakhs.
Okay. And the wands?
One cost, if you purchase the bulk, then one cost to be the 11,000 only.
Okay.
And also Merrill bones, also the one 9,000, 10,000. So
with-
1,000
with-
difference. Hello?
With one wand, how many tonsillectomy you can do?
Sir, tonsillectomy possible 3, but
Okay.
only if huge adenoid is there. In case of in young children, I don't prefer the reuse of wand. Basically, I don't prefer. Otherwise, there is a chance of again secondary hemorrhage also. So I asked the party, you should pay to me wand cost different.
And then
So difference is very clear cut.
my last question
Yes.
from the economic field. How much do you charge for a tonsillectomy with coablation?
Sir, okay, fine. Your question, sir. Every cases slightly different, but normal charge is the 30 to 35 plus one cost. This is the basically in our hospital charge. Total, including all charge package.
Then it's fairly good.
This is the look here. This way. Okay. Okay, and
Thank
also my assistant put the shakar in the oropharynx. Okay, so I prefer the too much water. No. Too much water I will place. Now the slight bit of DNS is there, spar. Okay. Now you see, हमारे शेष है ये step is ready करो. 5 minutes शेष करो. Look here, how it is be comfortable. Look here. Now first water for cleanness.
Hello.
Foggy, yes.
Hello.
Yes, sir.
Sir, we are your picture on the screen. Actually, we want the endoscopic picture.
Now is endoscopic picture?
No.
Hey, change karo.
Yeah. Now we can see.
Yes, no. Now you see how I'll manage. I go up. Okay, upper pull, okay.
Yes.
This way, movement this way, the back.
Okay.
Now water coming from the posterior part. Look here. Or in another company, water coming from the front side. So
Right.
I prefer the water pressure. Okay, pressure water. So that's the all-time problem created. So I don't prefer also.
We can see the ignition film in between the tissue and the band.
Yes.
Yes.
Look
This is the
here.
ideal way to use the band.
Basically, they told the 5 millimeter gap, but in human, how it is possible 5 millimeter gap? So your expertise, your water pressure, all will be created the gap, no?
Right.
So and also don't go the deep to the tissue. All time your ground electrode, all time you will visible, should visible.
Right.
So your bleeding will be totally controlled. Water. And you will see slowly debulk the tissue. And I will show the total plane. From the upper pole, this is the upper pole. So periosteum will be there in upper pole.
reason for the adenotonsillectomy.
Okay, this way, and you will finish this way. Okay, and public told that I use the coblation lot of time. No, time is the depends on. If you expert, then time will be less. Time, why time? Basically no packing, nothing. And you will do surgery and finish off and you take the coffee in surgeon's room. No headache at all. Again repeat check up. The bleeding is there, packing, and also irrigation, lot of time.
Right.
The bleeding is stopped or not, no headache, no. If you
Yes. Is going
one time
first
you will
it
enjoy,
getting
if you
coagulated and
see
then it
the
will suck out
surgery,
in the suction.
totally you will enjoy. Basically 2 years of kid, 1.5 years of kid, not
Same thing with
no
the
problem at all.
microdebrider.
But with microdebrider,
Just
with
taking
blind technique, this is very difficult.
Yeah.
But with coblation, I am using the periodic endoscope. So no blood at all, and 100% I will remove the tissue. And I will give the merely assurance, no chance of recurrence further. First question, patient party, no chance of recurrence. definitely no chance of recurrence with coblation. But if you claim the in curettage method also no recurrence, no, I don't believe. Basically, I am doing nowadays alternative revision case. So all record is with me also.
In tonsil we have to.
In also premium from Premium Institute, Vellore, lot of recurrence I have seen. I have seen Manchester ENT recurrence.
Don't select me. What we do? We removing.
So not a technique, not a fault, not surgeon's faults basically. This is the technique. Blindly, how will be possible to remove the all tissue? 100% up to posterior, 100% up to sheath. This is the sheath. You see, this is sheath. So it is possible. Look here, and also slight bit of 12 years of age. So slight bit of I will remove it, and also with this instrument is possible to prevent later on slight bit of hypertrophy or nasal block, and also you will see the fossa Rosenmuller area, some adenoid tissue that I will remove it and ease. Hello. Hello. Hello.
Hello. Hello.
Hello. Am I
Hello?
audible?
Yes, sir.
Yes. So keep on talking. Otherwise, I'll think picture is not there or not happy. You are not happy. So definitely you will be happy. You see the length of the tissue. All time you will see now. But pediatric endoscope required. In any pediatric case, we use only pediatric endoscope. Look here. All perimycial sheath, okay, perimycial. If you see the perimycial sheath, don't go beyond, because the unnecessary muscle injury creates a pain, neck pain.
We already seen one
Few
patient in
days.
his whole career.
So you ask the patient if neck pain will be there.
Hello.
Hello.
So there is a question from the audience. Did you encounter any kind of reactionary hemorrhage after the collateral-assisted adenotectomy?
Please speak in loud.
Hello.
Hello.
Sir, there is a question from the audience.
Yes.
Did you encounter any kind of reactionary hemorrhage after the collateral-assisted adenotectomy?
Sir, basically in coblation, no reactionary, no primary hemorrhage if you know the technique.
Yeah.
Okay, only secondary hemorrhage. Definitely secondary hemorrhage is there, no doubt about it.
So what is
In
your
case of-
experience in that?
No primary, no reactionary.
Okay, secondary?
This is secondary hemorrhage is there at days of 12 days.
Right.
When slough will be
Peeled off.
dislodged, sometimes dislodged
Yes.
from tonsil area, sometimes happen. But I mentioned this is the spotting, not a big hemorrhage, not required OT. Just give the tranexamic acid and cold water, and patient will be happy. After it will be automatically stopped. Basically, no severe hemorrhage because the not exposed muscle. So, hey, sir, কেটা কমার হয়ে গেছে রেডি করে দাও পুরো
Sir, there is a question from the audience.
Yes, sir. Yes, sir. Any question? No problem.
Sir, any special care for coblation tonsillectomy for post of care?
Post of gargling, good gargle. That
Good
is the main.
gargle. Okay,
Good
okay.
gargle, discipline gargle, Culora type of any hexidine or
With povidone. Okay, sir.
This is the gargle. Good gargling, and keep talking. Basically, patient not interested to talk. No. If no talk, so muscle spasm will be there. Mainly pain. Why pain? Basically, pain is the due to muscle spasm.
And
So
what will
if
be
you
the diet,
allow
sir?
the muscle movement, then no pain will be there.
So I think it is very difficult to make child to be talking. I think it's very easy for the adult.
No, but all problem will be solved, sir, after 10 days. Patients will be happy,
Right,
no?
right,
Breathing patient party total happy after. Only I see my practice. Only happiest parents and happiest patient. Only the adenoidectomy, after adenoidectomy. Basically breathing, you think the breathing problem, no? And steppies. This is the instant happiness. You will look you come my word, and all maximum happiness you will see the child's and child's parents, because the breathing will be started, no?
So thing is that first surgeon should be happy, then parents and patient should be happy.
So after staphylotomy and after adenoid tonsil, the most happiest result to the patient. Otherwise, other tympanostomy, graft taken up, hearing okay, But patient nagging, sir, pain, incision line pain, graft taken up at that area, pain. So instant happiness after stapes surgery and instant happiness after adenoid surgery.
Yes.
Maximum happiness I have seen with my adenoid patient. So we love adenoidectomy every day.
Hello.
Hello.
Sir, there is a question from the audience. Is there any chance of after removing the adenoids, scarring or nasopharyngeal stenosis or something is there or not?
Sir, basically voice is not so clear.
Hello.
Hello, yes.
তুষার সুব্রত বলছি
Oh, nasopharyngeal stenosis, no. But I have seen nasopharyngeal stenosis after one surgeon's microdebrider case and released it also. Sir, here no problem because I allow the breathing, no, just after our surgery. So how nasopharyngeal stenosis will be there, no? Again nasal drop and spray. So no way, no injury at all. Only the adenoid tissue I will remove. No muscle injury at all. So how the no, I have not seen any. I have seen only one cases, not this after snoring surgery. One surgeon does with microdebrider. That case I have done 2 times surgery. First and also they can re-stenosis slight bit. I have released again 2 times surgery.
In OSS surgery it can happen, but in specifically for the adenoidectomy, what is your take?
I think as the trauma was there and sometimes immunogenical problem was there with patient.
Okay.
Sometimes fibrosis, much more fibroblast formation. So at the time injury, lot of injury with microdebrider after OSS surgery, septoplasty, and that portion now all are stenosed. This was with me, picture also is there. I have shown the in different conference. This is the problem. Look here how the beautiful surgery, look here, and you will enjoy also, no, after doing this whole area removal. This is the periosteal sheath. Look, periosteum sheath, periosteal sheath. Look here, periosteal sheath. And picture quality, you think the picture quality here, the good picture quality, no? You enjoy the picture quality, sir?
Yes.
Look here how I will manage the fossa vaginal area. Sometimes 3 way fossa vaginal area. First, if you remove this, you will see this. Okay.
Yes.
Another is you just press it and press it. There is a chance of bleeding. So this way, just this way. Press it and this way. Another is take the angle endoscope, and you will see the all tissue in the fossa vaginal. 3 way. Okay. So all tissue will be removed and you see the student air is coming out. My all assistant nowadays doing the fantastic. Dr. Debayan Tarabdar, Dr. Debayan De, Dr. Kosturi, Arvind Gupta, all are doing nowadays a fan of coblation. So if you do the coblation, then you are unable to do normal tonsillectomy. Believe me, sir. Basically, normal tonsillectomy nowadays. I remember my young age, when I was young practitioner. Sometimes I have gone there after reactionary hemorrhage. I have seen, and then headache. After that, I am not so much interested to do the tonsillectomy. Now I enjoy the tonsillectomy coblation. Okay.
Sir, you are already young.
Hey, ready? Step is ready. Sir, you are happy?
Everybody is happy.
Thank you. If you see any RBC, just encounter it. Okay, check the tonsil also. Now my assistant will do the septoplasty, and also mic will be shifted to the another room. So partly I will do septo, partly assistant will record Look
Beautiful
here,
demonstration, sir. Very
thank
nice.
you so much.
Very
And
nice.
beautiful.
Sir.
Look here,
Yeah.
no headache. Patient will go
Yes.
discharge after 4 hours. No headache for all. Sir, you are happy, sir.
So adenotonsillectomy you used to do in the daycare procedure only, yeah?
Yeah, daycare procedure. All.
Oh, that's
If
nice.
you see my OPD no, yeah, here ward or cabin, after 2 hours, 3 hours, patient are absolutely fine, and so all are laughing. So now mic will be shifted to the steppies. Ready, sir?
Any question from
Done.
the audience?
Yes.
Thank
Hello?
you, sir. Thank you so much
Ah.
for the nice demonstration.
Thank you so much. Hey, sir, max দাও,
Yeah.
mic কোথায় গেল? আরেকটা mic ছিল তো। লাগিয়ে দাও, লাগিয়ে দাও। Now this case will be the laser stapedotomy. Here
Okay.
now I put the 4 steps, by chance back up 1 step is, yes, 2 lesions, step laser. 2 lesions I will do the 2 case, and I will do 2 case. Basically 4 case. Why 4 case? Because by chance if 1 case is cancelled, so different. First laser stapedotomy, then SATS another technique, and I will do with the skitter also.
So we are getting the endoscopic picture of intranasal anatomy. So can we get the brief history about the case?
Okay, no, just 1 minute. I'll shift the picture. এখানে পিকচারটা শিফট করো এই ক্যামেরাতে। Just 1 minute, sir.
अरे यार इसके ऊपर कवर आया ना
This camera is good, but here microscope is not so good because the 1FC microscope. But why? Basically the laser people now installed yesterday, day before yesterday, but they use it the 1FC because I have external microscope that not able to fit with my external microscope is very slow. So definitely we will manage within 15 days. They will manage also. Zeiss company also will manage. Now Dr. Deepak Holtipur will do. Definitely I will assist with the 1FC microscope. So I think picture quality slight be deteriorating.
Tushar, this is Professor Ogna.
Yes, thank you.
You should purchase in Pentero, not this 1K. Pentero is your microscope. Why don't you purchase Pentero? And that is capable to for laser, this one, Luminex laser. So Pentero is your microscope.
Sir, I have 4 microscope. কত আছে এটা 400 আছে নাকি? 250 টাকা না স্যার আসবে না স্যার ফিটিং ইয়ে করে নিন স্যার চোখের অসুবিধা হচ্ছে নাকি না ক্যামেরা ফোকাস করো স্যার ক্যামেরা ফোকাস করে নিন এবার
हाँ करो
कैमरा फोकस करो
ये रिंग बड़ा किया क्या आपने
जूम आउट करो
नहीं ये तो बड़ा कर दिया 1 मिनट
हाँ ज़्यादा जूम कर दिया
1 मिनट
স্যার কত আছে আপনি স্যার একবার ফোরে সিট করুন ফার্স্ট
এবার ঠেরো
এটা লেজার ইউজ করবে এটা আমার নতুন লেজার স্যার
ये कवर इसके ऊपर आता है बस ये कवर का प्रॉब्लम है अभी भी
कवर सरिয়ে দাও না পুরো কেটে দাও
ये कवर को कुछ करना चाहिए आपको
yes, this is the advantage of this laser. There is minimum error during stapedotomy, minimum chance, sometimes submerge. Still we are doing the reverse. Still there is a chance of problem, 1% or 0.1%, not a 1% basically. Last 15 years I have not faced any problem. Still sometimes we are scared. But with laser that problem will be solved, I think.
ओके ये देना लैम्पर्ट स्पेक्युलम देना
Hello. Can we
Hello?
get the brief history of the patient, sir?
History. Okay, sir. File down একবার. The bilateral otosclerosis. For this patient, bilateral otosclerosis, I have done by 22/8/22 one case already done. Already হয়ে গেছে. This is the picture of
keep
left
the
stapedotomy
circular
in
knife.
my previous nursing home. EBS hospital, right? Stapedotomy already done. Okay. Patient here is fantastic. So patient is happy. Now he came for. Now the previous one right here, hearing 28.3. Now the left ear 70. So now we are doing the left stapedotomy. One.
Okay.
হ্যালো তুষার,
Yes sir. Yes sir.
আচ্ছা তুই একটা কানে তো করেছিস আগে, তা আরেকটা কানে করছিস?
হ্যাঁ।
এখন কি দুটো কান বলেছে রিসেন্ট বইতে? দুটো কান
স্টেপিডোটমি ছিল স্যার, শিক্ষা ছিল তখন থেকেই। তখন you feel at that time when we diagnosed that case, diagnosis the right ear, left ear, both bilateral stapedotomy. 60-60 loss was there.
No, you do bilateral stapedotomy.
Hold this.
Bilateral otoscopy was there. 2020 we have.
No, it's okay. That was diagnosed, but the right ear is fantastic.
Yes.
So why you are going for risk for the second ear? Because if any time the right ear becomes sensorineural, because I've seen a patient after 15 years they develop sensorineural deafness. So 1 year we keep it in the hand so that we can use the hearing aid.
No,
So-
sir,
I don't agree, sir.
I differ from you.
No, sir. I always said that doing the side of stapedotomy for last
Sir,
15 years.
I differ from you. First 15 years, my understanding was that if you do stapedotomy on 1 ear, that is more than enough on the hearing aid. But
Okay.
now, that in auto, if you allow,
Not loss will be there.
at some point of time, it will become.
I can't hear, sir.
At that
I think audio, somehow audio, there is a problem. I
mask
think.
খুলে দিন না স্যার, কিছু দরকার
Hey, mask,
মাস্ক নেই না।
saline.
Sir, look.
Hello.
Hello, audible?
Hello. It is audible now. Okay.
Can you hear me?
But there is a lot of interruptions on your transmission. Please
Hello.
tell the audio people, technical people,
Yes.
that there must be some interruptions again. Audio is not coming uninterrupted. It comes in pauses.
Okay.
Now you tell me.
Hello.
Now better.
Hello.
Yes, definitely better.
Can you
but
hear
comes
me?
with interruptions. Please ask
Yes.
them to avoid the interruptions.
Yes.
Sir, told basically previously was the thinking was there.
Double end knife, circular knife or side
One
knife.
stapedotomy is enough. I think
Yeah,
the
side
doctors
knife
also, told that the bilateral you prefer also. All time we prefer this last years we have
Hello.
lot of.
I am starting my incision
Yes, sir.
Hello.
Focus to speed.
from 6 o'clock. The horizontal limb of Rosen's. You can see the incision now. I am coming all the way up to the bony cartilaginous junction.
Okay, sir.
That is the lower incision. Now let me go down to the upper incision. Round knife.
এই অজয় কোথায় গেল? এখানে এই ও সরি
I am staying anterior to the malleus. From there I will come posteriorly like that and then curve it to join the first incision. Right? Now you give me the circular knife for the elevator. Now I'll be elevating. Mic का कुछ प्रॉब्लम है. Hello.
Hello, we can hear you. Hello. Please carry on, sir.
Here no? Hello?
Hello, sir. Can you hear us? We can hear you. No problem. We can hear you, sir. Please carry on.
Yes. Yeah. Yes. Suction. They are becoming the suction a little smaller now. The cotton will come off. Yeah, ये रखो. Yeah. Yeah. Give me the crocodile forceps. Yeah, circular knife. Cotton. No problem, just another, we need just one more, yes. अभी section देना micro tip का. Keep this with you. Give me the sickle knife or the smooth cut, pick any one of them, yeah. Yes. Now you give me side knife. Are you getting the picture?
Yeah.
Yes, sir. We are getting it.
Alligator forceps. Crocodile forceps, yeah. Yeah. Alligators. Yeah, side knife देना. Yes. Give me a little of
Can the picture
xylocaine
be a bit focused more, sir?
Yes, 1 minute.
Please kindly.
Yes.
Take a chance to focus.
ये focus जरा करना उसको या.
It's already focused. I think we need a zoom in.
Okay,
one minute,
okay.
1 minute, 1
Please,
minute. Let
please.
me see. एक मिनट ये एक मिनट ये रखो, कुछ मत करो. Let me see. Give me the Lamperts. And maybe you need to zoom a little in. Lampert speculum you give me? Yeah. Now you focus a little bit
Yes.
on the middle ear, only that ring, yeah. No, it's on the hair now.
A bit more zooming, sir.
Yeah.
Please zoom kindly.
No, it should, we should be able to see the middle ear vessel, I can see.
Yes, yes. It's
I think
already
you can
seen.
also see that, yeah.
We can easily appreciate.
Yes.
Now it is better, definitely.
Yes. Now,
A bit fog is there, I think, in the front of the lens of the camera.
no, that is because once you put the gun, the
Okay.
scanner, that is a different lens actually.
Okay.
So, the drill is there? Yeah. Yeah, a little bit with the needle, please, with the needle. So that this is
So-
4% with adrenaline, I can anesthetize the middle ear mucosa a little bit.
So in the picture we are saying we already elevate the post-oral flap.
Yes.
And glimpse of incus we are already seen.
Yes.
I think I is the IS joint.
Yes. That's the highest joint.
Yes.
You can see. Give me the 15 knife, maybe this hair I can take out a little bit. These hairs are coming in the way. So maybe, I can just about.
We can rotate the speculum and take them behind it. But I think it's more convenient
Yes.
that way, yes.
Yes. Okay. Give me the drill. Foot switch. Yeah.
It's actually easy outside, but it wasn't especially at the middle.
Huh. I don't want saline.
Hello.
No, I don't want saline. I don't want
Hello.
saline.
Hello. Sir, there is a humble request from the audience. Can we zoom in a bit?
Yeah, we will.
So because outside it is looking bit hazy and
Yeah.
Thank you so much, sir.
Yeah, just 1 minute. I'll zoom in a little bit more.
Yeah.
No, make it a little bigger because this bone dust. No, when I take out this can get blocked.
Even that step we can do the curate also, because that part of the bone is very thin. Yes.
Yes, now
Yeah, that
maybe I guess we'll zoom a
surgeon
little bit
preference.
more. Lampert speculum or yeah, Lampert speculum. Can you see that?
Yes. Is better now, sir.
Yeah.
Yeah.
So basically, I'm trying to remove the scutum.
So any specific mark where you drilling or what else bone we have to remove?
Yeah, the idea is to expose the base of the pyramid.
Okay.
So I think I'm just trying to see. I should be able to see the facial now.
Okay.
Suction, please. No, take out the microtip for a while because no, not yet. I would prefer dry drilling only. Drill again. Okay, suction.
So there is a question from the audience. So
Yes.
is there any preference of you're doing the dry drilling? So is there any
No,
advantage of that?
you can see the only advantage with dry drilling is the fluid doesn't create a torque.
Okay.
So your flap which is anterior
Right.
or corda which is close by
Okay.
doesn't get dragged into the drill, you know.
Also, when we do the dry drilling, that dust with deposit in the field is further deep field is not clear.
Yes,
what I
yes,
think
yes. And you would like to create a bone dust into the deeper area of
So you are using the straight handpiece or like
contra angle.
Contra angle. Okay, okay, okay.
Uh,
Just to
you-
1 second.
Please. 1 minute. You are getting the picture?
Okay. So one more question from the audience.
Yes.
As you are doing the dry drilling.
Yes.
So what could be the possible chances of injury to coda and this facial? That because of the heat generation.
Heat generation is with a diamond burr. Never much with a cutting burr.
Okay, okay.
Suction with micro tip.
Now we can see the coda in the view.
Yes, 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 yes. Now you can see the corda in the view.
Right.
You can also see.
Yes. Sir, picture is bit hazy.
Yeah, yeah. Now you can see the incus, I think. Now there's a bony spicule here. I removed that.
Excuse me, sir.
Yeah.
Very sorry to interrupt, but the picture we are seeing are bit hazy, not that clear.
Yes, yes. Curate.
Yes.
Suction. Drill. Drill, drill, drill. Suction, please. Now I can see the facial.
Yes.
In the
Very into
background.
very into the deep part. Yes.
Yes.
Whitish structures.
Yes. Yeah, drill again.
Yes. I think it is the
You,
tympanic
you
segment.
can see the facial now.
Right.
You can see the, give me the suction again, please. You can see the,
Incus.
you can see the incus.
Yes. And deep
Very
down.
clearly, yeah.
There is the whitish structure that facial are
Yes,
seen
drill.
beautifully. Yes.
Suction. It is very important that you see the facial nerve very, very clearly. Just like most of the surgeries, I'm not getting the angle correctly. 1 minute.
Sir, clarity of the picture needs a bit
Yeah.
more sharpening. It is not
Yes.
not that sharp.
Yes.
Ask the technical people to zoom in a bit, so that we can see a better picture.
Yes. Yes, I can see the foot plate a little bit now.
Sir,
Yeah.
the picture we are seeing is a bit hazy. Yeah. Yes.
No, now the focus, I need to focus it a little bit.
Just take your time, sir.
Now you can see, we need to center the picture. Can you see now?
Right, sir. A bit.
I can see the foot plate now.
Yeah, we can
A little
easily
bit, I
appreciate
think
it.
the focus, just hold this like this better. I'll focus it a little bit. Wait. No. No. That's the maximum. Wait. Wait. Let me try and focus on this first. Is it focused well now? Let us see. This is the maximum focus I think I can get. Because this Tushar Das scope. No. Lampert speculum.
Yes. Every surgeon opts their own way.
ये थोड़ा ये हो रहा है, ये टाइट करो. Wait. हाँ, this should be okay. Yes, sir. I have a laser with me, sir. Yes, sir. Hold this, उधर रख दो. Let us have one. I have used it, sir.
No, haziness I don't know because of the laser or not. That point we are seeing.
Suction.
Nobody knows. Maybe the lens is. Hello, sir. Sorry to interrupt you in between. We are not getting the good quality picture here. Is it be possible to?
Yeah.
I think
Wait,
not the
that
focus
foc-
issue. Some
the foot
fogginess is
plate.
there. Yes.
Foot plate, are they able to see?
Yes.
You have to focus it on the foot
Yes,
plate.
yes, we are seeing just below the facial now. Yes.
Yeah. No, I think I am getting a
Exact word for that.
clear picture here, Tushar. One
Sir,
minute.
maybe the picture you are seeing and what we are seeing is not absolutely okay. This
one
may be
minute.
different. Maybe that's a
Maybe
different lens.
1 minute.
There is a difference.
Difference.
एक minute.
Clean cut difference.
एक minute. One minute. Yes. Or maybe what I can do, let me see the eyepiece. Where is this focused? Maybe I'll change it a little bit.
That circle you are seeing now.
Let me see now.
That circle you are seeing. That is the laser. That red color circle you are seeing.
Now let me move this. Let me see. Let me see, this is the best we can focus under the circumstances. Let me see if we can do something with this. Okay. Let us see the, oh my God, this is not. Lampert speculum. Okay, 1 minute. Alligator forceps. Ah. Beta, you to now focus the microscope. Section you give me, fine point section. Try to focus it on the foot plate. 1 minute, 1 minute. Let me clean this up.
Step is
Completely, yeah.
oh, it's the left side.
Yes. Now can you focus it on the
Because
foot plate? Let us see.
Up now, so I think it's the left side. Yeah. Left side.
Little bit. Yeah, it's almost on the foot
Yeah.
plate now.
It's now clear,
no,
sir.
yeah, no, go back. Vessel on the foot plate. Vessel,
Yeah.
perfect.
Yes. Foot plate is
This is okay
clearly
now.
visible. Yes.
Curate to give me.
We can see the even blood vessels over
Yes,
there.
yes.
Yes.
Cut pick. Smooth curved pick. स्मूथ कर्व पिक क्या है? आप रहो ना, मैं एडजस्ट करता हूँ. डोंट वरी. Smooth, or you give me right angle pick or something. Give me the 45-degree pick or right angle pick. Oh, the thumb instrument, is it? Okay. Yes. Suction. I think now I've got a good exposure.
Yes. It's very clear now, sir.
Yes.
We can see the IS joint, coda, facial canal.
Yeah.
Posterior coda also we can easily appreciate.
No, I just want to first see the chorda is also comfortably going out of the way now.
Right. It's just lying over the pyramid, like stapedial tendon.
Yes. So let me see, curate please. Finally,
stapedial tendon.
The microscope and the video picture have become like Mom and Narendra Modi seeing some one point. Smooth cut pick. Yes. Curate, or you can give me the drill a little bit.
Whitish.
I always love to see the base of the pyramid.
Yes.
And this one. Oh, that's the laser switch. Yeah.
The structure, whitish structure that running parallel to this coda, it's just lying below that. This is the stapedial tendon.
Yes, section please.
Sorry? Yes. Some people do curate with the curettage only. Yes. Yes. The surgeon preference.
Gradually I am taking out all the bone dust.
Yes.
Curate.
Now we can a good exposure of pyramid.
Yeah. You can see the pyramid, I think.
Yes. Pyramid, we can see stapedial tendon in the view. Posterior crura is already seen.
Yes. suction. Yeah, now you little saline to one area. Give the side knife. Saline, no? Yes. So I'll try to take away the now. Action is Dr. Moshai. Yeah, give me the side knife and then the sickle knife. Yeah. Yes. Curate. Now we'll get the laser ready. I want 5 watts and 0.3 mm aperture. Can you see the corda is away from us?
Yes.
You can see the stapedius tendon very clearly.
Yeah, exactly. Very, very clear.
Give me a small gel foam, please. Small gel foam, beta. सर पहले टेंट में सर तुषार बाबू योर सर्जन मैं पूछा रहा हूँ.
Your voice is not clear.
Yeah, it was never clear now. So yeah, okay. Give me the self-retaining speculum. Picture should be, I think, reasonably clear now.
Yeah, it's very clear now.
Yes. Now let me start the laser work. I want a small piece of gel foam to protect the foot plate. But believe me, Tushar will agree, sentimentally, with microscope. Isn't it, Tushar? This is very big, it will cover the entire foot plate. I want 1/4 of this. Laser ready? With the console, 5 watts, 0.3 depth, very good. 1 minute, yeah. See, I am going to put the gel foam to protect my foot plate. Are we ready? Yeah. I think, is it in the standby mode or in the ready mode? Ready, na? Okay. All the best to Tushar Babu and Boston Scientific with this laser. Ready? I will fire now. Yes. Coming here, don't worry. Wait.
First, you are cutting the stapedial tendon, huh?
The mucosal band between the posterior crus and the stapedial tendon. I just released that. Suction, please. In between, you have to suck the smoke a little bit. So, eight watts. Bus. It's ready. Yeah. Now tell me, where is the stapedius tendon?
Already cut it.
It's gone.
In air.
Can you see this?
Yes.
Stapedius tendon is totally vaporized.
Right.
Okay, put it in the standby. Go to 12 or 14 watts. Wait. Now you are at 8, no? Stay at 8. I'll just vaporize a little bit of mucosal band here. Stand by. Go back to 6 watts. Minus. 1, 2, 3. Bus. Remain at that. Ready? वो एक साउंड आएगा पिंक करके No, actually there was some mucosal bands between the facial nerve and the posterior crus. I vaporized all that. Now I can see the posterior crus very well. Stapedius tendon is completely vaporized. I don't know if you can see that.
We can easily appreciate it, sir.
Yeah. Just 1 minute. Can you give a small gauze piece folded here? I will position this thing better. Laser is working wonderfully. No, थोड़ा मोटा करना. दो रोल. 2 या 3 रोल लेके थोड़ा मोटा करो.
Now we can get a good exposure.
Yes. Yeah, that's fantastic. Bus. Now, give me that sickle knife or the thumb instrument. Let me just. See, the foot plate is being protected, suction, by the gel foam. Yes, now I will go for the posterior crust. Yes, before that I think it is at 6 watts. Ready hai? On karo. I want to remove a little bit of the mucosal band. Ready na? Yeah, right now 6 only.
Excuse me, sir. Sir, this bands removal would be any benefit for the procedure?
Absolutely.
So we are going to remove the crush.
Now posterior crus I am going to remove.
Yes.
For that I need a very clear view of the posterior crus.
Fine, sir.
So my focus has to be perfect. Now you put it to 14 watts, please. Yes. Now I am on the posterior crus, very close to the base of the posterior crus. Ready?
Now, sir, is directly hitting to the crus, posterior crura. Yes.
Action.
It's already gone.
Now the just about ordered. Keep a small right arm, 45 degrees pick ready, or a fish hook. Action please.
No, that's why he put the gel foam over there, over the foot plate. First he going to, yes. You can see that there is a gel foam over the foot plate, just to prevent any kind of injury from the laser. So first he is doing removing the posterior crus. Then after
Suction.
that, once it get removed,
What is the instrument you use to highest joint?
usually either the
Okay.
pick or the sickle.
Give me the sickle. I think give me the, if you have a small right angled hook, give me the small right angled hook.
Yes. So, sir, is there any specific thing we have to remove the we have to cut out the IS joint first, or then we have to remove the crura, or we can remove crura and after that do that step?
No, see, I'll explain the whole step to you. Let me
Yes.
get this one step right. Oh, this is the IS joint.
No, no. Thing is that sir is removing the IS joint. Okay.
This
He
is a little
disconnecting that.
too bulky.
Whether this step should be done first or after the crura is cutting. I
Yes.
want to ask that thing.
I dislocated the IS joint
Yes.
here. Now I need to vaporize the posterior crus a little bit. Give me the, make the ring 0.5 or something. No, 0.9 crore. Let me see how is the focus. पॉइंट 9 किया नहीं 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 ठहरो यार आई एम ट्राइंग टू गेट द शार्प फोकस ऑफ द रिंग आई एम ट्राइंग टू गेट द रिंग इनटू फोकस यस if ring is sharp then laser will be precise, you know. Abhi 0.3 karo beta. This microscope shoulder is very stiff. Okay, now it's all right. Yeah, give me a small gel foam, the small one which you gave last time. We need to protect the posterior crus. I think you can see the foot plate very clearly now.
Yes.
We are just 2 steps away. Please just give me a little time. We are at what? 14 watts, huh? What is the wattage? 14, huh? Okay. Ready? Ready, hai? Yeah, I want the size to be 3 only. Suction.
The foot plate is already covered with the gel foam. Actually, already.
Yes, give me that small right angle pick or something which you had given me. Yeah. Wait. Yeah, put it in standby, please. Yes, we are almost done. I need just one more shot with the laser.
To release the crura.
Ready? Yeah. Suction. Go to standby. Smooth cut pick. Or you give me that right angle instruments what you gave me now, or some this is okay. This is a little too big here to break the superstructure. I'm scared. Give me something with an angle, no? Don't give me straight instruments. Give me the sickle knife or something. This is no, yeah.
This is too big.
Okay.
Oh.
Ram Bharose, it came out. Give me the suction. Give me the straight pick first. Yeah, give me the suction. I think the super
Structure is already removed. Yeah.
Can you see?
Yeah, sir.
Can you see the superstructure?
Yes, sir. Clearly
Can you see
seen.
the posterior crust vaporized by the laser?
Yes.
And the anterior crust which is white in color?
just fractured outside.
Absolutely.
Yeah.
Smooth cut pick. The beauty of the laser, especially the Boston Scientific laser,
Hmm.
is the foot plate is now rock solid. Because the most important in stepidotomy is not the fenestra, it is the posterior crurotomy. Suction. Now you please put it to 22 watts. Clean this. No problem. You can see everything clearly now.
Yes, sir. We are seeing clearly.
Because you can see the foot plate, the entire superstructure has come off. Yes. Okay, suction please. 22. What is the aperture now? Point. Make it 0.7 please. What is the size of the piston, Babu Moshai? Then make it 0.8. 0.8 is it? Okay.
Sir, could you please be specific at the site where you want to puncture this
Suction.
foot plate?
You can see the red ring. Hold this. I think give a small gel foam. There's a little bleeding there.
Yeah.
And carbon dioxide laser doesn't work well if there is bleeding. KTP works well when there is bleeding. So let me just keep a gel foam for a second. Dry that area. The spot where you have to make a fenestra
Yeah.
is, imagine that your foot plate is like a oval structure. You
Okay.
divide it into anterior half and posterior half.
Okay.
The posterior half you get divided into two. Anterior half and posterior half.
Okay.
The posterior crust is usually attached to the posterior half of foot plate, the last quarter.
Right.
So you make the fenestra just anterior to that.
Anterior to that. Okay.
So in the anterior part of the posterior half. That is also known as the falciform gut. The deepest area between the utricle and saccule.
Right, sir.
So even if your piston is about 0.25 millimeters longer, vestibule will accommodate.
Right.
And patient will have no SN loss. Suction. Now we go to the last step with the laser. Ready?
Where we have to put a fire station. Yes. That is the deepest part. If suppose, sir told you the very, very good thing. If you put a piston over there and it is bit longer, so that doesn't cause any problem. It will accommodate
Ready?
itself.
Suction. Yeah. You can give me a
Yeah.
0.6 mm perforator to just remove the bone dust.
No, actually,
0.6 hai.
thing was that sir was mentioning that point only. Where we have to put a fenestration. That is very, very important.
Yeah, this is where I am removing the bone dust created by the laser. Piston measuring rod, please. Suction, I'll remove the bone dust.
We can see that is a good fenestration in the foot plate.
No, but maybe it is about 0.5. I'll try to.
You have to make it big.
This is a single shot laser.
Right.
You remove the bone dust. Ask the patient whether she is hearing well. Pucho. Jod.
ম্যাডাম শুনতে পাচ্ছেন শুনতে পাচ্ছেন
Yes. Yeah, give me the 6 mm perforator. Let me just check the size. Yes. People talk about thermal injury, that, this, everything. Look at the patient. Patient is extremely comfortable with the shots that I took with the laser.
Yeah.
Okay. Now you give me the piston length measurer, please.
No, it was done with the laser. So and it was dilated with this.
4.25. 4.25 देना.
You had a vast experience of doing all this surgeries.
क्या बॉस? हाँ हम काटेंगे बॉस. छोड़ो. ऐसा है क्या?
Okay, so lunch is ready at outside. So those who have not done it till yet, please have your lunch.
Alligator forceps. Give me the sickle knife or something. Yes. You can give me that to open the eye of the piston. With crocodile forceps, no? Yes.
So
Even
which
with crocodile
sir,
we
which
can
piston you are using?
0.5 mm piston.
Okay.
I usually use 0.4 in Bengaluru,
Okay.
but 0.5 is also okay.
Okay. Is that titanium or silicon
No,
something?
no. It is basically
PVC.
Teflon.
Teflon.
The usual
Right.
Teflon which we have been using.
Okay.
It is the same thing, you know.
So sir, that measuring the length of the piston, that is very very important step in doing the stepidotomy.
Smooth cut pick, yeah. You give me a sickle knife or something to push it. No, I don't want that.
Hello.
Give me the sickle knife.
Hello.
Yes.
Sir, sorry to interrupt you in between. I was talking about that measuring the length of the piston. This is
Yes.
very very important step
Yes.
for this stepidotomy. Can you
Yes.
please enlighten a bit over there when you were taking the length by taking the measuring rod?
Yes.
Yeah, beautifully it is fitted.
Yeah, sometimes you know you are lucky in life. It sits well.
Some people are lucky every time, sir.
Yeah, no, this is a crimper, huh? Okay. Yes, give me the crocodile only. Yeah, crimped. I think Calcutta is my lucky place, isn't it? I became the AOI president here. So, smooth cut pick. The crimping is over. The length is okay. Patient has absolutely no giddiness. Or give me some pick, yeah.
Hello. Hello.
Yes.
Okay.
Those who can afford, laser is a wonderful instrument. I know it is expensive, but it is worth it, you know. See, my foot plate is rock solid. Give me the crocodile forceps, please. And it is sitting perpendicularly.
That's why he's doing again creeping. No? One
Yes.
more thing.
Now you give
That
me the
piston-
thumb instrument, the straight pick.
More thing is there. The ring
See,
of the
remember,
piston shouldn't at the distal end.
tomorrow
Otherwise it causes necrosis,
when,
because that was the most.
Oh, give me the
Yes.
sickle knife, boss. This thumb instrument is a little, wobbly.
Yes.
I better take the
It
sickle
will be
knife.
at
Yeah,
the
I'm used
mid
to
or the
this.
shaft of the this. Right. Yes.
See, now the corda comes next to the piston. Okay?
Okay, sir.
Hello?
Hello, sir.
Corda comes next to the piston. So tomorrow when patient comes into the upright position,
Okay.
this piston will not slip in any way.
Okay.
Usually the lenticular process will keep it that way. Even then, this is a double insurance. Right?
Right, sir. Agreed with you.
And one small gel foam, very tiny gel foam, please. You know, the ultimate trust in human life is an accomplished stapes surgeon who has done a successful stapes on the other side on the same patient, allowing another surgeon to do the stapes.
Yes.
Because in this surgery, the margin for error
Is very, very less.
very, very less.
Not acceptable. Gel from to sport the
Sir. Sir,
Hello?
coming in? Sir?
Hello, you are very happy. Hello?
Hello.
Yes.
Hello, audience.
Yes, sir. Yes.
We are very happy
Yes, yes,
to
yes.
see the Dr. Soldipur's
Yes, yes,
laser
yes,
stability,
yes.
okay?
Yeah.
Now, if you have no laser, then how
Yes.
will manage basically?
Yeah.
Yes.
Then you should do, no. So, laser, when you are in peak in practice, then you should buy, no?
Yes.
You are able to buy. Otherwise, not possible to buy. Okay?
Otherwise, best do it in a center where they have bought the laser already. Yes.
Otherwise, how will manage this case? I will show this how will manage without laser, okay?
No, that can always be done.
Hello?
I have done it with only curate, I have done all that is fine. But what I am trying to say is this definitely an added advantage
Yes,
if you have a
laser, if you have laser, then no doubt about it, is basically
Yes.
riskless surgery.
Yes.
Zero risk.
Sir, one thing I just want to ask.
Yes.
That the defect you already made in the, to approach the stapes,
Yes.
is there any need to recon that defect with the soft?
No.
Or is
One
there
thing,
any
see
later on?
again, if you don't remove the anterior spine,
Okay.
Barinda that taught us that there will be no retraction.
Okay.
Because usually
Hey,
stapes
hয়ে গেছে তো
patients
মোটামুটি।
have
দেখো না গ্রাফ
a good eustachian tube function.
Sir, one more thing I just want to ask.
Just one
they will
second.
Hello.
Ah,
Some people used to put cartilage
Hey.
over that piston just to
আপনি ছেড়ে
prevent
দিয়ে
the
আসতে বলুন, এবার
expulsion
shift করতে
or
বলো।
lower the
এটা
expulsion
ক্যামেরাটা
rate.
শিফট করে দেবো না এখানে।
no,
So what is your
piston,
take on that
এটা
point?
ক্যামেরাটা।
almost
Hello?
never gets extruded.
না, আমার
Maybe
এন্ডোস্কোপটা
if you
শিফট করো
put
না।
titanium, you may need to do it. I don't know.
Okay.
But I have seen Satish Jain doing a lot of titanium. He never puts any
রেডি?
cartilage.
হ্যালো?
Right,
And
right,
he's
right,
getting
right.
a
Hello?
very good
Right,
result.
Hello?
Right.
You know.
Now,
And,
Dr. Deepak sir, please come this hall, please. Dr. BKC sir. Hello?
Hello.
Uh,
Yes, sir.
okay, this is the case of again another left-sided stabilotomy, right-sided by me. This
Okay.
patient came from Manchester, basically Manchester, England.
This is
This case,
right side or left side, sir?
This is the left side.
Yeah.
Okay. This case was done by me 1 year back. First started in Manchester, but anyway in midpoint they stopped the surgery. Okay.
Okay.
Any problem face? I think then I have done revision case. These patients I am doing this case left-sided cerebrum. Okay.
Okay.
Left sir, can you share the? Hello. Sir.
So we are getting the picture
Now the picture is ready.
Yes.
So patients is very much interested to do step is by me. Basically, I have done that another year. Return from Manchester. No.
Okay.
So this is the exposure. Good exposure required. If picture quality okay, fine.
Yes. It's excellent, sir. Yes. I think you already put an endoral incision. It gives you the good exposure.
Yes, yes. Already
Yes.
done. No. Otherwise, time loss will be there.
Yeah.
So same. Basically, I always prefer the endoral incision. No headache. So that incision, that slight bit of incision makes the difference. Basically. Our tight. Okay. This is the exposure. I think good exposure. No.
Excellent, sir.
My assistant have done this exposure. Basically, to shorten the time. No. Look here. Now I am using the drill. Okay.
Okay.
The indigo drill and dry drill. Definitely dry drill. Look here. How the movement of the drill. Okay. This way. For junior, this way. Inside out. Medial to lateral, because there is a chance of, otherwise if you not control, the chance of injury. Look
So,
here.
sir, last case when Dr. Haldipur was doing the case, we were discussing about he was doing the dry drilling.
Now dry, we prefer also dry, but slight bit of water.
Okay.
Now I also prefer the up to pyramid. Okay.
Yes, pyramid is exposed now.
This way.
Yeah, stapedial tendon in the view.
Now the exposure. Okay. I think picture quality is good. No.
Excellent.
I am not putting the laser basically. Basically,
That haziness is because of laser only, huh? Maybe.
now you see, I think foot plate is very narrow. So how I will manage basically? I always prefer reverse, because I believe there is a chance of submerged foot plate during fenestration if you have no laser. No.
Yeah, we can easily appreciate.
If you have
it is
laser,
visible. Yeah.
no problem. Otherwise, sometimes there is a chance of floating submerge. Basically, chance is less, but still, when you face this is the 100%. No, for patient, one patient, if hearing problem, then patient's problem is the 100%. So now all will be intact. Look here, all will be intact. No. Hello.
Hello.
All are intact. Look here,
Yes,
all are intact.
yes,
Checked.
yes.
And at that time, I will do fenestration. Okay.
So, sir, first you prefer to do IS joint discontinuation?
No. There is a
First-
separate technique I will follow.
Okay.
Look here. Look here is small, small second. This is the different technique I will follow.
Right.
All will be intact. At the time I will do fenestration. Okay. So my target is the 0.7. So I first control fenestration with 0.5. Check. Look here, movement checked. Okay. Now this is the measurement. Just do measurement.
So this is very important because size, length of the piston is the only
Very
thing.
important basically.
Yeah.
Here I will put
Can you please enlighten
Explain.
this? What is the how do you measure the length of this?
This is the
very important step.
three point. Here I will put the from foot plate to here.
Yes.
Below the incus.
Okay.
And here, look here.
So
And
you are
if-
taking the
if
length
here-
from foot plate to
If here,
Okay.
then 4. If here 4.25, here 4.5. So here 4.4 and I will add the 0.25.
Sir,
So I will place
my question is that you want to take a length from foot plate to lower border of the incus or the upper border?
No, midpoint basically.
Midpoint.
Huh.
Okay.
And I will add 0.2.
Okay, then you will add 0.25 over there.
Now I will fenestration. You will look here, posterior part, all will be intact at the time I will do fenestration.
Okay.
And
So
that's left side, my left hand with the.
if we want to make a stepidotomy, very simple procedure. Whatever foot plate we are seeing, we just do the fenestration. That's
Yes. Sometimes not possible, then I do only posterocleidomy. First
Right.
posterocleidomy.
So just
In my
a bit
YouTube, I will explain every step.
needle only.
This is the fenestration, okay?
Yes.
So if you have no laser,
Yeah,
basically.
we can easily appreciate it, sir.
0.6. Now the good fenestration, no?
Yes.
So all are intact, so slight bit of tension free.
No headache.
Yeah. Surgery should be done under less headache. So you will enjoy the life. Box.
Sir, there is a question. If we encountered the facial nerve descents, so
Then I will do posterocleidomy first.
Sorry.
Then I will do posterocleidomy.
Okay.
Then I will create the space.
Okay.
Then I will do the piston place fenestration.
Okay.
Then after that posterior placement of piston, then anterotomy.
So you're talking about when facial nerve is like a bit down. If suppose you encountered a case, you open that and you feel that there is a facial nerve is overlying this foot plate.
Very rare. So all are theoretical basically.
Sir, it is
All
rare,
are
but
theoretical. Basically,
no, sir. It is not theoretical. We already encountered one case. That's why I just want to ask you.
Basically,
What is
foot
your
plate
take on that?
sometimes is there, but
Yes.
slight bit of space will be there. If not there, not possible to do.
Because I think we never, very less chances when we get the scan for the stepidotomy. These are the intra-op sometime
This
surprise.
is the only intra-op possible.
Yes, these are intra-op surprise because usually we not get the scan for each and every stepis case. If we encountered like facial nerve is
I
lying
don't
over
do
there.
every case the CT scan.
Yes.
Yeah.
That's why I'm asking. If you encountered
Yes.
intra-op,
Now you
facial
see,
nerve is
now
covering
you
the
are,
foot plate.
my exposure is good.
Yes,
You
it's
enjoy?
very
Yes,
clear.
I
very
will
clear.
do the piston placement at that time. Hey, Dr. Holdipur kaha?
Sir is, I think, he was here in the hall.
Yeah. Then I put the piston. Now put the piston. This is the beauty of this technique.
Sir,
All will be intact at the time. Please piston. Place the piston.
okay.
Okay. Edao.
So, what is the exact size of the piston you are
Piston.
after measuring
This
this?
is the 0.5 diameter piston.
0.5 diameter and length?
Length 4.25.
4.25. Okay. Sir, and the fenestration you made, what is that size of that fenestration?
Oh, size I have done with Storz perforator.
Okay.
0.5, 0.6, 0.7.
Okay.
Basically, I prefer 0.2 millimeter extra.
Right.
Picture quality okay?
See, when 0.7 is there,
Hello, audience.
what is the difference between 0.7 and 0.8? Already
Hello, audience.
In that point, yes. Hello.
Picture quality?
Yes, it's very good, sir.
Very good, okay.
So there is a question from the audience, sir.
Now, 1 minute, just
sure.
putting the piston. How
Yeah.
is the putting the piston? This is the technique.
Later on we'll discuss.
Just-
Please proceed. Huh?
Just first in the fenestration. Look here
Okay.
and go the fenestration, and after that you place the over the incus. Okay, just go the fenestration first, and sorry. Basically, this is the technique. Okay, I'll manage, no tension. So first go to the fenestration, okay?
Okay.
Then
Hello.
Hello.
Sir, there is a question from the audience. Can you show us how you hold the piston?
Yes. Now the slight bit of angle.
Okay.
Slight bit of angulation. Look here in a microscope. Look. Look here. My piston, slight bit of angle. Look here.
Okay.
And here, if now first I put the piston in the fenestration, okay?
Right.
Then I put the then over the incus, okay? Normally, in one chance, but
So at this part we can use suction also. Yes, yes,
Yes,
yes,
yes,
yes. Because microscope, when we doing the microscopic stepitotomy, this is the another advantage when we are putting the piston inside. Because this step, single hand is very, very difficult. We can take a spot from the suction. Yes.
no, basically I am not facing any problem.
This is advantage.
But today I am facing only problem, I don't know. But still manage, no problem. Now the technique is the first target is the fenestration basically, okay?
This is the advantage of this.
Then piston. So
can use your both
what is the tension free? Why tension free? All are intact, no?
Yes.
At that time I am trying to place the piston. So basically tension free. Space is less but tension free.
Headache free.
And then I fix it. Then fix it, okay?
Yes.
So now, okay? Now just use them the skitter, okay?
Hello.
Skitter 1000 করো 1000 speed.
Hello.
I will use the 1000 speed skitter.
সুবিধা এখানে কেউ একটা দাঁড়াও কেস হচ্ছে তো আবার দৌড়ে দৌড়ে পড়ে
Hello. Sir, there is a question from the audience.
Yes. Yes, sir.
তুষার
Hello,
ডক্টর
Subodha.
সুবোধ মুখার্জি
Hello, বলুন।
হ্যাঁ বলছি ইজ দেয়ার এনি ইউটিলিটি অফ টেস্টিং দ্য রাউন্ড উইন্ডো রিফ্লেক্স
No, normally no. In revision case, yes.
ইন রিভিশন কেসেস
Yes, revision case, yes. Because I have seen no proper foot plate. If you interested, I will check, but not required basically.
Yeah.
If you are interested, I will show the round reflex, and also the one master of stepis surgeon also, sir not seen also properly. Look here, the round reflex, no?
Yeah.
So now I am doing the posterior crudotomy, no?
Yeah.
If I do the stepis, in case of stepis surgery, the main is the posterior cruda management is the main basically. Now focus it first. Yeah, let's focus. Okay, fine. Now with the skitter, I will do the posterior crudotomy. With laser, definitely more comfortable, but with skitter also possible. Hey, কি হচ্ছে? ঠিক আছে. Now with the skitter, now posterior crudotomy gone, okay?
Yeah. Follow the posterior cross.
Slight bit of movement is there. That movement will be obsolete with the laser. And now I will use the another instrument for anterior crudotomy. I will try to preserve the stapedial tendon. Okay. Here, this way, I'll do the enterochrotomy.
Okay. Sir, you're preserving the stapedial tendon. Is going to benefit?
I'll preserve the stapedial tendon.
Is it going
I
to benefit?
told no. Here
Okay.
2 lesions is there. First step is,
Uh-huh.
and I am doing the different technique
Right.
also.
Right.
Okay, so different technique.
We just want to know, is there any going to benefit?
And
the
audience will
procedure?
enjoy different technique. Now the movement started, okay?
Yes.
So here step is already done. So just within a 15 minutes step is surgery will be done. But if you are not happy, sir, how will anterior cruda was there? So I'll remove it. Okay. So here to show you that I am correct. Yes, sickle. So I am correct to show you I am correct. I will do dislocate with the sickle knife.
It's
Just this way,
already
okay?
dislocated,
Look
yes.
here, already I have
Yes.
broken with this my instrument, okay?
Yes.
So why this technique? Basically, I adopt this technique because there is a chance of submerge, piston placement difficulty, all will be overcome
Yes.
by this technique.
Right.
Any junior may start this technique because the headache free. I missed initially because the extension I think and a lot of pressure also in workshop. I missed the first time. Otherwise, doing regular step is I don't miss basically piston placement problem. But here today I missed one chance. But you see, the all are intact, so no problem at all. No.
We are totally agreed with your point, sir. We totally agreed.
Yes.
Because when it is intact, it is firm,
Yes,
and
sir.
in
Now
case
just-
mobility is not there, and it is very easy to put the piston.
Yes.
Yes, very easy.
Now the step is surgery done. No.
Yes.
Yeah.
Yes.
Now operation done. Look here.
Great, sir. Great.
Just
Yes.
10 minutes
Excellent,
or 20
sir.
minutes. No.
Excellent, sir.
So patients hearing, Momita, ভালো শুনছো? Fantastic, good, thank you. Patients hearing fantastic, okay?
Without
check the
flap,
movement.
without flap, he is hearing so good.
Yes,
After
and
the
now
flap, she is
beautiful.
like,
Now sound is okay?
yeah.
Hello, Momita? Yes.
Yes.
Okay, fine. You came from England basically.
Okay.
She not believe in England surgeon. So she believe in mine. So I targeted. I will do that case definitely today.
She is blessed to undergo
committed.
surgery
Okay.
with you, sir.
So fantastically done. Okay, definitely you will enjoy this surgery, no?
Everyone enjoyed the surgery, sir.
Yes. Thank you so much.
Thank you so much, sir. Thank you so
enjoy
much. It was a nice
this
demonstration.
simplified stapedidomy. I mentioned this is the simplified stapedidomy. Sir, enjoy. Oh, I mentioned one. I am lucky today. One of legends front. I am doing the stapes surgery basically. I adopt initially the technique from the BKC. After that, some change I have done during the surgery. Okay.
Okay.
The skitter, anterochrotomy, posteriorchrotomy. But main target is to preserve the stability. In that I adopt the from BKC sir.
Thank
So
you so much, sir.
Enjoy
Thank you.
the surgery.
Yes, yes.
Again, sir will do one steppies, another. So two legends already done. Will do different way. Another, I am junior person. I am done different way. Okay. And also one case I will show simple only drilling part inside of mastoid.
Right.
Just within 15 minutes, how the mastoid will be very simplified.
Okay.
Mastoid exposure will be done. I will show only drilling part. How will be inside of mastoid drilling part will be there in any cholesteatoma case. So here, if you know the stapes surgery, no, you will be the master of mastoid surgery. If you follow the endoscopic or inside of mastoid, so only main part is the suprastructure and fascial nerve and say lateral semicircular canal. This is the main funda of this mastoid surgery. But if you control, if you work from baranda, always you will see every structure will be there. So no tension. Don't go the ground floor. You will love to do see every time processus cochlea formis, suprastructure, incus, lateral semicircular canal. Every structure will be there. So you will do. I will show only drilling part. Then my assistant will do every job. And after that, sir will do one steppies. And also face will be done by Dr. Deepak Khuntipur. Okay.
Okay. Thank you.
I'll
Thank
show
you so
only,
much, sir.
only drilling part inside mastoid. How the inside of mastoid and made easy, mastered made easy. Otherwise, time will be not there to show the total mastered surgery. Only
Okay,
drilling
sir.
part, I will show the drilling, 15 minutes drilling, and mastered will be exposed totally. And suprastructure, all everything will be there. After that, osteoplasty all will be done. Okay. We will prefer the osteoplasty also.
Yeah.
Hey, ready হয়নি এখনো?
Hello, OT. Hello. Hello. Hello.
হ্যালো তুষার তুষার খেয়ে নিয়ে তারপরে আবার আরম্ভ কর
হ্যাঁ না 5 মিনিটের মধ্যে কিছু করে দিচ্ছি ততক্ষণ
তুই আগে খেয়ে নে না খেয়ে নে
ঠিক আছে
খেয়ে নিয়ে তারপরে কর 5 মিনিট
দিলে তো ঘুমিয়ে পড়বে
10 মিনিট কর
5 মিনিটে ও খুলে দিচ্ছে তারপরে আমি এসে শুরু করে দিচ্ছি
তুই 5 মিনিট ভালো করে খা
কেসটা কি can somebody give the case summary?
হ্যাঁ কেস সামারি কাউকে বলতে বল আর তুই আস্তে আস্তে খা
হ্যাঁ হ্যাঁ না আস্তে আস্তে
Case summary.
ও 1 মিনিট জাস্ট এই আমাদের ছেলে কেসটা একটু বলতে থাকো
দেখা করে গেছে ওর বউ হয়ে গেছে ডিন হচ্ছে বটম প্যান প্রিন্সিপাল না ডিন বললো ও প্রিন্সিপাল তাহলে ও আমাকে বলে ডিন বটম প্যানকে ফোন করে বললাম তো করে দিই রেকমেন্ড করে দিচ্ছি বউ এসেছিল সেদিন আমাকে
ফোকাস করতে বলো ফোকাস করতে বলো
কি ফোকাস করবে তো এটা এমনি ওটির পিকচার আসছে ফোকাস তো মাইক্রোস্কোপের পিকচার আসুক
কান করছে না
জেগে উঠেছে ঘুমিয়ে পড়েছিল ঘুম থেকে বলে ফোকাস করুক
আসলে ওনার কথা বলেছে তো মান্য করছে
এমনি ফাইন্ডিংসটা কি ছিল স্যার একবার একটু আমি তো এখানে খুলেছি হ্যালো
অতি নীরব কেন? একটু একটু বলুন আমাদের
Hello?
কি আছে না আছে।
The patient is a Mufujil Sheikh, 36 years old male. He presented with complaining of right ear discharge. On examination. Okay.
Yes, please.
This is a 36-year-old male patient presented with complaining of right ear discharge. On examination, we find that the patient has a hearing loss in right ear 51.6 decibel and cholesteatoma and granulation tissue in the ear, right ear. We plan for right mastoid exploration, tympanoplasty and ossiculoplasty.
What is the perforation? Attic or posterior marginal or central?
Posterior marginal perforation.
Acha. And CT scan or radial findings?
No, we do not do CT scan regularly.
Okay, CT scan was not done. Audiogram?
Sorry? Hello?
Audiogram?
Audiometry, the hearing loss is 51.6. 51.6 decibel hearing loss in right ear.
Acha. No radiological test was done?
No.
Oh, na radiology koreni bolche. Okay.
Sir, hot.
Hello. Can you hear?
Hello.
Yeah.
This is the Mufujil Sheikh, came from
Mohammed
basically
Mofidul.
ear discharge for 2 years, 3 years.
Recurrent ear discharge.
Recurrent ear discharge, atic one-sided atic retraction, one-sided atic retraction with cholesterol basically.
Yeah.
Posterior superior or atic basically. The drawing is there, posterior superior, perforation with cholesterol.
Yeah. And
Now I'll show.
Preoperative radiology means X-ray mastoid or CT scan?
Basically, I don't prefer the X-ray mastoid. We do regularly UM. Examination of microscope or endoscopic picture. Okay.
Yeah.
So this is the, and also why not believing the CT scan, I will show the during surgery. Because I believe CT scan does not make a change in my life during surgery. Basically, only in complicated cases, CSF otorrhea or facial paralysis, that will change. In atic cholesterol cases, CT scan does not make any change during my surgery. Because I have seen the pathology is there, I will do, according to pathology, I will do drilling. So that is regularly not essential for me in my hospital protocol. So I am not doing the regular way CT scan.
Okay, but there are some absolute indications of CT scan preoperatively, like complications.
Yes, in complicated cases and young age sometimes, in complicated say in facial paralysis also, definitely abscess or fever, sometimes heavy semicircular canal fistula. There is, but routine atic cholesterol case we still now we don't do regularly. In case of stapes also, some surgeons also doing regularly CT scan, but I don't prefer also CT scan. In face surgery, definitely their requirement, because though why unnecessary I will do the sphenoid sinus opening, why I will do the frontal sinus opening, but here you think here, because I will start from the atic region. Okay, so according to pathology I will do. I don't believe the pathology will start from the antrum and there stop. But if you see the pathophysiology, if you understand the pathophysiology, to start the atic or posterior superior or any from middle ear cavity. So why unnecessary if I do the cortical mastoid, if I think, but here does not make change during surgery. I will show this technique inside out mastoid and beauty of inside out mastoid surgery also. Okay, just give me 5 minutes and
But in revision surgeries, the CT scan is definitely mandatory. Definitely.
একটা অনেক গ্রস আইডিয়া আগে থেকেই পাওয়া যায় যে এতটা ডিস্ট্রাকশন আছে একটা এক্সরেই না করবে তাতে কি ক্ষতি আছে এমন যদি এক্সপেন্সিভ ইনভেস্টিগেশন একটা
Second surgery বা second opinion দিলে না Yeah, Dr. Tushar. Hello. না ওটিতে নেই মানে ও তো সার্জারি করছে
কেউ কি আছেন যারা লাঞ্চ করেননি এখনো? লাঞ্চ শেষ হয়ে যাবে। সবার হয়ে গেছে? ঠিক আছে, থ্যাংক ইউ। তুষার করছে দীপক হলদিপুর ফেস করবে ফেস
থাইরয়েড কে করবে
থাইরয়েড জানি না
হ্যালো অডিয়েন্স
হ্যালো
হ্যালো রেডি
হ্যাঁ
সুব্রদা
হ্যাঁ বলো
এই তো এসে গেছি সো I'll show only drilling part. After that, we can see again steppies and another phase. After that, microscopic thyroid, and lot of cases they are pending still.
Yeah.
Packet এখানে রাখো। Now a picture ready. A picture is a endoscopic picture যাচ্ছে চলো so now ready already exposed okay sir picture is ready
yeah
now the magic of mastoid surgery inside out look here
yeah
look here
malleus is visible
yes now you see how I will start. Basically, my drilling and drill is be slight bit of small. Basically, here I'm starting here. Okay.
Yeah.
Don't worry. Anywhere, don't worry.
That is the scutum region.
Yes. And I am doing the etic. So no tension at all because my guide with the incus will be the guide. Okay. So outer etiqual, don't go the ground floor. Okay. How will simplified mastoid I will show. So here, look here.
And here in the attic, colostomy is visible.
Yes, colostomy visible. So mastoid will be done very fast if we follow this technique, okay? Now, so now anatomy will be visible. The colostoma, the landmark is the colostoma.
Yeah.
So if I do CT scan or not,
Now
no
follow-
difference basically.
That is the following the path of the cholesteatoma.
Yes, I'm following the path of the colostoma. This is the lateral semicircular or will be the incus and also now drilling, okay? So unnecessary cortical I don't prefer. No way we are not doing the Kalloilak, okay? So here, look here.
It is towards the editus.
This is the look here. So facial nerve is the here, no long way. So here, hey, master bhai, tu sir ke study do na step is. So look here, the very fast master surgery and look here, my change of direction, no?
Yeah.
You see?
Yeah.
So beautifully, you look my change of direction. Okay. Look my change of direction. So according to pathology, and here to understand the pathology,
The editus has been opened.
যেটা মার্ক করা আছে look here. So now antrum is ready, no?
Yeah.
So it's simply, no? Look here.
Editus already opened and you are just entering the antrum.
Now the magic started. So already dealing no tension to open the mastoid, no? It's a simplified mastoid.
Anterior to posterior technique.
Yes, look here. My dealing. Ultimately, sometimes outside in or inside out will be same. But I do here the cholesterol is there. So I'll remove the incus and technique. I'll show the technique how to preserve the stapes. Basically, if you understand the pathology, so so this is the incus area, okay?
Dr. Tushar,
bolun.
the sound coming from the OT is a little bit less. The sound coming from the OT is a little bit less.
Yes.
Kindly ask him to raise the sound a bit.
Hello.
Hello. Now it is.
Now the volume is okay.
Yes. Okay. Now, okay. I am encountering the incus. How? Basically, this way, because the anyway chance of suprastructure injury. So I'll remove this, okay, and keep it. And you see the now anatomy is there, okay. So your understanding of area will be clear now. This will be the semicircular area. This will be the chorda, okay.
Yeah.
This will be the suprastructure area. So I will remove it here also. The semicircular canal will be there, okay. Now I just zoom it slightly so picture will be more comfortable, no? Now the picture is clear?
Yeah.
ঠিক আছে. So basically why mastoid surgery is very dangerous, because the suprastructure knowledge and knowledge of facial nerve, this is the main. So this I will do the drilling here, okay, but this bar is not suitable. Hey, small bar. So here, look here. During stapedotomy, this part also remove, no drilling. So small.
That is the portion. That is the portion of the bridge.
Yes. So I will show after drilling, every structure is very much clear. Look here. Now the chorda, okay?
Yeah.
So no fear of the facial nerve, because the facial nerve. Yes. So here, all structure will be visible. So I am working from the veranda and first floor, okay?
Yeah.
And all important structure is the ground floor. Look here. Okay. So friction is a long way, no? So just if you have a Malias cutter, you will remove it. But here already I will remove here. So here the possessor's cochlear formes. Now the possessor cochlear formes you have seen. The coda.
Yeah.
So here will be the facial nerve. So no fear of the facial nerve because you are seeing the here from here.
That is the tympanic segment of the fallopian canal.
Yes. The possessor cochlear formes.
Yeah.
Here the semicircular canal. Okay.
Tendon of tensor tympani is visible.
And the stapedial tendon will be the here. I will drill sometimes.
Tensor tympani tendon.
Yes.
This is the tensor tympani tendon.
And also you see the anterior buttress, I will drill it and you will see every structure. So no fear at all. Look, choto diyecho. So here picture quality is very good, I think.
This is the anterior attic.
Yes, ওড়নামোদা আছে তো?
ওড়নামোদা আছে।
ওড়নামোদা হ্যাপি? ওড়নামোদা স্টুডেন্ট কিন্তু।
ওড়নামোদা একটু বাইরে গেছে।
হ্যাঁ ঠিক আছে। এই দেখুন anterior now no tension because this is the semicircular canal. So I will show how semicircular canal will be tackled without CT scan also. Sometimes I will do the posterior canaloplasty also. People ask me how much you drill. So why fear basically? No, I am seeing the every structure, I am drilling it up to possessor's cochlear formes and anteriorly and also pyramid. So no problem, no. Now
you have to be well conversant with the anatomy, so that chance of injury to the facial nerve.
See how much beautiful, no, easily mastered will be drilled. And also I will do one master class and August, okay, 20th August already date confirmed. Look here, master class in otology. This now this is the drill. So I have seen the cholesteroma. So here you see now you see already I think now I'll see, you see first I will do take the side knife, how will manage. Look here, this way, just this way, because there is a chance of fistula in the lateral semicircular canal in cholesteromasis. So I ask my assistant, all juniors, please do this way. All time you will think fistula may be there.
Yeah.
So according to, you just take the cotton ball and slowly you will do this side knife.
And just
okay, and you will see the semicircular canal, okay?
That is the thickened master.
Here you the facial nerve, okay? This is the facial nerve, okay? So this is the facial nerve.
This is the external.
So all time, this is very much easy. Now this is look here how I'll operate here. Now you see the
thickened mucosa with granulation tissue.
Now most important here the suprastructure, tip sucker. I will take the tip sucker and এই এক কাজ করো তো, হ্যাঁ 4 নম্বরে Now you see, this is the main part, no?
Yeah.
So lot of surgeon
There is the retrotympanum area.
and also suprastructure is there.
Uh,
So here, just be careful. This is the main structure because this is the suprastructure, and we should preserve the stapes. So this is the area. Look here, how we'll manage. This is the important area. If you manage the fascial, you know the fascial nerve, and this is the structure. You preserve it, then master surgery will be very simple.
Tushar,
Yes.
Orunavada has come in.
Orunavada. Orunavada student ami. Orunavada.
Thank you very much for the beautiful operation which we have seen and seeing.
Yes. Thank you. Yeah. Orunavada inside out korlam eta.
Beautiful.
And even easy technique. Basically, simply I am showing the Simsek canal, I am showing the process cochleoformis, okay, the facial nerve, I will show everything like simplified master surgery. So why master tension? Because the facial nerve tension. So if you know the properly facial nerve and the suprastructure properly, so why the harm?
It is my pleasure that you being my MS student
Yes.
is doing so nicely, eta bhaba jay na.
Thank you. Thank you, sir.
Thank you.
You see, this is the stapes suprastructure. I will preserve it and do the osteoplasty, okay? For audience, this OT was named with Orunava Sengupta, Professor B.C. Das, and also Utpal Jana. And award also named by Professor B.K.R.C. Okay. And also auditorium named by Dulal Bose and Professor Santur Banerjee. Now here, this is the more important steps. No, Joldi Baji. So this is the pyramid area and stapedial tendon. So here, just move your head. If not comfortable to do here, do canaloplasty more. So your control will be more. But here I think possible. Here the facial nerve. So my direction change. Cotton though? Small cotton. Here.
Hello.
Hello.
Sir, Dr. Bhushan here.
Yes, sir.
I just want to discuss a few basic things here. Now you are dealing at the suprastructure region. Is there any specific stroke you are making to prevent the injury over here, like parallel to the suprastructure or like horizontal, or like the which part you have to address first, at the pyramid region or the foot
Sir,
plate region?
basically you just should know the incus area, okay?
Yes.
During incus removal, dislocate the joint.
Yes.
And remove superiorly, okay?
Okay.
And slowly I have seen the facial nerve. This is the facial nerve.
Yes.
This is the
It's already clear right now.
now the all will be clear, and slowly I have cleared all epithelium, okay?
So if you find it here, like removing the granulation, you find it that foot plate is bit mobile. So what is your take? You want to stop it here only, leave the granulation for the itself, or you want to remove each and every part of granulation?
One sitting. I always do one sitting.
Okay.
If foot plate is there only, still then.
If I think somebody left the granulation in behind, I think that is not
I'll
wrong
remove
also.
every granulation tissue.
Is the surgeon preference what he want to do at that time?
Here I know preference of second sitting, basically.
Yes.
You see, now the nearly clean, no cholesterol, only epithelium, okay?
Yes.
And here you see, if you are interested more, I will drill slight bit
So
of.
can you show us the sinus tympani region?
Yes. Why not? There are three ways. Just put the head this way, okay, and
Yes.
also drilling posterior part, all will be seen, okay, or may use the endoscope.
Okay. What you used to prefer? Take an endoscope over here, or you want to do more
No,
drilling? Yes.
sometimes endoscope is very rare.
Okay. Some people nowadays use a hybrid technique for
Hybrid technique,
to the,
okay, good.
yes, for the mastectomy. What they used to do, even some cases I used to prefer the hybrid technique. The middle ear part I used to address with the endoscope, do sinus
Basically,
tympanic clearance
that,
and the
that,
epitympanum
that
and the
I am
attic.
telling every day my assistant,
Yes.
please, all you should do inside out bar, diamond.
Okay.
Inside out, otherwise endoscopic surgeon after 20 years, they will do everything. Because they
Yes.
will do this way, no?
Right, sir.
Inside that technique. So,
Agree
we are
with
more
you.
comfortable with the microscope every day, no?
Right.
From born, so we are doing the this type, no, this technique. In my PG,
It's very, very.
this adopt later on my during practice.
You can put anywhere if you want to see anything. You're not.
You see,
Yes. Even anterior attic in the attic region, superior attic, everything we can.
look here the how cleanness, no? I am
Yes.
seeing everything. So why fear, no? Is the facial nerve and all granulation tissue, no tension at all.
So
So this is the step is okay. So you see now beautiful. So if you want to see in between two crura, I will show this also. But here epithelium, I think.
তুষার ব্রিজটার একটু নামাবি
হ্যাঁ নামাবো না ব্রিজটা অলরেডি নামিয়েছি এটা দেখো দেখা যাচ্ছে পুরো না আমি একটুখানি এটা একটু রাখার চেষ্টা করি আমাকে অল ওয়ার্কশপে সব কোশ্চেন করে এটা একটু রাখো কেন কারণ হচ্ছে আমি মেয়েটা ইয়ে করি তো অস্টিওপ্লাস্টি করি তার ফলে আই ওয়ান্ট স্লাইট বিট অফ ক্যাভিটি অফ দ্য মিডল ইয়ার ফর গুড হিয়ারিং Yeah, now you are happy, no?
So
Look here, all epithelium clear.
What's the said lesson you think about the posterior wall? Okay.
So that the cavity, middle ear cavity will not be too much shallow.
Hello.
Mastoid,
Sir.
Yes. Mastoid, nothing. This
Sir,
is the
picture
mastoid basically.
It is there. Right.
Look here, only 15 minutes. No, I'm spend only 15 minutes. Main job is already done. If I'm not interested to show anything, my assistant will do the job. Next job, no. Simple graft placement and also osteoplasty. So this is the main part of this mastoid surgery. So mastoid easy, mastoid made easy, simplified. Mastoid simplified. How? Basically, this part is the main. Look here. Possesses cochleoformis, anterior buttress, posterior buttress. Here already down. You look here, Urunamoda. Already facial nerve already seen properly. The semicircular, lateral semicircular canal. So slight bit of drilling also required. Also, next case ready?
Hello.
Hello.
Sir, there are few questions from the audience.
Yes.
So first one, I just want to ask, what about the facial ridge lowering? So,
sir, I think this is all theoretical basically. Oh, facial ridge, how much over?
there are.
Sir, basically you should see the basically facial nerve. Okay.
Beside the theoretical things, there are some literature and some people what they are doing, and they are putting a point over there. If sometime we encounter the weeping cavity, some surgeon they suggest we have to lowering the facial ridge and make a single cavity from hypotympanum to up to the mastoid entra.
Sir, basically,
yes.
Main funda. What is the main? Basically, disease-free ear, no?
Yeah.
So all cavity. Sometimes if cholesterol is less, here I will stop the drilling here.
Okay.
Sometimes cholesterol is less, all my drilling will be here. Stop.
Right.
So according to pathology, I will drill. Okay. And place the graft.
Okay.
And sometimes small cavity, sometimes the big cavity, sometimes unnecessary cortical. If you do cortical, then you will think all type. because the facial ridge, facial sinus, all you see the pathology, no. My target not to drill. This is my main motto. Not to not use the cortical word basically. Why? Basically drilling, unnecessary drilling. Just do the remove all the pathology, no, unnecessary. Then look here, I am everything clearing. So unnecessary again. Why drilling? I am seeing the round window, no pathology is there. For the reason I am telling no.
Dr.
The
Tushar,
master made easy. Bolo?
this is a canal wall down procedure.
Yes.
You have
that
done a
is
canal
also-
wall down
that
procedure
is also
basically.
I disagree. I always though sometimes canal wall up, canal wall down. I don't agree with this technique also. If you nomenclature is the cortical mastoid, then definitely you should do canal wall mastoidectomy or down, canal wall up or
Cortical
down.
mastectomy is a canal wall up technique.
Bolo?
Cortical mastectomy basically canal wall up
basically
technique.
cortical
But
mastectomy.
when
if
in this
cholesterol is
particular
there,
patient,
if cholesterol is there, if you don't do the canal wall down, then motamoti 50% recurrence chance will be there.
yeah.
Okay.
Can-
For that reason, canal wall down. But my main motto, forget it. My main motto, do like endoscopy, no? Do see the cholesterol and do drilling according to cholesterol. If cholesterol finish, then stop the drilling. Unnecessary. Why drilling? Basically, cholesterol not jump from here to here. No, like
actually,
no cancer.
actually pathway of the cholesterol should be followed.
Yes.
So that when the
That is
cholesterol
the main-
stops,
main.
your surgery will stop there.
Yes, yes, yes.
Yeah.
What this main? So if required,
Sir,
canal
like in this case, we can see that there is a cholestoma and the granulation also. What about the granulation? When we follow this granulation, we finally land up into the canal wall down and all
if
this
cholesterol
thing.
finish, then you should
Yes.
drop slight bit of granulation is no harm basically.
Sir,
Slight bit I remove it.
If
but
we
you see-
talk about the post of weeping cavity, the first thing the surgeon should suggest ki we should remove each and every cell and exenterate it, and to prevent the weeping cavity. Or other second thing to lower the facial ridge. But in this technique, I'm not criticizing, but I just want to ask.
But I'll remove this
yes.
this part also.
Yes.
This part. But I'm not doing the too much. Why I
Right.
don't agree with this technique also. All
Yes.
basically all are cortical mastoidectomy, and this is the all are system, previous system. No, pull down, saucerize everything. Middle ear and external auditory canal
Is the
and
job of
also
like 2 to 3
all.
hours.
But unnecessary, not required. If
Okay.
basically this is my practice, not for 1 year, 2 years.
Okay.
Basically 15 years follow up. I have seen nowadays sometimes cavity obliteration sometimes done, but all are mastered. Small cavity will be there. Unnecessary. This part not required. Believe me. If huge cholesterol is there, big cavity, then I should do here.
Sir,
Otherwise
totally
not
agreed
required.
with your point. If we are talking about the nowadays we are talking about the endoscopic and the hybrid technique. So
endoscopic, if you
we
see
are
the
not-
endoscopic,
Yes.
also they are doing this way, no?
Yes.
I am doing this way inside out mastoidectomy
So
under microscope.
we are not doing the canal wall down. In that case, we are putting the canal wall up. So once we are doing the canal wall down, I think maybe there is a different school of thoughts also. So it should be lowered. Facial ridge should be lowered at
Sir,
first. Yes, yes.
basic mastoid theory, what is the basically? Remove the cholesterol and dry ear, no? Basically, dry ear, remove the cholesterol, all cholesterol and dry ear, so not the facial ridge, not the anterobatrachus, not the antrum, not the cortical. This is I'm 100%, 200% sure. Every structure, every bits of pathology, I'm removed. So why the problem basically?
Dr. Ghosh,
yes.
From your point of view, what we like to get the message there, take home message,
Yes.
that you should follow the pathology.
Yes.
Don't do unnecessary
Unnecessary
surgeries.
bone drilling, not
And follow
required
the
at all.
pathology, clear the pathology, and keep the ear dry as far as practical.
Also in Baroda,
Don't do unnecessary cuttings.
Yes.
Okay.
In Baroda
Thank you,
also,
sir.
I
Thank
have seen also, and also with talking also Ruby Ramalingam. Ruby told you flat, and Ruby also the interest post outside in no, so flat cavity. Okay, so all are flat.
Okay, what is the condition of the synodural angle?
Check the synovial angle. Definitely you should see that way, but that way I am
there
not
is-
interested too much here.
There is a cavity inside, I hope, in
No,
the
that
synodural
I
angle.
do basically. I am telling so that way.
Sir, we got your point. like we have to follow the disease, we
Yes.
have to cut down the unnecessary drilling.
Ekdom,
So
right.
that is the reason, that is why that endoscopic and the hybrid technique developed.
Yes, so
So
inside the mastoid
like we are
also-
talking about the hybrid technique, we do endoscopic part, like middle ear part with the endoscope, and we do the cortical. Still we put the canal wall up. The point is here, if we do the canal wall down.
But
Yes.
the problem is in cortical mastoidectomy,
Yes.
in under the bridge some pathology will be there.
Sir,
that is not encountered anyway.
That we could address with the endoscope also.
Now endoscopy all time not clear, not too much.
Okay.
Not possible also.
Okay.
And also endoscopic surgeon also big mastoid cavity, they are changing the direction, cutting. They are changing the direction basically. So please, if follow this technique, believe me, the result will be fantastic. No doubt it. Mane, every time, only sometimes I prefer patients, please come and also suction. If required, 1 year in a year or something, just clear. Otherwise, all. No, you just sign rolling. But I have seen no pathology is there. Cholesterol is finished here. So I am not interested too much doing drilling, no. That is my simplified mastoid basically.
Okay, Dr. Tushar.
Bolo.
In this particular patient, if you want to do ossiculoplasty,
hello,
then, if you want to do ossiculoplasty in this particular patient, ossiculoplasty.
Ossiculoplasty. I will do ossiculoplasty. Every cases I will do ossiculoplasty.
Okay, in this particular patient, how will you do the ossiculoplasty? What is the basic principle you follow?
Yes, I follow this. Nowadays, I will show that technique also. Here, graft placement first. Okay. Then I will show the graft after graft placement, gel foam and cartridge will be placed here, and the graft placement will be there. So slight bit of cavity will be there, middle ear cavity. I prefer this way the cavity. I will show after also in midway. Midway I will show the case also. Sir will start this case, and midway I will show this case also. The graft placement and this I am interested to create this cavity. Okay, this middle ear cavity. I am not interested this total saucerization. Basically, this is I think this is the unnecessary work, unnecessary discharge here. So why pathology is clear? No, look here. This way graft will be placed and graft elevated, and then cartilage will be placed, and here will be gel foam, and this way. Okay. This way. So this much creation of the middle ear cavity, this is required, I think. And my patients all are happy basically this way. And hearing also not, I am not claiming the hearing will be the 20 or 15,
okay,
but audible hearing, nearly 30 this type. Okay, because I prefer always save the suprastructure and then cartilage placement and then graft placement.
So
always
will you highlight the sinus tympani area? Sinus tympani area.
Zoom in.
Yeah, the pathology all are clear. Look here.
Sinus tympani and the hypotympanic region, sinus tympani and the
hypotympanic also I will show. The pathology is starting from the basically attic. All are clear, no?
Yeah.
Okay.
The hypotympanic, there is something.
No, something blood clot basically. This is a blood clot. Basic principle of the cholesterol. No. If I don't agree with all, basically cholesterol here will be there, cholesterol here will be there, cholesterol here is the jumping. No, it's a continuous process. Why unnecessary? Here I think I should do here because the blood extraordinary can stop here, but here slight bit of sometimes pathology if required.
That is the anterior attic.
Yes, anterior attic. Slight bit
Residual
of
cholesterol or residual granulation.
No, cholesterol is there. Sometimes is there, so you should drill it. But here I have followed the properly cholesterol. Okay.
Yeah.
So not required. Look here, process got beautifully clear. If you unnecessary drilling, so for that reason before that, no, I will show the first the drilling system only. সেটা আমি ছেড়ে বললাম রেডি করলে ছেড়ে দেবো আমি তো বলেছিলাম যে একটু ড্রিলিং পার্টটা দেখাবো
So sir, you are planning to recon the soft tissue wall reconstruction, or you just leave it like this only?
No, graft placement, every gel foam placement.
No, I'm asking about that
Cavity
the
obliteration.
drilling you already did.
Hello?
Attic region or the like entrum you
This
already
all are
opened.
epithelium, properly epithelium. Yeah, not I am doing not every anyway. The graft is the all are clear pathology. Okay, coda. This is the coda. Okay. Okay, so all are clear. Look here, the clear. So unnecessary cortical mastoid and big cavity, that not required. Mastoid should be simplified. And for that reason, all juniors has fear of about the mastoid surgery. Because if you know properly drilling system, just from attic, just follow the veranda and the first floor. Don't go the ground floor. Is the facial nerve will be there. Just check the semicircular canal, and according to pathology, you just drill it. And if you are interested, if you are not happy, I'll show the drilling also here.
It is
So
basically
no
aticoenterostomy, isn't it? Aticoenterostomy, isn't it?
Aticoenterostomy according to pathology, and every structure will be okay. So this is the I'm drilling, but I know that no pathology is there. Still I'm drilling to satisfy you. Basically, this is no pathology is there, because under microscope I have seen no. Where is the cholesterol finish? Where is the
তুষার
yes sir.
তো এইটা ডিপেন্ড করে the myoplasty as per Vijendra.
Myoplasty definitely I will do myoplasty.
The whole operation of the success depends upon a wide myoplasty.
Sir,
That is the main thing.
every cases will do the myoplasty,
Yeah.
and after total surgery I will do the myoplasty, wide myoplasty, sir.
Wide myoplasty, that is the most important part of the success of this
Yes.
aticoenterostomy.
So my motto is the don't utter the cortical, because nowadays we are not doing the cardiac procedure, no. Sir, slowly it will be obsolete. Please don't take it otherwise, sir. It will be obsolete. Few years, and now endoscopy will be taken overhand, and its case definitely. After that I will show finish, because the other is lot of cases there. Some party will show is the problem, creating problem, no. They say our case 20 case the placed also, so some case is there. So I will show later on after finish, just 1 minute when in between the doctor's sir cases. So after myoplasty, how beautiful it will be there, I will show. Look here, beautiful cavity, no? Hey, sir, হয়ে গেলে বল ছেড়ে দেব আমি তো আবার পরে নিয়ে নেব। Hello?
Hello.
So that I place the graft up to this.
Yeah.
Big graft will be there, and look here, the facial nerve will be there. Unnecessary. Why? That part not required. Okay. Sometimes required. If I see the pathology is there, then I do only canaloplasty. But here I am seeing no pathology is there. Look here, round window. So unnecessary. If this part drilling not required, create the cavity, middle ear cavity. Okay. Create the middle ear cavity. So hearing will be good. Now my question is clear, sir.
Yeah.
Sir, hello. Bhusan sir. This is the facial nerve. Hello.
Yeah, it is clear now, sir.
Hello, audience.
Yes.
Yes, this is the facial nerve. Okay.
Right.
Beautiful vessels. Here the tips. Just 1 second, and then I give the mic to the Parina Chudri sir. Here the stapedial tendon. Here's the promontory. Okay, sorry, promontory pyramid. Okay. So all pathology is clear. So unnecessary this part again drilling not required. If cholesterol is there, for that cases I will do the hair canaloplasty. Okay. Otherwise I create the middle ear cavity, and create the middle ear cavity osteoplasty and good graft placement, and patient will be happy, because the graft will be this way, and small cavity and contraction will be there, and the small cavity in outdoor also directly with video otoscope all cavity will be seen, or under microscope all cavity will be seen.
Do you do cavity obliteration?
No, sometimes we will do here big when big cavity, then cavity obliteration, the muscle particularly flat,
but
otherwise no. Otherwise not routinely, because we do small cavity, no.
Okay.
না স্যার কে শিফট করে আমি ফ্ল্যাপ তুলে দিচ্ছি। So same anterior window I have shown no in morning, anterior window tympanoplasty. Here also we will do the anterior window. Here also I will do the anterior window this way. এই স্যার কি রেডি হয়ে গেছে? তাহলে আমি ছেড়ে দেবো। I will just showing the how the anterior window. Hello. হ্যাঁ 5 মিনিট তো ততক্ষণ দেখিয়ে দিই। Sir, hello.
Hello.
Unamada.
Hello.
Yeah.
This way anterior window tympanoplasty. In morning I have given this type of incision.
Okay.
Every case. Okay. And this way I'll I'll remove this way, okay, and tucking. Sakar কাজ করছে. And this way I'll remove, I'll elevate the anterior flap, okay?
Right.
And graft will be placed from here to here, up to here. So
Okay.
there is chance is very less to reject the, yes. Within 2 minutes, this flap will be elevated. So this way, no? Look here. I mean, half minute দিয়ে দিচ্ছে. Look here. Hello.
Hello.
Look here.
Yeah.
This is the annulus, okay?
Okay.
So up to this way, up to bony annulus.
Yes.
Look here, the fibrous and bony annulus. Look. This is the fibrous annulus and bony annulus junction, okay? Look here.
Yes, sir.
So here, now I am removing this. Now I will remove this way. So this and pressure give and this way, okay? So graft will be placed from here to here, okay?
Right, sir.
This way, here to here. After that I will show the final result, okay?
Okay.
And you will love this technique. Look here. And graft will be placed here and up to here, okay? So this is the locking will be there and osteoclast will be there. I will show everything. But now mic will be hand over to Professor Rajudi sir.
Sir, there are few general questions. Should
Yes,
we ask?
I'll give the question answer.
Yeah.
Mic will be shifted. Basically.
Okay.
Sir is
Sir,
ready, no?
sometime-
And I will show I will show the final result also after minoplasty.
Okay, fine.
অজয়
Hello.
এটা এরকম না হলে কি করে কাজ করবে?
এই স্যারকে দিয়ে দাও ক্যামেরাটা।
Hello.
না এরকম হচ্ছে না যে।
এই মাইক এই
শক্ত কেন? অত শক্ত?
এটাই দিয়ে দাও নাকি?
ওটা লুজ করতে হবে। অত শক্ত হয় না।
ঠিক আছে।
আরো লুজ করো। ওটা কত কাজ হবে? লুজ দেখো তো দেখে নাও। অন্য সবচেয়ে অনেকটা হয়েছে।
Hello.
বাবা এত শক্ত নয় বাবু, দেখো কোথাও একটা বুঝতে পারছি না তো। হ্যাঁ মনে হয় এখানে আরেকটু করে লুজ করো। হ্যাঁ এটাই বেশি লুজ করছো। ঠিক আছে এরকম থাক, ঠিক আছে। না টাইট করবে না, টাইট করলে হবে না। টাইট করলে কি করা হবে? এটাকে ঠিক করো। এটা তো ইয়ে আছে না, ও জুমিং আছে এখানে না? তাই সেজন্য আমি এটা আরম্ভ করছি, বলো।
Hello. Hello.
Hello.
Hello.
We are getting you.
Sir, can we get a brief history of the patient?
এই হিস্ট্রি, পেশেন্টের হিস্ট্রিটা বলো। ঠিক আছে ঠিক আছে ও জুমিং এর জন্য হচ্ছে এটা
Microscopic picture we are not getting. Yeah, now it is fine.
Hello?
Yes.
Hello.
This is the case.
জল দাও
ধরো এটা This is the case of bilateral conductive loss. Bilateral conductive loss, reduced
Okay.
hearing for last 3 years, and hearing loss, left ear 66.6 and right ear 50 decibel hearing loss. Okay. So bilateral CS type graft, I don't believe the temperamentary result also. Okay, basically. Sometimes AS type curve, normally A type, we believe the A type curve. If you see the picture, this type of loss. Look,
We're not getting the picture.
This is type loss, okay?
Hello. Yes.
Hello? This is the picture, okay?
Right, sir.
So left sided maximum loss 66.6, okay? So
Okay.
we are doing the left side first, okay?
Okay.
And we don't do regularly CT scan.
What was the temperamentary report?
CS type curve, AS type curve, no. CS
Yes.
type.
He has got the myelosclerosis.
Slight bit of sclerosis maybe.
Hello, Dr. Tushar.
Yes, sir.
Preoperative audiometry, amount of conductive loss is about 50.
Amount of conduct loss, it is not a mixed loss basically. More than 30, no, more than 40 probably.
And do you
More than 36 decibel hearing loss.
Do you consider speech discrimination score, preoperative speech discrimination score, SDS?
Speech discrimination, here speech discrimination score is good, more than 90.
Yeah.
No, nahi. Okay.
তোমার ওটা হয়ে গেছে
Now we are getting the microscopic picture.
Yes.
I think in posterior quadrant TS patch is there.
Yes, the myelosclerosis is there.
Okay.
Yes, sir.
Could you see myelosclerosis?
Right, sir. Right.
So, unless I open it, after tympanotomy, I will be able to understand whether the fixation is due to tympanosclerosis or otosclerosis.
Okay.
You see?
I think only one tympanosclerosis point is there, bilateral case. So it is a case of definitely otosclerosis.
Right, sir.
Bilateral and tympanosclerosis and fixation of tympanosclerosis is very rare case.
এটা তো স্পিরিটটা এসেছে Tympanic membrane normal থাকার কথা তো membrane is not normal. Oh, definitely tympanic sclerosis is there. Okay. So I will do it endorally. As you have seen the three-flap tympanoplasty done close out to couch. Could you hear me?
Yes, sir.
In fact, it is not pure and simple endoral incision. It is modified endoral incision. Only the vertical part I do keep, not the horizontal one. So modified Lempert's, you can say. And this is just for the exposure only I give of the external auditory canal properly and the tympanic membrane. এটা দাও 4 নম্বর ব্লেডটা দাও এত ব্লিড করছে কেন বিধান হ্যাঁ হ্যাঁ এত ব্লিড করলে কি করে হবে বিধান এই ভীষণ ব্লিড করছে Xylocaine adrenaline দাও, xylocaine adrenaline তুলো দিয়ে দাও, নাহলে করা যাবে না। সাইড নাইফটা দাও। xylocaine adrenaline দাও তুলো দিয়ে। সাকুরার সাইড নাইম লাগবে না, সাকুরার ওই পাফোরেটেডটা দাও, বড়টা।
Two vertical parallel incision was placed. Yes, sir is going to elevate the tympanometal flap.
Is it clear? Audience?
Yeah, it is clear, sir. You are elevating the posterior flap.
Yes, I am elevating the tympanometal flap.
Yes.
Atana, patient is moving. Hey, patient get to sedation lagbe. Sister. Sedation লাগবে, sedation দেয় অনেকক্ষণ হয়ে গেছে পেশেন্ট। কি দেবে বিধান বলে দাও। ছোট্ট তুলো দাও। ওই অ্যাড্রিনালিন দিয়ে ভিজিয়ে কোনো উপায় নেই, এত ব্লিড করছে। পেশেন্টকে সিচুয়েশন দিতে বলো। I'm having some difficulty with microscope. Some problems. এইটা দাও, ছোটটা দাও, মাঝারিটা মাঝারিটা। পাতা নাড়ছে, সিচুয়েশন দিয়েছে, করা যাবে না, পেশেন্ট মাথা নাড়ছে। নিউরোলাস তুলতে যদি মাথা নাড়ে তো মুশকিল। বিধান সিচুয়েশন দাও বাবু, একটু ইয়ে দাও তো, সিচুয়েশন পেতে একটু তুলো, অ্যাড্রিনালিন তুলো। থাকলো না। মাথা নাড়াবেন না। কিছু শব্দ হচ্ছে। দাও, নিডলটা দাও। মাথা নাড়াবেন না, আপনি মাথা নাড়াচ্ছেন কেন? ব্যথা লাগছে? Could you see that? কথা বলবেন না, আর জেগে গেলে মুশকিল। Could you see the color ribbon now?
Yeah.
Yeah. Patient is not well sedated. এক্ষুনি হয়ে যাবে, এক্ষুনি হয়ে যাবে। নড়বেন না, নড়বেন না।
Sir, you are doing the tympanotomy. Sir?
কি হয়েছে?
Only tympanotomy you are doing.
কাঁচিটা দাও তো একটু, মাইক্রো সিজারটা। করছি করছি। ওটা দিলেই ভালো হতো, মাইক্রোস্কোপ এটাতে ভীষণ অসুবিধা হচ্ছে।
Sir, the picture is out of field. Sir.
রুজিনটা।
Tushar?
Yes, sir. Hello.
Hello? The picture is not in the field. A little bit it's out of focus. পিকচারটা ফিল্ডের মধ্যে নাই। হ্যাঁ, এবার ঠিক আছে স্যার।
Is all right?
Yeah.
This is the handle of malleus. Here is the incus peeping.
Yeah.
Here is the coronary nerve. So I will drill out from
this portion,
like this one. This amount of bone will have to be removed by drilling.
Posterior superior bony meatal wall.
দাও, ড্রিলটা দাও। দাও। এটা কোথায়? সুইচ, ফুট সুইচটা কোথায়? এটা? এটা মধ্যে ঘুরছেই না। ঠিক আছে, না এখন না আমি এখন ঠিক আছে।
Yeah.
পেশেন্ট নড়ছে যে, পেশেন্ট নড়ছে সেই জন্য। নড়বেন না ভাই।
Again, the picture is out of field.
আর একটু বাড়াতে পারে। মাথাটাও নাড়িয়ে ফেলছে। সেন্টার আছে না সামনে বলে আমাকে, ছবিটা আছে সেন্টারে? বিধান
আর একটু সেন্টারে করলে বেটার হয়। হ্যাঁ,
একটু জল দাও। মাথা নাড়াচ্ছে পেশেন্ট। সিচুয়েশন কি দিয়েছে বিধান? এখন কি দিয়েছে? কি আইবি দিয়েছে? overhang, very big overhang. একটু হয়েছে?
Yeah.
এখন ঠিক আছে?
হ্যাঁ এখন ঠিক আছে।
হ্যাঁ?
Yeah.
You tell me if the picture is not in the center.
Too much posterior overhang is there. The ink.
একটু সাইড ল্যাম্পটা দাও তো, সাইড ল্যাম্পটা। জিটা দাও। হ্যালো অডিয়েন্স, সব ঘুমিয়ে পড়ছে নাকি?
No, no, the picture is out of field.
Out of?
Field.
Out of focus.
Now is it all right?
Yeah. ঠিক আছে স্যার।
Yes, if it is that, please tell me.
ঠিক আছে স্যার।
Is it all right now?
Now it is all right.
Yeah. I am now on the quarter tympani knob.
Yeah.
Yes.
Yeah, then.
Almost we have opened. এবার একটু কিউরেটটা দাও। Jill. Can see the facial nerve?
Yeah. This is the posterior part of the tympanic segment of the fallopian canal.
Yes. পেশেন্ট কি মাথা নিজেই নাড়লো? ও, দাও কিউরেটটা দাও। This is the bone lying onto the chordotympanic nerve.
Yeah.
Jill. Yeah. Can you see the foot plate?
Yeah.
Hello?
Yeah. Now the foot plate is visible.
And you see the facial nerve carving?
Fallopian canal, external genu.
Yeah. জল দিয়েছ নাকি? তাই বলো। হ্যাঁ। হ্যাঁ কি বলছো? কিছু বললে?
না 3-4 দিন আগে এসছে এখন ওটি করবো কিন্তু ওটি করার আগে ডেফিনেট হতে চাইছি
Drillটা. Is it the center now?
Yeah. Now the lower part of the
See the chorda tympani?
Yeah. Lower part of the chorda tympani.
I have not touched the chorda tympani as yet.
Yeah.
এটা দাও তো একটু ওই নিডল chorda tympaniটাকে মডিফাই করি এবারে. This is chorda tympani.
And you are now mobilizing the chorda tympani.
Now I am mobilizing because I will have to mobilize a little bit because I am to see the
posterior cross. The stapedius tendon is visible.
You see the pyramid, you see the stapedius tendon?
Apex of the pyramid is visible.
Did you see this?
Yeah.
Okay. This is the incus.
This is long processing incus.
And chorda tympani is very thin. I don't know why. So now exposure is almost complete, and just to all of you know that exposure is very important. Unless you fully expose it nicely, see pyramid and the stapedius tendon properly drilled. It becomes difficult to do this surgery. Only thing now is to do as Tushar was telling, the reverse one, and that I follow from the very beginning. Now this is the technique of fish curate. Hugo Fish has recommended to put the piston first. That is now what is that called? Chuck says that reverse one. That is reverse. That means put the piston first. Then you do other things. So, but here.
Now the pyramid is completely visible.
Pardon?
Pyramid is completely visible. Pyramid.
Yeah, now pyramid is completely exposed.
Completely exposed.
Only thing is this chorda is so thin, and chorda is practically very difficult. Because I want to mobilize the chorda. This is chorda, you see. So unless I mobilize the chorda, I won't be able to put the piston.
Yeah.
You see?
Yeah.
Have you seen this?
Yeah.
So thin.
That anterior part of the chorda tympani nerve should be further mobilized so that adequate space will be created.
I don't know what I will do with the chorda. কারণ chorda নাই করলে পিস্টনও পড়ানো যাবে না। So it is fixed. You see, I am moving the incus, stapes is not moving. So it is otosclerosis, as Tushar was telling. It is not due to the fixation of
tympanosclerosis.
Sclerotic. That means myelosclerosis or tympanosclerosis. Now you suggest, what shall I do? The tympani, the chorda tympani.
If I have to sacrifice the chorda tympani nerve, then a sharp cut of the chorda
I don't like to, but I want to preserve it. Pardon? No, soft tissue. This is soft tissue. Anyway, let me do the finestra first, then we'll try later on. Now, this is the foot plate. Have you seen this?
Yeah.
I can make it better focused. The measurement দাও এখানে ফোকাস কর এখানে এখানে এই যে হয়ে গেছে একটু ঠিক আছে
Yeah.
now I'll measurement so I am now measuring it
By measuring gauge.
from the foot plate
Yeah.
to the lateral border of the incus. It is 4. So I will have to use 4.5. Huh? 4.5 millimeter piston I need. The 7. So this is the 7 millimeter pick perforator.
Sir, what is the size of the perforator you are using?
Pardon?
Size of the perforator what you are using?
0.7 millimeter.
0.7 millimeter.
Already made.
Yeah.
Is it focused now?
Little bit hazy.
একটু hazy.
Too hazy. Now it is clear. Now it is clear.
Okay.
Without any hindrance, the piston can.
আমাকে একটু সরুটা দিতে পারো সরু পিকটা সরু টিপটা I think is it I'm to use the 5.5 millimeter piston.
Now it is adequate. The opening is now adequate.
That is adequate, I think.
Yeah.
আরেকটু দাও পিক পারফোরেটর আর কি পারফোরেটর মাথা নাড়াবেন না ঠিক আছে দাও this is enough I think huh?
Yeah.
দাও পিস্টনটা দাও হ্যাঁ কি বলছো হ্যাঁ হ্যাঁ ওপেন করে দাও তুমি যেরকম করো 4.5 নিয়েছো বাস ঠিক আছে তুমি এ করে দিয়েছো
Perilimb leakage is there.
সাকশনটা মাথাটা একটু ধরো তো, মাথাটা নাড়ছে। কি হলো, ঢুকছে না কেন? না, এটা বোধহয় ইয়ে হয়নি বিধান, টাকা দিয়ে না, পেশেন্ট পেশেন্ট নড়ছে, এটাকে সোজা করো তো। এটা কি ফটো হয়নি নাকি? ফেন্সটা হয়নি? ফেন্সটা তো হয়েছে। তো হওয়ার কথা না, ফেন্সটাতে ঢুকছেই না। না, তো ফোকাস করতে বাবু। ফুটপ্রিন্টে ফোকাস করো। ফুটপ্রিন্টটা দেখা যাচ্ছে কিন্তু বুঝতে পারছি না। না, দেখি আমাকে পয়েন্ট আরো সরু ইয়েটা দাও তো, পারফোরেটারটা। পারফোরেটার দিয়েছো? পারফোরেটার দাও। What do you feel? Is it the fenestra or a false? False, not হয়নি। That's why আপনি কেন মাথা নাড়াচ্ছেন? আপনার সঙ্গে কথা বলছি না। So it was a false actual impression. That's why the piston did not enter. Focus করো। What I was feeling, the পারফরশনটা হয়নি। এই যে মাইক্রোস্কোপ নড়ছে না, পেশেন্টটাই নড়ছে।
সবাই এলে, আমি তো নিচে পেশেন্টকে দেখলাম, যখন যাচ্ছে না ওই ম্যানচেস্টার পেশেন্টটা, নিচে দেখলাম, নিচে যাচ্ছে।
Actually, what I felt that this is the fenestra, it is not. There you go. Have you seen?
Still the bone is
It's a
entire.
thick foot plate. Very thick foot plate. সরুটা দাও 0.7 না দিয়ে আরো সরুটা দাও ওটাকে করেছো Now I am trying with the 6.6 millimeter piston. Now it is all right. Now it is all right, okay?
The perilimb is visible.
Nah, nah. Point six, nah? না 7 একটু লাগবে মনে হচ্ছে 7টা দাও না ঠিক আছে and it never suck directly into the vestibule, okay? Pick the down 0.25. Delegate কেউ আছো কথা বলো
You are now enlarging the opening with 0.25 peak. 0.25 peak, you are enlarging the opening.
Yeah.
The peak instrument.
ফুট প্লেটটার জন্য হয়ে উঠলো না ওকে দাও এবার বোধহয় হয়ে যাবে পিস্টনটা দাও ধরেছ পিস্টন কোথায় ও দৌড় দিয়েছ না
Out of field now. Sir, একটু ফিল্ডে নিয়ে আসুন স্যার না পিস্টনটা ধরছে আউট অফ ফিল্ডে হয়ে যাচ্ছে
কিরকম একটা ফলস ইমপ্রেশন হলো হ্যাঁ
হ্যাঁ
তুষার কিরকম একটা ফলস ইমপ্রেশন হলো
Sir, the opening was in the
মাইক্রোস্কোপে
moment.
আমার তো মনে হচ্ছে ফুটো হয়ে গেছে, আর পিস্টনটাই বেঁকে গেল পড়াতে গিয়ে। দাও
False impression হয়েছে। মানে কি
হ্যাঁ
তখন বনি ওপেনিংটা হয়নি।
কি করবে?
না ঠিক আছে স্যার, এখন
না
piston-
না 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 এসব করবেন না, হয়ে গেছে। কি গো, ঠিকই তো আছে। যা এখানে বলতে কি করা যাবে, কোয়ালিটি মানে সরাতে পারলাম না ওখান থেকে, দিলেই ভালো হতো না। হ্যাঁ এটা খুলে গেছে।
Now it is very nicely placed.
ঢুকেছে কিনা দেখি।
Sir,
এই মাথাটা ধরো, না ঠিকই আছে। ভেবেছিলাম যে হবে ইয়ে করব, হলো না সেটা। সো দিস ইজ রিভার্স stepidotomy. Could you see the piston going in?
হ্যাঁ ভেস্টিবুলার এন্ডটা দেখা গেছে স্যার।
হ্যাঁ
ভেস্টিবুলার এন্ড ইজ কোয়াইট ইন প্লেস।
আমাকে একটা নিডল দাও। নাও ফিল বাইরে ফিলতে আছে। ঠিকই আছে। So so it is not possible now to preserve tendon because already dislocation has been made here. You see?
Yeah. The superstructure of the step is separated.
না কাটবো কিন্তু এটা হ্যাঁ You see the piston in?
Yeah.
না না কিছু ভাঙেনি। কি বলছে কি? হ্যাঁ কি দেবে ওটা ফুটপ্লেট আটকে পাইছে।
স্যার ইনকাসের গ্রিপিংটা আর একটু সিকিউর হলে ভালো হয়।
হ্যাঁ ছেড়ে দেবো। না না মুভমেন্ট চেক করবো না। না না ইয়ে করবো। এমনি ঢুকেছে তো। এই যে
ভেস্টুলাইনটা ঠিক আছে।
পুষ্পের পড়াটা যখন করছি তখন এটা কাঁচিটা দাও, এটা কাঁচি না?
স্টেপিরিয়াস টেন্ডন পোস্টেরিয়র সেন্ট্রিক।
হ্যাঁ,
না না কাটেনি, সুপারস্ট্রাকচার
হ্যাঁ, পিক দাও। হ্যাঁ, ultimately I had to cut the posterior cross. এসে গেছে।
Now superstructure is separated.
হারিয়ে কোথায় যাবে?
ভালো শুনতে পাচ্ছেন তো? ব্যথা হচ্ছে একটুখানি, ব্যথা হবে 5 মিনিট হয়ে যাবে। আরে জীবনে ভালো শুনছেন, এটা বড় কথা।
আমাকে নিডলটা দাও। So ultimately corda tympani I could save, but neostaphyseটা আমি couldn't done. এটা একটু ক্লোজ করে দিতে পারি, দাও। পিস্টনটা একটু ক্লোজ করা দরকার। হ্যাঁ, তো না করলে না না বেরোবে না। ও নিডলটা দা, নিডলটা দেখুন, এটার জন্য অসুবিধা হচ্ছে। না ঠেলতে হবে না, দাও জেল ফর্ম দাও। না জেল ফর্ম আমি দিই। ক্রিম করতে পারলে ভালো হতো। হ্যাঁ, দাও আর একটু যখন দাও। হ্যাঁ হয়ে গেছে বাবু। আচ্ছা এবার মোবিলিটি দেখি, এই দেখাও, ঠিক আছে। সাকশনটা দাও, সাকশনটা দাও।
Hello.
Hello.
I'm Dr. T.K. Ghosh. Tushar Ghosh. Now, basically fantastic demonstration. Congratulations, Dr. BRC. Now the mic will be shifted to the another OT for face.
Yeah.
Basically, less face, less polyp is there, but rhinosinusitis case. So for demonstration purpose, this case is good. Sometimes for workshop, sometimes proper case and also selection sometimes not so much possible within a few days in private practice sometimes. Still I have Still I have done at least 20 cases ready.
Dr. Tushar,
hello.
The face case, particularly the history and the CT scan picture should be shown fast.
Basically another 2 cases there, some parties the very anxious, why too late. Okay, basically our practice is done basically from 8 to 1:30. After that we do chamber. So morning time case finished, no? So we use the 4 OT at a time. So case is finished within 1:30. So now at least 5:30. So some patients very annoyed and anxious. So one case is put, not too much face, but is the technique rhinosinusitis case. I think Dr. Deepak Holdipur's demonstration is fantastic. Basically less bleeding will be there. So this case will be demonstrated by Dr. Holdipur. And
Tushar.
Hello, sir.
Tushar.
Yes, sir.
Thank you very much for the beautiful workshop you have arranged.
Thank you, sir.
And various cases which you have demonstrated.
Sir, not completed. Still now there is another 5-6 cases will be demonstrated.
I know plenty of cases.
Yes.
But sir, we have got ages process. My Shubroto, everybody have got age. So we will Komal. So we are proceeding back to home. Okay.
No, sir. Yeah, dinner party, cocktail dinner is there, and now Dr. Deepak Holdipur taking the mic. Okay, please don't go. Okay. And another, I will show the microscopic thyroidectomy. My always favorite surgery, microscopic thyroidectomy. Also another case, backup case is there. If someone guest is interested to show the case, no, because today I have chosen the endodicier case, but my guest faculty wants the I will do the endodicier. So all cases I have backup. Basically, if guest faculty wants that case, I will leave that case and I will do another case. Okay. For that reason, I have kept 4 steppies basically. If anyone missing, so I will do another 1 steppies also. But luckily 4 steppies admitted. Still I will do 1 steppies, I think. If and in the meantime, I have finished 1 mastoid, another mastoid also. Okay. And another OT, I have finished 1 big mastoid. If you see the big cavity, big cholesterol, but this is not possible for demonstration. In the meantime, I have done drilling also, that mastoid case, and my all assistant all finishing that case also.
So you have brought all the cases from all over West Bengal. There will be no steppies case from for us. So all the steppies cases are
luckily I got blessed and with your blessing, I am doing it nowadays nearly every day basically stepidotomy. nearly
we are
every
not
day.
getting any steppies, that's why.
Basically nowadays my steppies in month nearly more than 20.
My God.
More than 20.
And we are not getting any steppies only for Tushar Ghosh.
So yesterday also I have done 2 steppies.
Wow, beautiful.
So for that reason, minimal manipulation of the posterior corotomy with the skitter I don't like. So for that reason, I have purchased the luminous laser. So that also it will be overcome. Okay, and mic will be handed over to Dr. Holdipur.
How much price of this luminous?
Luminous, sir, more than 1 crore. More than 1 crore. If you bargain, you will get it 1.2, 1.25, but they will quote the 1.4. Then it should bargain. I bargained for last 6 months.
Tushar,
yes, sir.
Where you are hosting cocktail dinner?
Here, sir.
Oh,
no movement. For your age, no. Why unnecessary movement will be there?
You start the cocktail dinner just now. Otherwise, everybody is.
No. Just after 1 hour, we'll start the snacks and cocktail also. Okay, we'll start. In the meantime, felicitation after some snacks. After that, we'll do the felicitation. Okay, just don't go. So, senior faculty will be disheartened. No. Okay. Hey, Mike, take feet program set. Now started endoscopy change for the endoscopy. So navigation is there, but this case has not required navigation. The time will be more. So to finish the, and here not a huge polyp is there. So without navigation system, we are doing this case.
Cut.
Sir.
Yes. सक्शन देना. सक्शन ऑन है क्या? सक्शन ऑन करने को बोलो.
So what is the CT scan finding?
Okay, local. Hello.
Hello.
Yes. Okay, sponge. छोटा करो. हाँ, सीजर. मीरोसेल है. हाँ, ले लो एक. हाँ.
Sir.
ओपन करो. खोलो.
Sir.
हाँ. एक मिनट. ये पैकिंग को यूज करेंगे. इसको थ्रेड डाल दो. हाँ, स्टिच. हाँ, नहीं इसमें एक डोरी अगर डाल दिया, नहीं तो और एक यूज करेंगे. छोड़ो, ये तो इसके लिए जरूरत पड़ेगा. हाँ, वो सॉल्यूशन कहाँ है? वो दे दो. अरे गिराना नहीं, वो पानी से गिर गया. एक मिनट. नहीं, वो तो ठीक है. वो सीजर. हाँ, ये लाइट्स ऑफ करो ना. हाँ, वो स्पंज देना. बारिंदा है या अच्छा. हाँ, हेलो. स्पंज. हेलो.
हेलो.
माइक ऑन किया क्या? देखो. हेलो.
हेलो.
Can you hear me?
Yes, sir.
Yeah.
Sir, will you show us the CT scan findings?
Yeah. अच्छा, जब वो देते हो स्क्वीज करके देना. अच्छा, और 5 एम्पूल एड्रेनलिन डाल दो उसमें. हाँ. हाँ. हेलो.
Hello, sir.
एक ही फिल्म है, एक और फिल्म है ये निकालो, मेरा चश्मा निकालो बेटा, ये तुम्हारे पास रखो, ये फोकस करो. हेलो.
Hello, sir.
Yeah, you can hear me?
Yes, sir.
Are you getting the picture of the CT scan?
Getting.
इसके ऊपर फोकस करो बेटा. ये ऐसा लगाओ, उल्टा लगा है. एक ही फिल्म है, एक और फिल्म है. हाँ, और एक है उसमें. नहीं, ये एक ही है या एक और है? दिखा जरा.
सर, कोई डायनामिक सीटी स्कैन अवेलेबल है?
वो दिखा, वही डालो, निकालो, ये डालो. Yeah, can you see the picture?
Yes, sir.
See, in the first cut you can see the nasal bones. In the first cut you can see the nasal bones. Can you see that?
Yes, sir.
The second cut you can see the nasal septum.
Yeah.
Third cut you see the nasal septum slightly deviated to the right,
Right.
with the right frontal sinus coming in the view.
Yes, sir.
The next cut you can see a small interfrontal septal cell or maybe a partition, and then you can see the right frontal and the left frontal. In the next view, this partition is going away and you can see the right and left frontal.
Right.
Now, the moment you cross this cut and this cut, the maxillary sinus starts appearing in this cut. The moment maxillary sinus appears, what you see above will not be the frontal sinus. It will be what is called as the supraorbital cell. Why? Because as you go behind, you can see Kennedy's nipple. This is the anterethmoid artery. From this point, we are going into the posterior ethmoids. So see this. As you come behind the right frontal, the left frontal, a small interfrontal septal cell, and then as we go behind, the frontal beak disappears. The frontal beak disappears, you are into the frontal sinus ostium, which is the posterior medial boundary of the frontal sinus. The immediate next cut, when you start seeing the maxillary sinus, the frontal sinus has disappeared.
Right.
What you see here looking like a frontal sinus is a supraorbital cell. When the supraorbital cell is big, the anterethmoid artery will hang from a mesentery. Because the supraorbital cell is small in this case, the anterethmoid artery is running on the skull base. just behind the anterior artery. Now you go into the posterior ethmoid. In this cut, you are actually in the posterior ethmoid proper. How do I say that? The skull base, which is W in shape, W in shape, W in shape, becomes flat. Number 2, the maxillary sinus, which was quadrigonal in the anterior ethmoids,
Sir, you are
becomes
obstructing
oval.
the plates.
Number 3, the middle turbinate, which was vertical,
Sir,
turns horizontally
Dr.
and attaches to the lateral wall.
Dr. Holipur,
Yes?
where you are demonstrating, your body is obstructing the view of the
Sorry.
exercise.
Okay. So, this is where, the cut is going into the posterior ethmoid. There are about 5 features which tell us that the scan has moved from the anterior ethmoid to the posterior ethmoid. The skull base, instead of being a W, becomes a gentle U. Number 2, the maxillary sinus becomes oval. Number 3, the middle turbinate turns laterally and attaches itself to the lamina papricia, forming ground lamella. Number 4, you can appreciate the 2 superior turbinates. And number 5, the orbit, which looks round and big in the anterior ethmoid, becomes narrow and quadrigonal. So now we are in the posterior ethmoid. From here we go back. You can see the septum slowly dividing into 2. In this cut, the septum becomes like a Y, which means you are in the sphenoid. This is the posterior ethmoid, this is the sphenoid. You can see a second nipple here, and this is nothing but the posterior ethmoid artery running on the skull base. It usually runs on the skull base. You look at the sphenoid, you can see a septum going from above downwards. The left sphenoid is small, the right one is bigger. There is no lateral recess. You can see 2 foramina here. This is the foramen rotundum carrying the V2, and this is the Vidian canal. When there is a sphenoid aeration here in between the 2, it becomes the lateral recess, one of the common sites for CSF leak. So to summarize, I have a nasal septum which is fairly central, little deviated to the right side. Number 2, I have anterior ethmoid artery which is running on the skull base. Number 3, the lamina papricia is intact. Number 4, both the frontal sinuses are pneumatized. There may be a small interfrontal cell, which means my drainage pathway on the left side may be a little lateral. Number 5, the posterior ethmoid artery is also running on the skull base. Number 6, and most important, the optic nerve and carotid artery are not dehiscent within the sphenoid sinus. The right sphenoid is slightly bigger than the left, and both the optic as well as the carotid are not dehiscent within the sphenoid sinus. So these are the salient features you must know. And finally, the lamina papricia is intact. It is not dehiscent. This information is enough for us to go ahead with the FES. And remember, I did not describe the disease inside the sinus, because in FES, a surgeon's job in reading the is as to do a safe FES surgery. Okay? Oh, hey, इधर डाल यार. हाँ. Yes, debrider ready? Yes. Dressing forceps. SMR elevator. First step, I am going to lateralize the inferior turbinate. Okay? Hello?
Hello.
Hello.
So we are getting you, sir.
Yeah. Debrider. फुट स्विच का है इधर है ना. Yes, sponge, sponge. नहीं वो ये मेरो सेल. अच्छा ये करके दे दो, पानी निकाल के दे दो. हाँ हाँ हाँ. इस करेंगे बस. हाँ बस. रिबन का छोटा काटो, छोटा पीस काटो. ये आधा आधा काटो. ये लंबा और एक दे दो. Dressing forceps. SMR elevator. See this? Yes. अभी ओके. नहीं SMR एलिवेटर देना. हाँ बॉल प्रोब देना. हेलो. नहीं ऑडियो में उधर ऑडिटोरी में कोई है क्या? आई डोंट.
हाँ सर है.
हेलो.
We are here, sir.
Yes, see, I have just done the uncinate lower part opening up
Natural osteo.
of the lower part of the uncinate debrider. Okay. Straight Blakeslee. Hello. Suction, please. Okay, 40-degree blade है? हाँ? Okay, ये straight 40 है, दे दो. अभी straight देना पहले, जो है भी दे दो. 40 आने तक. You can see because there's not much extensive polyposis, I'll be making a correct. Yes. Okay. हाँ लगा लो. Ball probe. Scissor. Yes, 40 दे दो. ओके स्पंज देना. स्पंज मेरोसेल देना. बॉल प्रोब देना पहले. So I have done a middle meatal antrostomy because there is not much of a disease. हाँ ये दे दो. 40 डिग्री डिब्राइडर देना. ब्लेड अभी दिया ना. ओके छोटा छोटा रिबन गॉज पीस रेडी रखो. ये पकड़ो, क्लीन करो. 1 मिनट.
So, Dr. Halipo,
Yes.
I'm Dr. Mukherjee here.
Yeah,
So,
hello.
Hello. So you're in the anterior smart, bulla.
Yes,
na?
yes. I have just actually
Yeah.
suction removed the uncinate only.
Right.
And I am trying to now, basically the bony partitions are also thick,
Okay.
which shows that probably the disease is limited
Right.
and more of allergic in nature
Right.
rather than AFRS. But yeah, Mirocell dena. But right now I have just about completed 80% of uncinectomy
Right, sir.
and a middle meatal antrostomy.
Right.
Maybe we'll look at the frontal sinus
Okay.
shortly. So, one more sponge, please. One more sponge. Mirocell, yeah. So I am just packing that area and going on to the other side now, where I just removed the polyps. And let me see if I can. This is the narrower side due to the yes, ball probe. So now let me see this side as well. Looks like this is where the maxillary sinus is. Yes, there is something coming out of it. Debrider. Yeah. Yeah. Okay, ball probe. Give me the suction, please. Yeah, give me the ribbon gauze. Yes, dressing forceps. Oh. Suction. Yes. So ball probe, please. Okay, give me the debrider. Keep one more ribbon gauze ready. Dressing forceps. Yellow.
Hello, yes, sir.
Suction दे दो.
Oh, sorry.
अभी इसको curved suction डालना बेटा. Yes.
Hello.
हाँ. डिब्राइडर देना पहले. अरे वही रहने दो.
Sir, any opinion about the bleeding in this case?
Yes.
Sir, any opinion about the bleeding?
Yes.
So sir, what?
No, I'm not able to hear you properly.
Okay, sir, I'm just asking your comments about the bleeding in this case that you are facing.
Bleeding, is it?
Yeah.
Yeah, that will be there if in case. It also depends on the case preparation.
Right, sir.
No?
That's what I want to know.
So bleeding, the only thing is, you have to be very careful.
Right, sir.
Because when there is bleeding,
Yeah.
you can easily lose the landmarks.
Yes, sir.
And you can have complications.
Right. Okay, sir.
So you have to be slow and careful.
Yes, sir.
Ribbon gauze देना बेटा.
So in such infected cases, how do you prepare your...
Usually, see, one thing is you have to give good amount of steroids.
Okay.
That is one thing. Suction, please. Second, of course, the antibiotics.
Right.
Okay.
So is it always culture directed or empirical?
1 minute. One more ribbon gauze, please. Gauze piece you give me. So, basically one thing is give enough antibiotics. Second, give steroids. Third, see that the patient has not been recovering from a viral infection recently. I remember recently one child, an anesthetist child, I wanted to do debrider adenoidectomy, and the nose had become very congested and narrow because the child had just started one, bout of, one more pack, please. Yes, and per-operatively also.
Right.
You would like to have a BP of around, I think the BP of this patient is more, around 143 by 96. It should be 90 by 60 and the pulse rate should be around 60, which is even more important. Beta? Boss, straight play कसली देना?
Middle tablet.
The BP is more. Curved suction देना. Okay, bone punch. Bone punch देना. Garrison's punch, हाँ. ये जरा पुश करो बस. हाँ, तिली देना, 70 degree scope लेना, लिया, yeah, yes, 70 degree देना. Hello?
Yes, sir.
Yeah, I'll just put a 70 degree.
Yeah, okay,
now
sir.
look at the entry wall of the bulla.
Right.
Huh? And yes, long ball probe, Kunt cell seeker. Long ball probe है? वही है. Okay, दे दो वो ball probe. So I think, I would like a longer ball probe or a Kunt cell seeker. So, ठीक है, जिराफ है या नहीं? वो ठीक है.
Hello.
Accurate तो है. Yes.
Sir, good evening. Dr. Bhushan is this side.
Yes.
Sir. So now you are going to open the frontal recess.
What? That is a frontal recess.
Yes. So you are entering into the frontal sinus with the
45 degree
intake puller
forceps
technique.
देना. 45 degree forceps. Blakesley. So I will be entering into the frontal recess.
Yes. This is agar cell.
Yes.
Yes.
After I remove these two bones, debrider देना, 40 degree blade है ना? हाँ.
So this is intact puller technique, huh?
Yes.
Yeah,
I always try to
prefer to
do
do.
intact bulla technique.
Yes.
The only disadvantage with intact bulla technique is that you may not get adequate space, working space at times.
Okay.
But as far as the anterethmoid artery is concerned,
Yes, intact
it
puller
is
technique
very-
is much better
very-
than
very,
yes,
very
yes,
safe.
Yes. And sir, one more thing, if we are doing it for the just chronic sinusitis without the polyposis,
Yes.
intact puller technique is the best one.
yes.
Yeah.
Curved suction, please.
So, sir, one more thing I just want to ask. If suppose some suprapular
Yes.
cell is there,
Yes.
it got a lot of confusion about
Ball
location of anterior ethmoidal artery.
Yes.
So,
No, I think there is no confusion anymore. Anterethmoid artery forms the posterior border of the
facial recess.
supraorbital cell.
Sir, I was talking about the suprabular.
Yes.
Yes. Supraorbital cell is very clear when ethmoidal artery is at the
Yes.
caudal end of the supraorbital cell. We are very safe.
Yes.
Yes. If suprabular cell is there, then I think a bit confusion is
Yes.
there because it is lying
Debrider?
within the cell. Yeah. I think you already opened that.
Yes.
Yeah.
I don't have a Kunt cell seeker. That's the only thing, you know. Ball probe.
So what all precautions we had to take during the frontal sinus manipulation or frontal sinus
No,
surgery?
basically, see, you
yeah.
should not go very medial
Okay.
to damage.
The cribriform
Yes,
part, yes.
yes.
This is, sir, about the intra-op thing. We have to prevent the complications. We have to stay within the
First thing
limits.
is a proper reading of the
Scan.
CT scan is
Okay.
most important.
Okay.
You know, and
Cell by cell we
debrider,
have to
yeah,
get it.
yeah. The way I am going slowly, palpating and I am using the 40 rad blade.
So, sir, these are the intra-op thing. If we have to iatrogenic frontal sinus or frontal sinusitis is very common if we do the manipulation. And
Yes, yes. So you have to keep it like this.
Yes. What precautions we have to take to prevent all this complication?
No, basically you should not strip the mucosa.
Okay, okay.
See, look at here.
Yeah, mucosa is
behind
intact.
the back, the mucosa is intact.
Posterior wall mucosa intact.
Yes.
And
Ball
is there any kind of adequate size of the frontal sinus we have to open for the chronic
If you
sinus?
can do about 9 millimeters, ideal.
Okay, like
But
30
you will
40% shrinkage is there.
Yes.
Yeah.
See, look at the beak.
Yes.
The beak is so hard.
Right.
And this is my frontal behind the beak.
Right, sir.
Okay.
Right, sir.
So it is because of the neo-osteogenesis again.
Right.
It was a little difficult, but of course, not exactly very difficult. Yeah, ball probe. I mean, debrider. 40 degree daldo.
I think it is a 45 degree. Sir, the scope is 45 degree or 70 degree you are dealing with that?
Yes. I am with 70 degree now.
70 degree now. Okay.
Because near the frontal I like to work with 70 degree.
So what is your take about the draft procedure if like frontal sinusitis is there?
Yeah,
how fully
draft,
you can
I
consider?
do in limited cases where it is.
So where do you
where
think
it
it should be
requires
done?
the draft, yes.
At the primary setting only, suppose.
Yes,
Yeah, in the
right.
recurrent cases, definitely we have to
Yeah,
think
but
about.
it still has limited. I am not a
Exactly.
very aggressive proponent of the draft procedure.
Okay.
I do it once in a way.
Okay.
And I feel it should be reserved for really those extensive cases.
Extensive cases or the
Yes.
recurrent cases, isolated
Yes, and then
frontal, yes.
tumors.
Exactly.
And as an
Osteomas.
approach to skull base.
Yeah.
You know.
For like tumors like from the cribriform plate or osteomas or encephaloceles.
See, now my frontal recess work has become more clearer. You can make out
Yeah, exactly, sir.
the pathway to the frontal now. Yeah. पहले ये देना. No, I'm just checking the giraffe. Yes, boss. ये दे दो, sponge दे दो. 45 डिग्री फोर्सेप्स दे दो, 45 डिग्री फोर्सेप्स देना. हाँ, अभी टिलीस में मिरोसिल देना.
Sir, do you think we need to cut out the medial end of the middle turbinate? Is that bulky to?
You can. I am a middle turbinate conserver.
Okay.
The disease is not that
That
bad
much
in this.
we have to, yeah. If
I
suppose,
don't think I should be sacrificing the
so
middle
where,
turbinate. That would be a little too radical, I feel.
okay.
No? One more sponge.
Sir, where you usually took the decision to cut the medial end of the middle turbinate?
Whenever it is very flappy.
Okay. If suppose,
Or really coming in the way of my surgery.
okay.
Here it is like more like a little nuisance.
Mainly for to get the access.
Yes, yes, yes.
If suppose, sir, like in CRS with the nasal polyposis, you get the middle turbinate is like
yes,
polyps is coming
Zero
throughout these
degree?
mucosa. I think then only we have to remove that part of middle turbinate.
Yes.
Yeah.
But otherwise I am quite happy
Conservative.
to leave the middle turbinate
Yes.
here only. पकड़ो बेटा. वो उसमें डाल दो. 70 में. Straight black asleep. Dilis देना. Straight black asleep कहाँ है देखो. इधर ही है ना. ये लो. अच्छा, सलाइन इरिगेशन देना. Okay.
So now
Garrison sponge दे दो जरा.
now we are seeing the intranasal endoscopic picture.
Yes.
Maxillary sinus is already been cleared with the adequate enterostomy.
Yes. So also the, the frontal sinus.
Yes.
Frontal and maxillary is over.
Yes.
I am just left with the sphenoid
And ethmoids.
post-ethmoid. So I will just open the bulla now.
Right, sir.
यस, डिब्राइडर में स्ट्रेट ब्लेड डालना. पहले मुझे ये दे दो. नाउ द एक्सपोजर इज गुड. द अनसिनेट इज रिमूव्ड. I can see the anterior wall of the bulla very clearly.
Right, sir.
So I think I'll try and open the bulla now. Yeah, this is what I've done.
Yeah.
Just open the bulla. Garrison sponge. The bony partitions are tough. So what I will do, I will use my Garrisons,
Okay.
which is a safe instrument,
Okay.
to first take away the tough bone. Debrider. Now I will use the debrider. Okay.
Yes, sir.
See.
In face, I think for every sinus there are the very different kind of approaches convenient to the surgeons.
Yes.
Yeah. This is the most common
Can you
technique you
see
are
this?
using to remove the bulla.
Yes.
Yeah. Now we can see the posterior ethmoids. Yeah.
Yes.
Yes.
Well, this is the medial wall of the bulla. Okay. Yes.
Very nice demonstration, sir. Yes.
Okay. Bone punch.
So, sir, at this part, usually
Yes.
we encounter the anterior ethmoidal artery. Already had gone through the scan. It was in the
Yes.
mesentery. So we can say.
Anterior artery
Yes.
is
So-
usually one cell behind.
Yes. If suppose this is in the nasal cavity, what precautions you usually took to delineate this area or the skull base clearance?
Yes.
So I think in that cases, people used to prefer to come from sphenoid to anteriorly.
Yes, yes,
Yeah.
yes, yes. See, if you are a beginner and not sure,
Yes.
see, remember the skull base has an angle of about 15 degrees.
Yes.
Anterior to posterior sloping, it is not linear and horizontal.
Exactly.
So if you go horizontally, you have a chance of, yeah.
Yes. Yes.
See, the anterior point will be here, where I am palpating now. Okay?
Yes, sir. Yeah, just posterior to frontal viscous. Yes.
Yeah.
Sometimes we get some mucosa
Bone
and cells
punch.
and see, it is very clear in these kind of cases. When we encounter the nasal polyposis, there are a lot of bleeding, and then it is very difficult to. Yes. Then always there is a fear of
45 degree
ethmoidal artery
forceps.
injury. Yeah.
And that behind portion could be the posterior ethmoids. Okay.
Yes.
Now you can appreciate the ethmoids are fairly nicely exposed, and the skull base is gradually getting
Sloping.
defined.
Yes.
Straight blade then a boss. बॉस डिब्राइडर दे दो। अरे गिर गया ठीक इसलिए वो देख के रखो ना।
Sir, to address the sphenoid.
Yes.
So, what route you usually prefer, like medial or lateral?
See, you can see I am going the intermedial way here.
Yes, yes, yes. That is the thing we just want to know.
Yes.
Because that part of posterior ethmoids we will clear after getting
Yes.
the sphenoid entry because it's very, very safe.
Yes, see,
Yeah.
this is the upper border of the coina here.
Yes.
So you can see.
Upper border of the cona is, I think, the most constant landmark even in the revision cases or when
Yes.
extensive polyposis is there. We
Yes.
just took roughly 1 centimeter idea from the upper border of the cona. Yeah.
Yes.
And we have to slide instrument along with the septum.
Yes.
Definitely will enter into the sphenoid sinus. Yeah.
Yes.
Is there any noddy cell in the scan? I was not there at the scan. Okay. Sir, sorry to interrupt you. I was not present at the time of scan. So,
Yes.
is there any noddy cell?
No.
Neither. Okay, fine, fine.
No
Right,
noddy
sir.
cell in this case.
Right, sir.
But it's always better to assume that there's a onodi cell.
Yes, yes,
Okay.
yes.
Suction, please. Yes. 1 minute, yeah. Debrider, straight blade, yeah. The bone here is very, very hard.
So
Yes. Yes. Sponge, please. मेरो सेल दे देना बेटा. Ball probe.
okay.
Bone punch.
So at this area you're dealing with the superior turbinate.
Yes.
Yeah.
-45 forceps. Suction.
So at this part, like sir was doing, he first he fractured the superior turbinate, then only he pulled it out. Because directly if
Yes.
we pull it out, there is a more chances of CSF leak.
That looks like the
Sphenoid sinus.
sphenoidal opening there.
Yes. Once we cut down the lower part of the superior turbinate, we directly
Yes, yeah,
encountered
this is the
yes.
superior turbinate.
Yes.
And here you can see the sphenoidal opening, you know, bone punch. Debrider. मिरो सेल एक रेडी रखो.
See, sir, once he get the idea of the sphenoid sinus, so that anterior to that ethmoid cells very easy to remove, so without any fear.
You see that?
Yes.
You see here?
Yes, yes. I think it's the non-dominant sphenoid
That's your
sinus of the
sphenoid.
neck. Yes.
Okay?
Yes.
Sponge. मिरो सेल देना बेटा.
Sorry? So, sir, during opening the sphenoid sinus, what precautions we have to take? Because, yes.
Basically, stay below medial and inferior, and most important landmark.
Okay.
I keep saying this, I follow it every time I open the sphenoid suction. See, the most important landmark I'll tell you, even if you are lost. Okay?
Okay.
Look at this maxillary sinus.
Okay.
Look at the junction of the roof
Right, sir.
and the medial wall, this point. Draw a horizontal line. Your sphenoid ostium will be just along that line.
Okay.
You stay along that line or below that line, you are always safe.
Yes.
Bone punch.
This is for the location,
Yeah.
for identification of the sphenoid sinus. And
For sphenoid sinus, I will tell you in a moment. Remember, you can confuse a sphenoid with the
Rhodocell.
posterior.
Yeah,
So
posterior
the
points
best way
also
to
first.
know
Yeah.
any cell whose floor is easily visible, where you can see the floor of the cell very easily.
Not be the sphenoid sinus.
See, look at this. You can see the floor
Yes.
very easily.
Yes.
This is a posterior ethmoid.
Yes.
Okay.
Right, sir.
And the cell which you cannot see easily will be the sphenoid. Bone
Right.
punch. So now we have opened up almost each and every cell. You agree?
Yes.
Suction. Look at the skull base now. Can you see this? See?
Yes.
Every cell is opened up. Bone punch. Take this. Debrider, please. Yeah. Straight Blakesley.
So posterior ethmoid cells already opened.
Yes.
Yeah.
And
This is sphenoid sinus.
the sphenoid is also
Yeah.
opened quite nicely. Debrider. Suction, please. Is Tushar ready with some case that side? Yes, then you can, I'll another 5 minutes, I'll transfer the camera to you. Bone punch? Yeah. Yeah. Yes. Okay. Debrider. Distance punch देना.
Hello.
Debrider.
Hello. Hello.
Hello.
Hello.
Hello.
Bone punch.
Hello, sir. Hello.
Yes.
Sir, like in the when we doing the maxillary enterostomy, we used to prevent the sinus stenosis. We
Hello.
actually prevent.
Clean.
We actually preserve the one of the wall, like in the sphenoid sinus. What is the precautions we have to take to prevent the sphenoid sinus ostium stenosis?
What?
To prevent the sphenoid sinus stenosis, like you are doing work on the superior lateral aspect now.
I couldn't hear you 1 minute. Can somebody increase the sound in the mic in the hall, please?
Hello.
Yes.
Sir, in the sphenoid sinus, now you are working in the sphenoid sinus.
Yes.
To prevent the later on sinus stenosis.
Yes.
So, what precautions we have to take?
Keep it wide.
We can work on every wall of the sphenoid sinus, or we have to
No,
preserve
no.
mucosa and the one.
No. One thing is you can, sometimes you'll have to work on every wall.
Okay.
Otherwise, not always necessary.
Right.
You can leave about 1 or 2 areas, like
Untouched.
mucosalized.
Yes.
Otherwise, you make it wide like this.
Okay.
What I have made.
Right, sir.
This is unlikely to stenose, and again the sphenoid is well mucosalized.
Yeah.
There is no bare bone area anywhere. You can see this.
Yes.
Huh?
I think skull base mucosa is looking normal. Not
Yeah,
that
45
angry.
degree forceps.
Yes.
And nowhere have we stripped the mucosa.
Exactly.
Okay.
Yes.
A couple of mirror cells show you a panoramic view.
So one term is
Right,
there,
I
full
know.
house space. Hello?
Yes.
One term is there, full house space.
Yes.
So can you
Yes,
please
hold
enlighten
this.
that and where we should consider that
Yes,
kind
yes.
of radical surgery?
If you notice, even the maxillary sinus, I have not widened it too much.
Right.
Because Tilly's forceps and mirror cell. But overall, now once you put the spray
Okay.
or the irrigation, it is going to. One more. And you see my middle turbinate is reasonably stable
Yes.
all along. Okay?
Okay.
Yeah. Suction.
Hello. Sir, we were actually discussing about the full house space where you consider this kind of radical-
Mainly in chronic sinusitis,
Okay.
but allergic fungal rhinosinusitis.
Okay.
70 degree scope dena beta. A full house face, mainly I would do it for
AFRS mainly.
AFRS.
Yeah.
Try to keep each of the openings as wide as possible.
Okay.
You know,
Then you strip out the mucosa of the skull base also.
yeah, sometimes
In
wherever
revision,
you feel it is diseased.
in sir revision cases of CRS with nasal polyposis.
Yes.
Yeah.
Ball probe. No, you give me the J curate. Yes, give me the 60 degree blade beta. One last bit of work. I think the antiathmoid is here along the skull base.
Okay.
This
Sir,
is a supraorbital cell.
sir, a bit bleeding is there. When can we?
Yeah,
see
1
clearly
minute.
bit? Yeah.
I'm still planning to do a little bit of work in the frontal recess.
Okay.
The last part.
So in the frontal sinus, the mucosa is looking like a bit edematous.
Hello.
Hello.
One case, just I am taking only 5 minutes from
Yes, yes.
Dr.
No, I am
Okay.
done.
Okay,
I am done. I am done.
Okay.
Sir.
You can actually.
Sir,
Hello?
I will show the simplified face.
Hello?
Just 5 minutes.
Yes.
Okay.
Hello.
Sir is also doing
Hello,
demonstrate
getting
the
the
face
picture?
also. Okay.
Hello.
Hello. Sir.
Are you getting the picture?
Yes, sir.
Yeah. You see my simplified face. Here taking the degree.
Yes.
And just feel the frontal
Straight,
peak.
0 degree.
And
then
just
I
with J-curate, just break the agar you will see the frontal. Every 1, 2, 3 frontal will be open. Okay. And you see my sucker, curved sucker always this way, going downwards. Downwards you see the anterior first, then posterior. Okay. And this all is simple. If you again you see my my sucker always upturned, so there is no chance of injury of any structure. Okay. This is the
Hello.
You see the posterior artery. This is the anterior artery. Okay.
Hello.
And hello.
Sir, you are talking about in which kind of, like, suppose there is a cones type 3 cells or the 4 cells or the type 2 cells, then it is very difficult for the beginners to like put a like a seeker upward and manger to the cribriform plate also.
For not beginner basically, for expert.
Okay.
So for beginners should not open the basically frontal sinus.
So
first with the under the guidance of mentor, you should open the frontal.
So there is a one technique, a very old technique in any kind of cells. If you are going like this way, we should put our seeker just medial to the middle turbinate. We are just going superiorly and laterally along the middle turbinate. You directly end up into the frontal sinus.
You see the frontal sinus is there.
Yes.
Okay.
Yes.
Just clearly simplified. Another side also I have opened.
Sponge.
You see
मेरा cell देना.
Same you see this way. Open the frontal and go downwards. Lamina right side, and you will see the anterior artery and go downward. Then is the posterior artery. Okay.
Yes.
And with 70, always I 70. And another point, I always open the first sphenoid and medially.
Yeah, posterior to anterior technique. Huh?
Yes, and then coming to
मेरा cell
the
3-4
posterior
दे
point
देना
completely. And that
और
way
दो दे देना.
I teach my juniors, please do this way, then you will be. Now another fellow said, now after your technique, now I am very much confident about the face, Arvind. So basically, a face is simple if you see and if you follow the technique. Okay, now
Hello. Hello.
I think Tushar, you start the thyroid.
Yes, it's already started.
Ah.
Open, just
Sir, already stripped out all of the skull base mucosa. What was the indication for the case?
वो ये डालना बेटा. Yes, ये दे दो. Suction दे दो, curved suction.
Sorry? No. Every information is on Google.
যাতে ওইখানে একটু পলিপটা করে নিলাম কেসগুলো শেষ করতে হবে তো আমি ওদিকে যাবো তোমরা ফোকাস করো তোমরা দেখো
Debrider. Straight forceps দেনা.
এই এখানে মনিটরটা দিতে হবে কিন্তু এখানে এই তারটা একটু
अच्छा
সরাও
ये
না
देना.
এই স্যার এই ডেমনস্ট্রেট এটা যাবে তো হ্যালো
Hello.
নাও রেডি
Debrider.
ক্যামেরা আছে নাও I will show the microscopic thyrotomy how junior will do without any too much fear. Okay, but you
Sir,
should take the microscope.
Sir, we are in I think OT, different OT. Dr. Haldipur is operating. We are seeing that screen. Hello.
Just 1 minute, sir. Microscope light throw. না না ও স্যার তো ছেড়ে দিয়েছে এটা মাইকটা অন করো ফোকাসটা দাও মাইকটা হ্যালো হ্যাঁ নাও আচ্ছা দিস ইজ দ্য লেফট সাইডেড thyroid nodule, okay?
Sir, we are actually now it is clear.
Okay.
Yes. Now we are seeing RBCs also.
Basically, I have done exposure because in the meantime, Dr. Holdipur done case and.
Sir, can you please zoom out?
Zoom out. Okay. In the point 4, basically, okay.
Yes.
This is the simplified thyroidectomy under microscope. If junior also follow this technique, no, the microscopic thyroidectomy, so fear will be less. I've exposed previously.
Sir, can you please a bit zoom out?
Again, zoom out.
Yes. One step zoom out.
Okay.
Yes.
Now
sir,
focus.
Sir, in hemithyroidectomy, which approach you usually prefer, midline or lateral? In hemithyroidectomy,
yes.
Which approach you usually prefer, which corridor, midline or lateral?
Key. Incessant. No.
I think
midline approach.
Like in usually midline approach, we split the.
Split already done. Okay, I also.
We'll split the stap muscles, while in the lateral approach.
This way was there.
Yes.
I have done previously without any and subplatysmal level dissection.
Okay.
And midline separation.
Yes. These are the stap muscles you already.
Yes. Already.
So this is the midline approach. Yes. In lateral approach, what we people used to do in hemithyroidectomy, we put a lateral incision not in the midline, and we dissect in between the stap muscles and the sternocleidomastoid muscle. So in that case, we directly encountered middle thyroid vein and RLN. Yeah.
Here I will show the how it is simplified. Just simple dissection. Okay. Because likely here will be the parathyroid is a color. Okay.
Yes.
And just every tissue you should know. So no fear.
Sir, your one basic thing I just want to ask, you are operating on the side of the pathology or on the opposite side?
No. So my one assistant likes the same side, but I always right side.
Okay. So you are doing subcapsular dissection, huh?
Yes.
Yeah, this is the best way to prevent injury to the RLN and or
and also
parathyroid glands. Yes.
Look here. All will be seen clearly, basically. Now every structure I will see and I will cut it. So why unnecessary fear? No. Yes.
So this is the advantage of microscope.
Yes. For that reason, I mentioned the I will show legacy. So I love to purchase the instrument because I love to do.
If you have money, then only you can purchase.
Yes. So. No, basically I belong to middle class family, but I love.
You earned that, sir. You earned that.
Yes. This is legacy or.
Yes.
No, every structure. You see every structure, no? Yes. Unnecessary. Sometimes I have seen also recurrent laryngeal nerve also this way come. So always not over the trachea laryngeal nerve will be there. But my technique always you see every structure. Okay.
Right.
Nerve monitor is there. Still I am not showing the nerve monitor today. Because I am showing the without nerve monitor also. If you see, this is the recurrent laryngeal, I think. Okay. And very fast it will be.
So, sir, what was the pathology? What was the brief history of this case?
Nodule. I will show
colloid nodule. On USG, kind of any classification was mentioned. Bethesda, Tiroids. What was the 2 or 3? Something is.
Triads, I think 2 or 3.
Because in type 3 always there is a chances of malignancy when comes out to be the colloid goiter.
Triad after 5 there definitely chance of malignancy.
The 4 and 5 is definitely there is a malignancy when there is a type 3 Bethesda.
Tiroids.
Right.
This is Tiroid 2.
Yeah. And on FNAC it is always type 2. Then we have a clear cut indication for the hemithyroidectomy.
And now you see the recurrent laryngeal nerve. Because
Yes.
my target to see the recognition here, thyrocricoid junction. This is the most dependable part of to see the recognition. You see the recognition.
Yes.
I will show the recognition, prominently recognition. Every day you will see the recognition nerve. Bipolar.
Sorry. Okay.
If you use the microscope, then you will love this. The microscope. This is the recognition nerve, okay?
Okay.
So I am working over the recognition nerve, but not so much fear. You lift it and do it.
Tushar,
Yeah.
in that situation, usually a triangle comes, and that
Triangle
triangle,
no.
you are following the triangle, or
Hello?
particularly in that area, we call it a Lord's triangle.
Yes, Lord's triangle.
Lord's triangle. Will you follow this Lord's triangle,
No,
or
I follow my eye only. No triangle, basically. Yes. By basic principle, my surgery is very simple. So thyroid, removal of thyroid, leaving behind all important structure. This is a surgery basically. So I prefer always this way, and also I in master surgery also, step surgery also, and face surgery also.
So this is the advantage of subcapsular dissection, sir. Yeah, you just
No,
dissection in the
250.
subcapsular plane and you
Yes,
left
please,
every
yes,
vital
please,
structure in the bed.
So look here, this is the, here will be the recognition nerve, okay?
Okay.
This is will be the recognition area. So thyrocricoid junction. I will feel always the thyrocricoid junction. So if when lower pole always. No. কমে যায়.
Yes.
মেটা দাও তো একটু. রিনি.
There are a lot of triangles. Bare triangles.
You see the recognition nerve?
Larry's triangles.
Clearly, okay?
Yeah. Sir is right.
If you see the microscope, always you see the recognition nerve clearly, okay?
Yes. Follow your instinct and your eyes.
And sometimes also branch. I have seen also lot of time is the branch, okay? So when you see the recognition nerve, then you go, this is the recognition nerve, okay? This is the recognition nerve, you are sure?
Yes.
Okay. So fear only the recognition nerve, about young or for all youngsters, the recognition nerve only the structure, the fearing, no superior laryngeal nerve. So if you are 100% sure the recognition nerve will be there, so thyroid surgery is nothing, okay? But I am nothing without microscope. So I am nothing by
So-
microscope. Without microscope,
Sir, whatever you are saying, it's true for the colloid or the benign thing. If we are dealing with the malignancy, if we have to do the total thyroidectomy along with the neck dissection,
Oh, but,
so every
in col-
bit of tissue will left that make a significant difference.
No.
yeah.
Yeah, in case of total thyroid also, we are
Yes.
not removing leaving any thyroid tissue. Microscopic also
Yes,
there is
yes,
advantage. If
Yeah.
I remove from thyroid area also,
Yeah.
I will every time I will remove all tissue.
Yeah.
That is also advantage in
This
microscope.
is a general thing, sir. You are doing very, very good job.
You see now the
Sometime we find,
parathyroid,
sometime we
okay?
not, but
And
if
we
there
do
is a
parathyroidectomy
cross disease
also
with the nodal
under
metastasis,
microscope.
Like in the medullary, we find
Now
lots
here,
of lymph node. We have to do that
dissecting
dissection
the
over there. It's very
superior
difficult
parathyroid,
that
okay?
way.
And now I will go the upper pole. And upper pole, every time there is a chance of injury, but if you see the microscope, then chance of injury will be less also. Now here recognition also is there, okay? So that portion,
It didn't come.
if you cauterize, no
Come in
tension.
the very
Okay.
few patients. So how frequently you sir encountered
No.
the middle thyroid vein in?
Sometimes is there or not. Sometimes
Yeah, it is
I have
not
seen or not.
consistent thing. Yeah. So I think that nodular Zucker candle I think is in the picture just below your finger.
Yes. Now I will show the upper pole. Kamaldas, no, call upper pole.
Tubercle of
I am
Zucker
sure,
candle is also a landmark for the
Yes.
recurrent laryngeal
Then-
nerve. Yeah.
and one gutter will be there. One gutter will be there. That gutter I will follow, and every structure I will see. Without knowing any structure, I will not cut or diathermy any structure. Okay, every structure I will follow. Every artery, every vein. So no way I will. Yes, you see every structure.
This is the most avascular plane where you are dissecting.
Yes, sir.
Some people start the dissection at this plane. This is the angle of Rose's avascular plane.
Yes. So my parathyroid already gone. So this is the gutter.
Gone in the
I'll-
bed, I think.
And the external branch of the supralaryngeal, this will go this way. Okay, so I will go that upper part. Okay.
Yes.
So it's very difficult to injure that part. That part. Okay.
In hemithyroidectomy, we can sacrifice without
This way,
any
okay?
leg.
And also now I will do 3 steps. First, this no cut. Here I will do this and cut. Yeah.
No suture technique.
No suture. Under microscope, no. For that reason, I purchased this instrument only because I
Yes.
prefer to do.
You're lazy to do the suture.
Yes, but under microscope suturing is sometimes difficult, irritation.
Yes.
So here now ligature.
Yes, yes.
So now simplified. Simply you see, the thyroid will be done also very simply. Look here, the stretching, and you will see. Look here, my recurrent nerve.
Yes, sir.
Looking to you, no.
Right.
So no tension at all.
No
So-
headache. No
So
headache
this
at
way,
all.
This way. Sometimes I will use the blade also, but sometimes blade.
We can easily appreciate the ligament of Berry fibers. Yes.
This is the ligament of Berry.
Yes.
Sometimes bipolar also. Another surgeon different. Here no. Your question is the cancer surgery. When we do dealing with the papillary carcinoma or something,
Yes.
I always remove every bits of tissue, no?
Yes.
Because at that time I always seen the every structure. So microscope also no harm in case of cancer
Sir,
surgery also.
in papillary, if suppose there is no nodal metastasis, you prefer to do the central compartment
Central compartment
dissection.
always.
Yeah, it's very important in that case.
So you see, again my ligature.
This is bipolar.
This is bipolar.
Yeah. That white color instrument previously was there. That was ligature. Yeah.
Another 30 minutes, please wait. Okay, I'll show my last. And
Another 30 minutes for what?
this is the finish. Okay,
Yeah.
this finish of thyroid. Okay.
Very nice demonstration, sir.
The ligature and microscope. So without microscope, I am nothing. The all structure. Look here. Superior parathyroid, inferior parathyroid, recurrent. Without knowing anything, I am not doing anything. Okay. So, okay. So you are happy.
Yes, sir.
So simplified thyroidectomy, basically. See, beautiful recurrent.
Hello.
Parathyroid.
Hello.
Hello.
So there is a question from the audience.
Yes, sir.
So what are the chances of reactionary hemorrhage after using the ligashore, because we are not putting any kind of secure sutures?
Sir, basically, ligashore not, I am not discovered. Discovered company is the basically Covidin and Johnson & Johnson. Basically,
so we are asking about your experience, because you are using that instrument now.
My experience, no, I have not seen.
Okay,
and
okay,
I have
okay.
seen in also another nursing home,
Yes.
big artery vessels they are clipping with the ligashore.
So another one is the price.
And also
most
no
probably
chance.
next question would be how much charging you are.
Hello? Charge, cost of ligashore, sir. Cost of
Yes.
ligashore not so much.
Okay.
6.75 is after bargaining, but this cost is 35,000.
So sir, I have 4 ligashore.
Only ligashore machine cost is 6.75 lakhs, but this is the hand instrument, but hand instrument you should change sometimes after few cases. This is the cost of 35,000.
Sir, we can you enlighten the superior laryngeal nerve in the field, sir?
Basically superior laryngeal nerve will be there, but my target sometimes not searching the superior laryngeal, always
Okay.
searching the recurrent.
Okay,
but
okay.
I'll remove the thyroid, seeing the every structure. So I am sure I have not injured the superior laryngeal, okay?
Yeah, superior laryngeal nerve, if it is not injured, then
Yes,
it was
because
okay.
this way will go.
Sometime in singers, it would be more difficult
To injure.
because their tone will
So my
change
last
after
case,
the
okay?
Yes.
All ready, flap already ready. I am just showing.
Hey, Dr. Ghosh.
Yes, sir.
Hey, I am Dr. Mukherjee.
Hi, sir.
So it's an excellent demonstration that
Thank
you have
sir.
done.
Your talk means I am so happy. Now last my case, one step is.
So just one point.
Yes, sir.
Just one point we want to know, that of all the advantages that you are showing us with the microscope, so which one do you think is the most important advantage for which even those of us who are not doing microscopic thyroidectomies should change to the microscopic thyroidectomy?
Hello, জোরে বলো একটু।
বলছি কোন অ্যাডভান্টেজটা মাইক্রোস্কোপ ইউজের ইজ মোস্ট ইম্পর্টেন্ট, যার জন্যে মাইক্রোস্কোপিক থাইরয়েডেক্টমি আমাদের সবাইকার করা উচিত।
মাইক্রোস্কোপিক থাইরয়েডেক্টমি করলে আপনি আমি বেসিক্যালি নট সো এক্সপার্ট ইন হেড নেক সার্জারি, but only microscope now the given me the head neck surgeon, basically only microscope, believe me, because I am not trained in hospital any head neck, but I am now confidently I am doing the parody of doctors basically. Nowadays thyroid is very relative cases because only the microscope, because the still navigation NAR monitor purchased a few days back, but before that I have done the doctor's case, doctor's referral case, doctors, my doctor himself, done because the only microscope.
Only because there is a microscope.
Yes, microscope, because I know basically the structure I will not injure anyway. I am not a big surgeon like big head neck surgeon like you basically. I know you. So, but
no,
I know
actually, Tushar, what I mean is,
yes,
the most important advantage is practically identifying the vascularity of the parathyroids.
Yes, sir.
And that is not possible, almost not possible with naked eyes, at least when you grow up with age.
Sir,
and that is the only way out that you can save the parathyroids, because it is just not keeping back the parathyroid, which is important. It should be kept back with its vascularity.
Sir, believe me, just few days back, only 5 minutes I have removed one parathyroid. That is possible only under microscope. I am not taken any credit basically.
So what was the size of that parathyroid adenoma?
Parathyroid adenoma, that left side parathyroid adenoma. I have
What was the size?
Oh, size at least I think nearly 1 centimeter.
1 centimeter, yeah. Okay. So like you did the bloodless surgery, and do you need to put a drain? Do you think?
By some way, sometimes I think, but still small drain I placed, and next day drain off. Still I am giving the drain, because I have seen with less minimum bleeding also slight bit of collection is there.
So sir, nowadays some people are doing hemithyroidectomy in the local anesthesia only. So what is your point on this discussion?
Hello?
So what,
local anesthesia I am not capable, sir. I don't know basically, but I am more comfortable with the this technique. No, GHOSH thyroid da local GHOSH. Hello?
Yes sir, no signals.
Hello? This is the most difficult step is I will show. Here no space is there. So how will manage this case? This is the real challenging case for any conference. Look here.
Sir, we are not getting the endoscopic picture.
Picture, please.
He's just rushing.
And one legends is there. Definitely he will tell this is the most difficult case.
So endoscopic, microscopic pictures are there.
Eh?
We are seeing the coda and incus, IS joint,
But no
stapedial
foot plate,
tendon.
no foot plate.
Okay, right.
My assistant done some job for me, so unnecessary I am not wasting time basically, because the still some cases is pending. So without demonstration some case will be done inside basically. Look here, no foot plate is there, no?
Right.
This is the real challenging case. Okay. So this is the case for conference. How will be managed? And one legends is there with me. He will guide. And Kamalda also will guide.
Sir.
Okay. Look here the picture. Okay.
Hello.
Hello.
Sir, there is a request from the audience.
তুষার
হ্যালো কমল
তুমি পুরো ফাইন্ডিংটা ভালো করে আমাদের বলো তো আইডেন্টিফাই করে দাও
হ্যাঁ প্ল্যানিংটা বলছি এক সেকেন্ড আমি আরেকটু এক্সপোজ করি কোনো ফুট প্লেট নেই কেসটায় তাহলে কেসটা কি করব সেটা ইম্পর্টেন্ট
না ফুট প্লেট নেই মানে কি বলতে চাইছো
ফুট প্লেট নেই মানে ফুট প্লেট আছে কিছু দেখা যায় না ফেসিয়াল ওভারহ্যাং যে বারবার কোশ্চেন আছে কনফারেন্সে সেই কেস এটা পেয়েছি
সেটাই বলো রাইট
সেটাই বলছি
ওকে ওকে থ্যাংক ইউ
তাহলে কি করে কেসটা করব
Understand the language?
Real challenging.
Okay, it is not visible. Oh.
Not visible, yes.
It is there, na.
Definitely footplate will be there.
Yes. We were thinking footplate is not there at all.
No, footplate is not there means I am not seeing the footplate.
Yeah, it is not visible actually. We have to make it.
Yeah, totally one question at the time, no? For junior, drilling this type not so easy, so you should drill this way, this way. I ask my junior, drill this way, this way, this way, just medial to lateral, okay? When you will be expert, any way you do, no problem.
Hello.
Yes, sir.
So there is a question from the audience. You are using the diamond or the drill? The cutting drill. Cutting bit. Cutting.
But for junior, I am not suggesting this.
Okay. So what is the size of that bit?
I think 2 to 3.
Okay. Yes.
Up to promontory. Okay, I will expose this.
2 is big. 2 is too big. Is 0.2 or something?
No footplate visible, okay?
Yes. I think pyramid is visible, huh?
No footplate visible, no?
Stapedial tendon is visible.
Only stapedial tendon visible.
Yes. Pyramid is also in the view. Yes.
So slide bit I am zooming, then it will be. No. Look here, no footplate visible. So in that case, my question: how will manage this case?
Can you please zoom in a bit? One step ahead. Yes. Yeah, because of that blood droplet.
So now my question, sir, all legends, how will case is manageable? You will abandon this case or will duel the case? Now question to the audience. Hello.
As like legend like you should do.
No. also I am asking the question also.
So non-legend can see and appreciate your work, sir.
No. Now this problem already started.
And there is one comment from the audience. Non-legend do refer to you.
Look here, this case not possible anyway to do the stapedial tendon preservation. Definitely, sir also no.
So, sir,
Not
in
right.
deep, this is the facial nerve that is overhanging this.
Yeah, total. So first I will do.
Same thing I was asking you in your previous case. When foot plate is covered with the facial nerve, so what should our decision intraoperatively?
Yeah.
Because we are not getting the CT scan for each and every
Yes,
step is
no.
case.
Still, I will manage this case. Please come. Please stay with me for 15 minutes.
Yeah,
Okay.
we are
How
with
will
you.
manage this case? No, measurement করব না এখন। কেটে দাও। How will manage this case? না, কেটে না, cut. Stapler. First, I will cut the stapler tendon here. Okay.
Yes.
Then I will do posterior corotomy. Then I will create the space.
The focus is not.
I think God will support me.
Work, no? That's why you just keep focus up.
Yeah. Okay.
When he's going to do work in
Yes. Now I will do a Norvenna.
Sir, can you do please a bit focus?
This is the.
Yes. Now we are getting it.
Yeah. Okay.
Yes.
This is the stapedial cut. I the stapedial tendon. Okay. Now I will do with the skitter. With the skitter I will do posterior corotomy, not anterior corotomy. Still anterior crura will be there. So stable incus. I want stable incus for good piston placement. This is technique I follow always. If difficulty, no suprastructure removal. Only posterior corotomy. This is the diamond, okay?
So, what is the size of the burr? Yeah, skitter you are using? Hello?
Point
6.
Yes, 0.6, 0.4. Look here, how I'll create the space there. Now I bit little bit, no? So now you see the foot plate, they appreciate.
Sir, a bit out of focus, sir.
Oh, yes, yes.
Can
So
you
now-
please centralize it
yes,
and
yes,
focus
yes,
it?
Yes, yes, 1 minute. Now you appreciate
Yes.
the foot plate, no, 1 minute just.
Yeah,
You
we can
appreciate-
easily appreciate it just below the
Yes,
facial nerve.
So,
Yes.
yes, cotton, please cotton.
Sir, can you please zoom in a one step ahead?
Yes, yes. Basically, one zoom is there. Still, I'm doing
asking if,
1.15.
Is completely
1.16. Okay. This is the okay, no?
Yes, that was the thing.
This is the 1.6 zoom, 16 zoom.
So there is a distance.
But I am not comfortable.
So there is a distance.
I am comfortable with the
occluding
10.
the foot plate.
Okay, I'll manage it, no problem.
Yes. Yeah, it's like the same.
First, I will create the space first. Suru down.
Yeah, it's, I think some foreign body hairs are there. Huh? Not- now two foreign bodies are there.
Now little bit happy, no?
Completely hit it.
So if laser,
Completely
just laser. Now measurement, okay? Give the measurement.
Yes. that you can say.
Tushar,
Yes, yes.
before measurement,
4.5, 4.25. একটা ঢুকিয়ে দাও ওখানে ওইদিকে টেম্পারেন্ট করে দাও ম্যাস্টটাকে ক্যান্সেল করে দাও কালকে বলো খাইয়ে দেয় কালকে রেখে দাও এই
some Tushar,
yes,
some foreign body is there.
Some foreign body cotton.
Cotton is there.
Cotton,
On the cotton there are some hairs.
Hair.
You can irrigate and
I don't
clean.
know how hair is there. ওয়াশ করে দিই একটু জল দিই হালকা জল নাকি
You can irrigate. Wash it
irrigate.
out.
টিপস কর
Now the foot plate can be appreciated.
ম্যাস্টটা কিন্তু করা মুশকিল হয়ে যাবে আচ্ছা ঠিক আছে চলো ডিল করে দেবো তুমি করে দেবে
Hello, Tushar. Hello.
পাটিয়া ঝামেলা করবে হ্যাঁ বলুন স্যার
Have you come across any patient where the fallopian canal is completely hiding the foot plate area?
hiding not I have not seen staphylococcus artery I have seen but I'll manage anyway basically pressure cotton ball I'll do any case I have done this different only congenital anomaly I abandon this case otherwise any case I am doing
Okay.
This type of difficult case I have seen also previously. This is the slight bit of na suction হচ্ছে না বা ওয়েট বা জেল ফর্ম দাও আমাকে সাকশন হচ্ছে না just first of all I'll suck clearly otherwise after fenestration problem will started. Yes, now I'm happy. Okay.
Yeah.
Yes, now I'll do with first 0.5, 0.6, 0.7 control fenestration with the storage. Basically, otherwise sometimes the problem though. Hey, two case দুদিকে ঢুকিয়ে দাও
Already measurement has been done.
Yes, 4.25 I will place. Foot plate থেকে middle part of the incus. Add করি yes. না কিন্তু এর মধ্যে ঢুকবে না খানিকটা ফুটোর মধ্যে খানিকটা ঢুকবে তো some mucosa is there.
Hello, Tushar.
Yes.
The inferior aspect of the fallopian canal may be sometimes
touching, but no problem.
Hello.
This is the most difficult case. Please,
Yes.
just 1 minute.
Okay, fine.
করি তো, কিন্তু আমি তো অ্যান্টির কোডটা এখন রেখে দিয়েছি স্টেপল। এ মাইক্রোস্কোপ ঠেলো না গো। হয়ে যাচ্ছে। So this is the very thick foot plate. So slight bit of weight required, otherwise free movement not possible.
The fluid is coming out. Huh? So there is more chances of injury also.
Yeah. একবার দাও।
Tushar? Hello?
This I am creating the funnel shape, okay?
Okay.
Because the free movement, for free movement.
Right.
Because I am not using the here skitter.
So how often you use a skitter at this stage?
Sometimes I use, but here not regularly, here not using, in conference also. If
Has skitter any advantage over these perforators at this
here
step?
advantage is the thinning of the footplate, because I am now still preserve the anterior cruda.
Okay.
একদম 0.6 হতো একবার। So here like skitter, no, I am already with 0.7. If you have no skitter, then this way will be do.
But now you have laser also, no? So in such a thick foot plate,
Work here.
what is
The laser, for laser,
Yeah.
drill thin up to blue level.
Oh, you have to drill up to blue level. Then you can laser it out.
Basically, this case is, I think, slight bit of congenital anomaly. Yeah, now is happy. Now put the piston. Okay.
Yes.
So difficult case, but it's possible.
Impossibly possible. You make it possible, sir.
Make it possible.
Yeah. Yeah, it's come with the pulsation. Yeah.
Yes, sir. It's a very difficult case. Totally.
Hello. Hello.
Yes.
Sir, some amount of fluid is coming out. Is a perilymph.
Just 1 minute. I am doing piston placement only. Then Venesta ho gaya is very difficult. Step is basically foot plate adhesion, foot plate overhang.
So is there any point to
Only-
put
only-
fascia over there?
Only posterior crudotomy done.
Fascia.
At first, and then still. Bigger.
Yes, yes.
Funnel shape done.
Yes, yes.
Oh, your
Right.
your face case, no?
Yeah, exactly.
First put the in the fenestration, okay?
Right.
This way. So if you are not visible both one shot, just don't try to put. Try to put.
Tushar. Okay, that.
Yeah. There's a lot of soft tissue was there.
ऐसा तो 25 peak placement, then you make the hole a little bit larger. Dr. Bangas was habituated to do that.
In this case, strength is there.
You will get no space. Surrounding space is less. হয়ে যাবে কিন্তু whether best
Otherwise, I'll wait after gel form and then after Deepak's case I will do. If not bar repeatedly, his problem is there. This way. Just go the first fenestration and then over the incas. Okay, this is the technique basically. Same case. Dr. Deepak, just do first and then come. I'll bleeding stop basically. More. Yes. So, আরেকটু বড় কারণ এটা তো ভেরি থিক না গিভ দ্য জেল ফর্ম হ্যাঁ একবার শিফট করে দাও ওটা শেষ হলে আমি কমপ্লিট করছি পিস্টনটা খুলে নাও হ্যাঁ এটা আছে বাকি কেস ডেমনস্ট্রেশন হবে না গোপনে হয়ে যাবে আসলে আরো প্রবলেম হচ্ছে কি স্যার এটা তো মিউকোসা ছিল প্রচুর ফুড প্লেটের ওপর না প্রচুর মিউকোসা ছিল বুঝলেন তো ঠিক ফুড প্লেট এন্ড মিউকোসা ইজ দেয়ার সো ব্লাড ইজ দেয়ার সো জাস্ট ওয়েট
Hello?
Yeah, hello.
Can you hear me?
Yes, sir.
You are getting the endoscopic picture?
No, you're still with the microscope.
अरे वो काम का ही आ रहा है
Hey, change that room. No, দিয়ে দাও না ওখানে
Yeah, now you can see your face.
Straight. Now it is seen.
No, the endoscopic picture is not there. It's the external camera.
अरे endoscopic picture लगाओ बॉस. Straight blackishly देना बेटा.
No, not yet.
No, I will wait.
Yeah, now you're getting it.
Now you are getting?
Yeah.
See, this was the case initially, it was bleeding a lot.
Right, sir.
Yes?
Yes, sir.
Now I'll take out one mirrocell by one mirrocell. You are getting the picture?
Then चले जाओ.
Yeah. Can you see the middle meatal antrostomy?
Yeah.
Quite wide?
quite wide.
Yeah, straight Blakeslee, then abhi diya tha na, yही.
So,
ये निकालता
sir, I
है.
think it is the mega enterostomy.
Huh?
I think it is the mega enterostomy.
Yes.
So,
Now,
yeah.
see this.
So, there is a question from the audience. What was the ideal size for the maxillary
Again,
enterostomy?
depends on the disease.
On the left side, it was like a 4 mm or 3
Yes,
mm.
yes.
On the
Because
right side, it is much bigger.
Because the disease was not much on the
Left side.
left side. Here are all the polyposis.
Yes.
Can you see the sphenoid there?
Yeah, beautifully we are seeing
Suction.
that. Yes.
Yeah, now that is your sphenoid sinus.
Yes.
Okay.
Okay.
This is our enterostomy. I always tell people, look at the upper part of the maxillary sinus
Yes.
and the relation with the sphenoidal ostium.
Right, sir.
Straight horizontal line. Okay.
Okay.
70-degree scope. Now one final look with the 70-degree scope. Can you see the frontal
Yes,
there?
beautifully seen, sir.
Yeah.
Yes.
And can you see the anteroethmoid artery on the
Yes.
face?
Yeah.
Can you see this anteroethmoid artery?
Right, sir. It's
Yeah.
in the view.
Yeah.
Yes.
As I go down, you can see the sphenoid.
Sir,
And as I rotate, you can see the maxillary.
maxillary. Yes.
Yes, in a
Yes.
single view.
Sir,
can see the-
is there any some posterior ethmoid cells are there? Or yeah, this one.
Yeah, we can take out
Yes, this one.
45-degree forceps.
Yeah, these are the posterior ethmoid cells. Might be some disease is behind that. Yeah.
Yeah.
Yes.
Debrider 40-degree.
I think just.
Yes. Maybe we'll take out a little bit.
Yes, sir.
There
We're
are
talking
one
about
cell.
these cells. Yes. Yes.
Yes. That was a good lead, actually.
Yeah. What we used to do, we not completely delineate the lamina papricia. We just working along with the lamina papricia. We
Yes.
just defined our lateral limit so
Yes.
that any kind of ethmoid or
Yes.
whatever cell did not left
Yes.
behind. Yes. Yes.
45-degree forceps, but that was a good lead because the moment I put in a 70-degree,
Yes.
I also realized that I had left a couple of cells there.
Because of when we open the sphenoid sinus and we just have a look over the ethmoids or the skull base, there is always be a slanting. There should be in any hump.
Yes,
If any
yes.
hump is there, definitely some cells is left behind.
Yes. That was a very good suggestion.
Yes.
Yeah, debrider.
Yes. This is the ideal, like, yes. Yeah, this ledge we are talking about. Yeah.
ब्लॉक हो गया है वॉल प्रूफ दे दो
So meanwhile, sir, we just want to ask you, like, after the face surgery,
yes,
what precautions you usually took post-operatively? What is your protocol to
operatively
prevent
basically to do a regular this thing
washing?
Yes.
Washing, yes.
No, endoscopic cleaning.
Okay.
45-degree forceps.
Any
So the bottom line is,
yeah.
though it takes a little time,
Mhm.
it is better to do a thorough job once you take up something.
Okay. So
You know-
sometime we'll end up in the trouble because of the some not properly post-op care.
Yes, yes,
Yeah.
yes.
So what precautions we all should take, and at least few things we have to do.
No,
Sometimes
one is endoscopic cleaning.
Right, sir.
Second,
How
maybe,
frequently we should advise the patient to come for
seventh
the
day, 17th day,
Okay.
27th
Okay.
day.
Fine. Fine.
And then if required, one on the 42nd day.
Okay.
Yeah. स्ट्रेट ब्लेड है तो स्ट्रेट ब्लेड दे दो बस, नहीं तो अगर ये ब्लॉक हुआ है तो स्ट्रेट ब्लेड दे दो.
So, like post-op, we usually prescribe do the nasal douching with the nasal wash. nasal
Yes,
wash
yes.
Or some
If it
like,
is AFRS,
yes.
you can even go for
Sir, আমার just 1 minute.
budesonide irrigations, you know.
Budesonide only for the AFRS or baki? Sorry, rest of the like
Rest
CRS
of
with the nasal
the
polyposis.
CRS nasal polyp, some amount of spray is enough. Irrigation and all.
Okay.
First few days, later on no.
Okay.
What requires very meticulous treatment is the AFRS only.
Okay.
Because the recurrence and then the mucin has to be cleared periodically.
Yeah.
So that is always there. Now I think both of us are happy.
Yeah, exactly, sir. Now everything is looking clean now.
Yeah, see?
Now there is no headache.
चलो मैं खत्म हो गया. Close.
Sir, like this is the case of CRS without polyposis. Is there any role of linozolids and vitamin D? There are few
No,
articles
no,
saying-
no, no.
Okay.
This is a simple polyposis, even if it is AFRS.
Okay.
We have caught it at a very early stage.
Right, sir.
Let's not overdo anything.
Okay.
I think I'll pass the camera to
Yeah.
Tushar Kanti
Yeah.
Ghosh.
Thank you, sir. Thank you so
very
much, sir. Thank you so much, sir. Thank you so
2
much.
minutes, okay. So give the
0 degree देना
camera fixed करते बोलो.
और पैक देना.
Hello.
Hello.
The camera is there.
Sir, actually, we need to shift the screen to your OT.
Okay, okay, just 1 minute. So my work only 1 minute or 2 minutes. Please allow me. Basically, at the time,
Hello?
mistake was there. At the
Sir.
time, my mistake was the 1.6 zoom. So, but I am not habituated to do.
Sir,
because-
screen need to shift on your OT.
Okay, okay, just shift हो जाएगा. So
Okay.
at that time,
Uh-huh.
some difficulty. Why difficulty? I understand. Basically, 1.6 zoom.
Okay.
If you 2 zoom, then control of piston in one shot over the incas and over the fenestration is very difficult.
Okay.
Okay. Now the zoom out. I think now it will be more controllable. Now picture is there.
Yes, sir. It's clear. Good fenestration
Okay.
is seen.
Now I will put the piston. Here I will told this is the half reverse because piston দাও. Piston দাও. জায়গা তুলে দাও না। ম্যাস্টারটা আজকে ক্যান্সেল করলে হতো না? বলো না। হ্যাঁ বলো না কালকে করে দেবো কি আছে?
Hello.
একই ব্যাপার তো।
Hello.
আজ এমনি বাড়ি যেতে পারবে না। হ্যালো।
Sir, is there any advantage of putting temporalis fascia
No, sir, I
over
have
this
not-
fenestration?
I have not used it.
Okay. Okay.
Sir, 1 minute. Just I am this way. You see, this way. Slight bit of angulation. Okay.
Right.
Angulation, and always you just first look the fenestration. Okay. Look the fenestration, and then over the incas in one shot. Okay.
Yes.
This is the my technique.
Beautifully.
Anyway, before that system, I missed because the 1.6 zoom, 1.6 zoom is accommodating both is very difficult. So why this I am doing this half reverse, because I am telling you, you have seen the SAT's case, because the when sir tried to fixation, such a movement, no, too much movement of the incus was there. Okay.
Okay.
But here less movement, because the still I am securing the anterior crura. Okay.
Okay.
This is called the half reverse technique. Half reverse, because half reverse I tell is the half reverse, because here you see here still anterior is there, sir, here still anterior is there. Now I'll remove the anterior, okay,
Okay.
separately. Separately I break the anterior, then join dislocation, okay. দাও এটা কথা গেল সিকেল. So here you see now my job done, okay. Now my job done, no. So look here how the patient will be safe, because the manipulation of the foot plate, that is the main culprit. So manipulation will be, the piston is very less, because the one shot if you miss also, no, now done, my job done. So beautifully, look here, the patient is happy, no.
Very nice
Look
demonstration,
here,
sir.
yeah, most difficult case in this conference, sir. Sir, totally facial overhang is there. Now I cut the first cerebral tendon, after that posterior crura. Still anterior is there for the stability. I have seen, sir, still the stability. After that piston placement, then anterior crurotomy, then junction displacement. So the most difficult case this conference, okay.
Thank you so much, sir, for the nice demonstration.
Thank you so much.
Yeah. Any question from the audience?
I am lucky because in front of all legends, there are audience, there are a lot of legends, and here also one set to legends definitely all knows. Kamal Haldar also legends. Dr. Haldar is there also.
Dr. Ghosh.
And yes, sir.
Hello.
Hello.
So you have done lots of trapezotomy, sometimes with preservation of trapezius tendon,
yes,
and
yes,
sometimes without preservations.
Yes,
Yes.
Utpalda.
So how is the difference between these two? Are they practical? The
Definitely
post-operative
there is a difference,
period.
because nowadays I am doing a lot of revision cases, different incus necrosis. All this case not cerebral tendon preserved. Incus necrosis also due to this problem.
Yes.
Okay. And I am lucky also in front of Utpal Da. Basically Utpal Jana is my guru basically, and because the basically in my initial practice in hospital not a step is not possible, no. After that in my practice I always
Okay, Tushar.
initial
Okay.
life I always hired
All know from your name in the OT. Okay. From my name in the OT complex. Okay. Thanks for keeping my name there. So
Yes.
nowadays usually the students forgot the teachers, their role. But I am not a teacher, direct teacher of you, but still you mind it. Okay. Now, my question is that
Yes.
what is the difference?
difference is there, sir.
Because is it very important to preserve the stapedius tendon?
Basically Shat's paper is there, but in livid paper, sir, sometimes incus necrosis is very less, and also loud sound, patient's ability, no, loud sound discomfort, loud noise discomfort level really less in case of, because I have demonstrated lots of time.
From my experience, I have that the patient usually complains of hyperacusis in the beginning for 5 to 6 months like that.
After that,
the patient usually. What is your opinion, Deepak?
After that, patient habituated. Only.
Stapedius tendon cutter.
Only the habituated basically. But if you preserve the stapedius tendon, believe me, incus necrosis, pistons slip, all will be less. Luckily, I have done my case 10 years back.
And one question from the audience also:
Yes.
how you manage incus necrosis in the revision cases?
Revision cases, incus necrosis is very difficult. Basically, one cases I have done piston placement slide below laterally, and one cartilage place the monomer is there, no, the one cartilage, and place the over the incus to support it. Okay. So incus will be from incus piston will not slip away for that support system. So that is my master possible now.
Sir, in a situation where the incus long process is necrosed,
ওদিকে রেডি হন স্যার, আমি মানে ই করে নড়িচড়ি দিয়ে জানো।
hello, Hello.
Hello.
Hello, Tushar.
Hello, sir.
If the incus is necrosed, in
Yes,
that
sir.
situation, we can consider for a malleus prosthesis.
Sir, malleus also malleus stability I have done also.
Yeah.
Basically difficult malleus movement and medialation done. But I am not sure the long length piston I placed. But sometimes hearing capability I think is very doubtable. So best is the you just place the piston more laterally. Tip of the incus necrosed. Basically, just put the more laterally and also place the
more laterally or appropriately more superiorly?
More superiorly. Yes. And also place the quadrantempany nerve and also support with the cartilage to prevent further displacement.
But Tushar,
yes, sir.
In that case, there is more chance of slippage of the piston.
Hello.
In that case, there is a more chance of slippage of the piston because this necrosed long process of the incus is slightly thinner and pointed.
That is difficult. Basically, I have also asked the Mines. Basically, bone cement is there. So I have no bone cement. So in that case, I have placed in my AY friends forum. The lot of doubt, lot of debates. Was there with Mohan. There is a chance of against. I don't know. Basically, patient is happy still. Patients came from basically Gujarat.
So you have not used this titanium articulated prosthesis?
No. I am only using this Teflon material basically.
Okay. And what company, what brand of?
Grace piston.
Oh, you are using Grace. Okay.
So Amit Chaudhary previously supply, now another fellow is supplying.
And what is the diameter you prefer?
Normally 0.5 diameter I am using. Normally.
Okay.
Basically and 0.7, 0.5, 0.6, 0.7.
Okay.
Diameter of the perforator. Okay. So 0.5, 0.6, 0.7, and I prefer the 0.2 millimeter more diameter because I have seen the 0.1 millimeter if increase the diameter, slight bit of fixity. But if you come with if you gap 2 millimeter, 0.2 millimeter, then more free. Here no, more free basically.
Then do you use oval window seal?
Basically, I am not using because in my 2500 case, I have 1-2 cases I have seal only because the foot plate fracture. In that cases nowadays with Skeeter no foot plate fracture. Previously, when I used the crurotomy, then foot plate fracture was seen. I presented also, but here no small gap, blood clot. If you see, just after 2 minutes, the blood clot will be there.
Okay.
So that blood clot acts as a seal basically.
Natural seal
basically, not required anyway.
Okay. But in this case, really I appreciated your approach.
Yeah. Basically, you should encourage my courage.
No, it's not. No.
Courage.
Actually,
this is a difficult case.
Actually, frankly speaking, in this particular case, I was not worried about the facial nerve at all. But what this very small space on which you worked, just increase the space by doing a posterior crurotomy, and then do the foot plate work and the piston fitting, and then remove the and then completing the stapedectomy removal of the superstructure. That was very appreciable. That is very nice, because basically I believe what Utpal was also asking me, that preserving the stapedius tendon really does not do any good purpose, because even that had been now proven that the arterial supply of the long process of the incus and the lenticular process is more from above, not through the stapedius tendon. I mean the arteries of the stapedius tendon, a branch of the posterior auricular artery there. It is more from the above. So really it does not add much. Number one. Number two, normally what happens when with the loud sound, when the stapedius contracts, it actually hinges the posterior pole of the foot plate, as I can say now, onto the posterior border of the oval window and fixes the stapes. And that way it actually protects the oval window from the very high loud sounds. But when you are just by removing the saphenous footplate or removing the crura from the oval window and replacing it with a piston, really such mechanism does not operate. So even protecting the inner ear from loud sounds is also biophysically is not very explainable. But what is the most important thing is that due to the presence of this stapedius tendon, the chances of slippage of the mechanical slippage of the piston is one advantage. But what I think that by this reverse technique of you go fish, the main advantage is working on a very stable footplate up to your placement of the piston. That prevents damage, mechanical damage of the inner ear, and that is I think the most important advantage of this reverse technique. And really I appreciate how you do it in this case, where the space was so minimum. Because frankly speaking, in this case, if I had to do, I would have done the conventional technique, though I usually do a reverse technique. Thank you, Tushar. Tushar Swarani mone kichu.
Hello, Hodi. Oh. ডিনারটা খেয়ে যাও তো আজকে পুরো ইয়ে ঠিক আছে হ্যাঁ তুমি একটু
Hello. This was the last case. Hello, this was the last case demonstrated already by me, Stepis, and also Holdipur, and previously also BKRC. So thanks BKRC sir and Deepak Holdipur for coming here to do the case, and thanks audience, and thanks Sipla for giving me this opportunity and organizing this such a fantastic organization, fantastic arrangement. We are happy basically. I'm so happy today giving and doing this type of big workshop and giving this type of case. Okay, so definitely in workshop we have kept basically 20 cases, but not possible to demonstrate 20 cases. Still 1 or 2 cases pending. We will do leftover case tomorrow. But
hello,
today,
hello, Odi.
Today not.
Hello. Hello, Tushar.
Okay, hello.
I am very sorry that due to some unavailable reasons I have come late. But
Yes.
I have enjoyed all the things in YouTube. So
Oh,
thanks also for from the 9:30. Actually, you have started 9:35. I have noticed that, not in 9 a.m. Okay.
Yes.
So from that beginning, after your stepirectomy, I have all seen in the cases of in the YouTube.
Oh, thank
And
you
it is
so
so fine. Only one thing, not for this workshop. This workshop is very good. I appreciate you very much from the very beginning. But you have also done this in YouTube. So so much students have seen these workshops. Not only from here, from all India.
Yes, yes.
Yes.
Yes, yes. Thank you
So
so much.
I think this is a very good opportunity for us to learn also.
Yeah.
And so many Stepis cases, different techniques.
Yes, yes. So I'm coming to the auditorium. Okay. For YouTube, I think live demonstration now. It finished. Okay. Thank you, YouTube.
No, thank you to all because
thanks
of
to
your
all.
these workshops and training to all the juniors.
Yes.
ঠিক আছে? I always told that you are not my direct student.
Yes.
I know you from the very beginning in the National Medical College.
Yes.
I am in the one unit and you are in the other unit.
Yes.
So very few cases you have take the help of me, but still you think that I am your guru.
Basically, I have learned some surgery. Otherwise, no. Sometimes difficult. Initial practice. If no mentor will be there in support, so difficult.
Now this is also to be learned from you, because nowadays students usually forgot their teacher after learning. Oh, sir.
Okay, esophagus also, bronchoscopy now I'm not doing nowadays, but esophagus also I learned from you basically. And also definitely
No, but see, at the end of the day,
definitely
the OT list, the number of cases you had collected and the number of instruments you got, so it's amazing. You ask for any instrument, it is there. I thoroughly enjoyed operating today in your place.
Yeah, thank you.
In fact, he had called me day before yesterday. He told me what all cases you want to do. I told him I'm gone beyond that stage where I want to do anything. You do what all you want to, and what all you want me to do, I will do. I told him very clearly, I've shown enough and more. It is your time. And today he demonstrated very well. I enjoy doing the laser stapes.
Yeah.
Because I have the laser in Bangalore and I use that.
You install laser basically, you open. Basically, I am not done, no, still. I'll do after 2 to 3 days after, I'll start. Basically,
And again, like Coblator, once you get addicted to laser, then you will start using it more and more.
Yes, yes.
But all in all, for the sheer number of cases, the way you demonstrated, the instrumentation, the entire setup, and of course, the biggest inspiration is Dr. Barin Roy Chaudhary.
Yes.
At 88, if he's like this, at 61, I feel very young. 27 years to go, for me at least. Yeah.
Sir, I'm coming to the auditorium, sir, within
Yeah.
1 minute, okay?